Yes, sir.
Are we live?
We are live, sir.
Okay. Good morning, everyone. Welcome to the day 2 of our 26th annual conference of Society of Nuclear Medicine India. To start the session, we'll have the Professor Arkat Gajaraj Best Paper Award. So we have 7 presentations out of the 30 abstracts that were submitted. The top 7 were selected, and the top 7 have been included for oral presentation. The top the presentation will be awarded with the Professor Arkat Gajaraj Best Paper Award. To take over the proceedings, we have 3 senior nuclear medicine physicians. Dr. K. Kumaresan sir from Hyderabad. He needs no introduction. Dr. Madhu Srivastava, who is the associate professor at NIMS Hyderabad, and Dr. Sunil, who is from Narayana Hridayalaya, Bangalore. Now I request the chairpersons to take over the session.
Good morning, everybody. Good morning, Harishankar and Sunil and Madhur. So let us start the Professor Arkat Gajaraj Best Paper session. We are having 7 papers. I think at the end of the session, there will be a Dr. Riju will be introducing about Dr. Gajaraj. So Dr. Sunil, can you please call upon the first presenter? So for the information that your presentation should be within 8 minutes, preferably 7 minutes, but 8 minutes is better because 2 minutes for discussions, because we will be scoring the presentation based on the clinical relevance, the content of the paper, and the quality of slide and the way presentation and the questions are handled. So this will be scored by 3 different people. And that's how we will decide who is going to win the award. Sunil, please, over to you.
Good morning, everybody. I call out first speaker, Dr. Major Bushra Asima, to make a presentation.
Your audio is muted. I think we are not getting the audio.
Uday, are the presentations recorded or they are going live?
Recorded.
We are not getting the audio, Uday.
Can we play the,
Yeah, play from the beginning, yeah.
Good morning to all. Myself, I am Dr. Asima. I'm working as a nuclear medicine specialist in the armed forces. And for my paper presentation, I have a topic that is a role of HSSG, hysterosalpingoscintigraphy, as a tool of tubal patency in infertility workup. So, if we take what's the role of HSSG, how it comes. So I'll be basically covering an important thing, that is introduction, aim, purpose, materials and methods, results and conclusion. Now, why this study? This is because HSSG, if we speak, it is still in nascent stages in India. What we do by this study is basically we're assessing the functional tubal obstruction. So if you come to the definition, WHO defines infertility as a disease of the reproductive system, which is defined by the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. So infertility is a very critical component of reproductive health. So it is basically affecting both men and women, and it is affecting the personal, interpersonal, all aspects of life. So if we take the factors, we have both male causes and female causes. Now we concentrate on the female causes. So if we take the female infertility causes, yes, they are uterine causes, cervical causes, I have shown in the diagram here. But the most important is the tubal factor. Now these tubal factors, they constitute 40%. So the aim of the study was to assess the role of hysterosalpingoscintigraphy as a tubal patency test and compare it with the routine HSG, which is done in infertile women. And the objective is to determine the tubal patency with hysterosalpingoscintigraphy and compare these results with routine HSG. So if we take the assessment of fallopian tubes, we do have various methods like laparoscopy, chromoperturbation, and with recent newer techniques like hysteroscopy, phalloscopy, sonosalpingography. But this technique is more interesting because we are imaging the radioactive tracer from the cervix to peritoneal cavity. So we are basically now this movement of tracer, this action is similar to the migration of sperms through the tubes. So if we take the conventional HSG, that is more of an anatomical study, but HSG is more of a physiological study. So we are not injecting any contrast agent under pressure. So that's the basic difference. So if we take the study design, so this was a cross-sectional study, which I did in my department, the Army Hospital Research and Referral, Delhi CAT, and the study duration was for 2 years, from 2017 to 2019. And basically, there were three, it was interdepartmental. I had tied up with the Department of Radiology, where I conducted HSG, and the Department of the ART, Assisted Reproductive Technology, from where these infertile patients were being referred to my department. So the total sample size was 50. Now, the important inclusion criteria were the all females who were undergoing infertility workup, and exclusion criteria like any past history of pelvic inflammatory disease, who were not willing to give the informed consent, and who had any claustrophobia or any difficulty in lying down on the gamma camera. So this study was done in the proliferative phase of menstrual cycle between day 6 and day 12. And both procedures were carried out only after ruling out the pregnancy. And procedures were explained well to the patient, and also informed consent was also taken. So how did I do HSG first? This was done in the radiology department. Patient was given a pre-medication, any muscle relaxant to decrease the uterine spasm. And then after lying down in lithotomy position, after checking the internal os with the uterine sound, we use this Leach-Wilkinson cannula into the cervical canal, and we instill the dye under pressure. And then serial images were taken just to see the movement of the dye and how the dye is moving into the abdominal cavity. So these are the basic instrumentation which we can see, the SIM speculum and the Leach-Wilkinson cannula. So these instruments we used, instrumentation we used. So if we take, these were the images, and the left first images is a normal HSG image, where we can see the after the contrast being injected, we can see the dye going in the peritoneal cavity. On the other right hand side, that's a image of a blocked fallopian tube on both the sides, where we did not see the contrast spill into the peritoneal cavity. So now this study in a department, we did using SPECT-CT Symbia T6 gamma camera. HSG procedure, what we do? First of all, we explained the patient the procedure well. We took the informed written consent. The patient was asked to empty the bladder before us starting the study, and the local parts are clean prior to the administration of radioactivity. Now, I administered 1 mc of technetium nitrate sulfur colloid in 0.5 ml volume. This was instilled in the cervix. Now, the most important is the thing that this radioactivity was just placed inside the endocervical canal, and care was taken that it is not being mechanically pushed the colloid inside the uterine cavity. Then dynamic images were acquired for 10 minutes after instilling the radioactivity, and then we took static images 5 minutes. Now, for the static images, we took at 15 minutes, 30 minutes, and 1 hour. Now, we took more scans depending on whether the spill was seen or not. So this it kept on doing till 1 hour. And the images were acquired in 256 matrix and using a dual detector. So this is how a normal HSG study looks like. So we can see this, see the focus of intense tracer activity which is seen outside the uterus. So this is a normal study. Then there's a functional obstruction of the left fallopian tube, where we cannot, we can see the radioactivity only visualizing the right fallopian tube. This is a bilateral tubal obstruction. Now here the tracer does not flow beyond the uterine cavity. So this is called the characteristic corner cutoff sign. So this was given as a bilateral tubal obstruction on HSG. And instantly, one interesting study was even which was the arcuate uterus. So which showed the functional obstruction of the right fallopian tube. So results, if we take, we saw that most of the patients were between the age group of 26 to 30 years. And we did a universal pain assessment tool by using the pain scale. And interestingly, found that the patients who had done HSG, they compared of a higher pain scale compared to HSG with the pain scale where patient complained of lower pain. Next, if we take compare the results of tubal patency, so individual left and right fallopian tubes were analyzed separately. So 15 subjects were identified as having blocked left fallopian tube, by HSG, and out of them 12 were identified correctly by HSG. And right fallopian tube, 16 subjects were identified as having blocked right fallopian tube, and 11 were identified correctly by HSG. And the chi-square test results showed that there was an association with the two tests to be statistically significant. So HSG showed a sensitivity of 80% and 68.75% in left and right fallopian tube, and a specificity of 82.86 and 82.35% in the left and right fallopian tube separately. So accuracy we found out to be 82% and 78% when it comes to the detecting the patency of fallopian tube. So now the conclusion is that the study had basically objectives to determine the tubal patency with HSG and compare the results with conventional HSG, and also at the same time to compare the pain scale between both the procedures. The major disadvantage of HSG is that we are using contrast medium, we are instilling the dye under pressure. So it is basically having some discomfort to the patients and complication during the procedure. So HSG has significant advantages because we are evaluating the physiological fallopian tube patency, and we are even avoiding the complications use of contrast media. So appreciation of the functional status, so it more provides information about the therapeutic modality for the treating gynecologist. Now, this since it was tied with ART, I had spoken with the concerned treating infertility specialist. So they, the best part was that those patients where there was no evidence of any physiological obstruction on HSG, so the treatment modality they preferred was a intrauterine insemination. But in cases where there was bilateral functional obstruction, the treating physician preferred to go for IVF, that is the embryo transfer, instead of IUI. So this is how this modality can help the treating physician. So now the only thing is that further studies with a higher sample is recommended. So if if found accurate, then HSG alone could be used as a diagnostic tool in the workup of infertility cases, because the radiation exposure is similar to what it is done in a conventional HSG. So it was a nice study, and I thank you everyone for the patient listening. Thank you so much.
Dr. Ashima is online.
Yes, sir.
Okay.
Is she here? Yeah,
Sir.
Yeah, good morning. Okay, Dr. Asima, you hail from where?
I'm from Hyderabad, sir.
Oh, okay. And you are right now based in RR Hospital, Delhi?
Yes, sir. Yes, I'm presently posted there, sir. Yes, sir.
Okay. Did you see in the literature any work done in this country before? In the same area?
So, yes, sir. One study was done in Manipal, sir. Hello, sir. I'm audible, sir? Sir?
Yes, ma'am.
We can hear you, please.
Yes. Yes. Sir, I'm saying that, yes, sir. One study was done in Manipal, sir. Similar studies they had done, sir. So it was done. And other countries also, sir, many studies have done, sir, using different tracers, sir. Like most of them using this macro aggregated albumin, and even using different techniques also, sir. And with
you didn't know the study done from Hyderabad, and she got a Padma Shri, that gynecologist, and then it was a best paper awarded in nuclear medicine conference in Chandigarh.
Okay, sir. I'm not aware. Actually, I'm not aware.
It is published also. It is published. Okay, in
sir.
IGN. Okay, right. So what's the gold standard for your study?
So I had taken the gold standard at the HSG, sir, but actually gold standard should be this laparoscopic, this chromoperturbation, sir. Because laparoscopic procedures, it has have more that visualization of anatomy, sir. Laparoscopic one, most of the literatures, they consider that as the gold standard. But since practically it was not possible, sir, I took HSG as the gold standard.
I would say the gold standard is follow up and see the consumption, whether consumption related to the site, whether in those people you predicted is functionally patterned, right?
Yes, sir. Yes, sir. Follow up the patient, right, sir.
Okay. Anybody else? Any more questions?
Nothing from my side.
Dr. Ashima,
Yes, sir.
you talked about that radiation exposure, that it is much less as compared to what is there in HSG.
Yes, sir.
Okay.
Yes, sir. So in the HSG, sir, radiation exposure, sir, it is coming out to be 1.2 millisievert, sir. And for the past literature, means what of the studies have been done in various countries, they are saying that it is almost 1/9 of the one which is being done in conventional HSG, sir. But most of the studies, sir, they do report it is to be 1.2 millisieverts, sir, the radiation exposure, sir.
This is of HHSG or HSG?
HSG, sir. Like it is similar, so, but comparatively, like, sir, two studies were there. So one study says it is more or less around 1.2 millisievert. Other studies say it is comparatively less compared to HSG, sir.
You have not done SPECT CT in any of these cases?
No, SPECT had not in any of the cases, sir.
Because you know that in some patients that spill will happen posterior to the uterus, which is masked by the uterine activity. You may not be able to appreciate the spill.
Yes, sir. Yes, so since it was the first study, sir, in the initial stages, I thought let's do with this one first, and later I'll
Can we use the sulfur colloid for this study?
Yes, so sulfur colloid can be used, sir.
This was done at Command Hospital, Bangalore, or R&R Hospital, Delhi? This
Sorry, sir. R&R Delhi, sir. Delhi, sir.
Any false positive in your study?
Sir, 3 were there, sir.
Pardon?
Only three patients were there, sir. The issue is only about the follow-up of these patients, sir. Because most of the patients, the 3 patients where I am having discrepancy, sir, like they get posting out and following up telephonically. So that was the only issue. I couldn't follow these patients, sir.
No, false positive. Not follow up.
So false positive. No, so false positive. 3 were there, sir. 3 patients, sir. There was a discrepancy of 3, sir. 3, sir.
Okay.
So.
Sir, you have to unmute.
Asima, I think we can move to the next presentation. Sunil.
Right, sir. Okay. Thank you, sir. Jain, sir.
Now I call upon Mr. Jaisurya D to make his presentation. Jaisurya D.
A gentle request to the people who are presenting, please go into a place where you have good internet connection, because you have to answer the questions from the judges.
Hi, hello, I'm M. Manoj in Jaisurya, studying BSc Nuclear Medicine Technology, 3rd year in KMCH Institute of Allied Health Science. Here we're going to discuss the topic about stability analysis of lutetium-177 based radiopharmaceuticals. Introduction. Lutetium-177 is a beta-emitting radionuclide with an half-life of 6.65 days and beta energy around 497 keV, 384 keV and 176 keV. It is an excellent radionuclide for targeted radionuclide therapy. Radio-labeled PSMA, prostate-specific membrane antigen, is a therapeutic agent used in the treatment of prostate cancer. Radio-labeled dotatate is a therapeutic agent used in the treatment of neuroendocrine cancers. Objective. The objective of this study was to determine the stability of lutetium-177 tagged radiopharmaceuticals. The radiochemical purity of lutetium-177 radiopharmaceuticals PSMA and dotatate was used to represent its stability. The same was determined for the sample stored at room temperature and freezer. Materials required: ITLC SG paper, Eppendorf vials, samples of lutetium-177 PSMA and lutetium-177 dotatate, and acetylonitrile and HPLC water. Methods: 150 millicurie to 200 millicurie of each lutetium-177 radiopharmaceutical were ordered for treatment of patients specified radionuclide therapy. Around 100 microliters were pipetted to 10 Eppendorf vials and each having 10 microliters. 5 Eppendorf vials were stored in the room temperature and rest in the refrigerator at 0 degrees Celsius. Radiochemical purity was analyzed with freshly prepared solvent of acetonitrile and HPLC water in 1:1 ratio. Procedure. The ITLC SG paper was cut into 10 into 0.8 cm and marked 1 cm away from both ends as the origin and solvent trend. An aliquot of lutetium-177 PSMA and lutetium-177 dotatate samples was dropped at the origin. A chromatogram was developed. The strip was dried cut into point of spot and solvent print and counted. Radiochemical purity analysis was performed in 24 hours interval consecutively for 5 days. Result: the stability of lutetium-177 radiopharmaceutical was studied for 5 consecutive days from the date of receipt. Lutetium-177 PSMA and dotatate were stable for 5 days and radiochemical purity is above 95% for both of the samples. Here this tabular column is denoting that consecutively for 5 days in hours, lutetium-177 PSMA and dotatate were kept in the cold temperature and room temperature. The percentage was in the range of 99% to 96%. The graph of lutetium-177 PSMA, the blue line indicates the lutetium-177 PSMA in cold temperature and the red line denotes the lutetium-177 PSMA in room temperature. The graph of lutetium-177 dotatate, the blue line indicates the lutetium-177 dotatate in the freeze temperature and the red line indicates the lutetium-177 dotatate in room temperature. Conclusion: the study concluded on the positive side, emphasizing the stability of lutetium-177 PSMA and dotatate samples were stable even after 5 days of recipient. Even if there is any logistical delay in the patient arrival to the department or medicine arrival to the department, the stability of lutetium PSMA and dotatate were stable so that the patient can undergo for the therapeutic purpose. Thank you.
Do you have any clinical images of the scans done after giving treatment to the patients with these doses?
No, sir, we have no images, sir. We have done this experimentally only, sir.
But what is your recommendation to use it? You have seen that it is there, but within how many days you should use it actually, optimally?
Sir, optimally, we should use the day of consignment, sir. In case any logistical delay, if the patient arrival or the radiopharmaceutical arrival, sir, we can wait up to 5 days, sir. It is stable up to 5 days.
What is the shelf life that has been told by the manufacturer for these radioisotopes?
Sir, within 24 hours, sir.
So they say that you have to use it within 24 hours.
Yeah, sir.
Correct or wrong?
Sir, within 24 hours.
You have seen or?
I have seen, sir.
Okay, you have taken that 10 samples in Eppendorf vials.
Yeah, sir.
And 5 you have stored at 0 degree in refrigerator.
Yeah, sir.
Okay, which part of the refrigerator did you store that it is 0 degree?
Sir, in freezer, sir.
In freezer?
Yeah, sir.
But in freezer it is minus 20 degrees.
It is freezer, sir.
The temperature of the freezer is minus 20 degrees.
Yeah, sir.
Practically, if you see, there is no place where 0 degrees there in refrigerator.
Okay, sir.
Okay. Anything else?
Just on the defense of Jayashurya, the routine refrigerator that you have, the freezer compartment is around 2 degrees that we have for our NABH. The minus 20 degree that you say is for deep freezer.
Deep freezer.
The routine freezer compartment is around 2 degrees.
Okay, sir.
Good work, Jayasuriya. Thank you.
Okay. We'll go to the next speaker. I will invite Mr. Harish Goel. Harish Goel to make his presentation.
Topic of my presentation is evaluation of diagnostic performance of 18F FDG PET-CT in comparison to conventional imaging modality in Ewing sarcoma. Ewing sarcoma, a rare tumor of neuroectodermal origin arising from bone or soft tissue, most commonly metastasized to lung, other bones, soft tissue, bone marrow. Conventional staging, primary MRI and CT, and for metastatic evaluation, HRCT bone scintigraphy, and bilateral bone marrow biopsy. Metastatic disease at the time of presentation is a strong predictor of outcome. Localized disease is having event-free survival approximately 75%. Our objective of our study is to evaluate the incremental value of 18F FDG PET-CT with Ewing sarcoma over the conventional imaging techniques for baseline staging. Coming to the methods, records of 64 patients diagnosed with Ewing sarcoma who had underwent 18F FDG PET-CT were retrospectively reviewed, and out of these, 21 patients were included as per our inclusion criteria. 21 patients having an age ranging from 4 to 24 years, histopathological proven Ewing sarcoma, subjected to a total 36 imaging studies prior to 18F FDG PET-CT. Total 17 out of 21 patients Ewing sarcoma with skeletal origin, and 4 out of 21 is extraosseous Ewing sarcoma. 18F FDG PET-CT accurate for localization of primary sites in all patients. CT was false negative in 1 patient and MRI false negative in identification of primary site in 2 patients. CT was reported as a normal in 1 patient, which was accurately detected by MRI and 18F FDG PET-CT. MRI mislabeled primary lesion in 2 patients as chronic osteomyelitis. 18F FDG PET-CT showed the concordance with CT and MRI in primary disease localization. 18F FDG PET-CT detected additional lesion in 12 out of 21 patients, including lung nodules, soft tissue deposits, nodal disease, brain, skeletal, and bone marrow lesions. Clinical follow-up further imaging with MRI, HRCT chest, histopathologically of the additional lesion detected on PET-CT confirmed metastatic disease in 10 out of 12 patients, while the findings were false positive in 2 out of 12 patients. Overall, 18F FDG PET-CT could show presence of metastatic disease in 10 out of 12 patients, that is 83.34%. Coming to the case scenario, this is the first case. We can see the scarogram showing a fracture site in mid-femoral region, left side. Coming to the MRI image, it's showing significant soft tissue component and the fracture site with the significant extension of soft tissue component intramedullary up into the left femur shaft. And this is MIP image showing significant FDG avid lesion is seen in mid-femoral region left side, with the FDG avid lesion is extending into the femoral shaft. On coronal and sagittal section, we can see the pathological fracture site along with the soft tissue component and FDG avid lesion, and intramedullary FDG avid lesion is also seen. So this is accurate localization of primary in concordance with MRI. This is another patient with the significant soft tissue component on MRI is seen in pelvic region, right pelvic region, and on normal X-ray picture is showing the soft tissue component in left leg region in relation to the tibia. On MIP image, we can see on FDG PET-CT, there is a significant FDG avid lesion is seen in right pelvic and right iliac fossa region. Additionally, 1 lesion is found in left leg region, and 1 popliteal lymph node is also identified. This is another case. It is extraosseous Ewing sarcoma. There is a significant soft tissue component with FDG avidity is seen in orbital region, extracornal extension with destruction of middle floor of orbit, and the extension of soft tissue is also seen beyond that orbital cavity. And this is another lesion is seen. This is another case scenario in which we can see there is significant extension of soft tissue. We can see on MRI in right tibial bone, and on bone scintigraphy we can see there is increased osteoblastic activity is seen in the corresponding primary site itself. No any other metastatic or additional osteoblastic focus is seen on bone scan. On FDG PET-CT MIP image, we can see the primary site very well localized, along with the 1 focus of increased FDG uptake is noted in left thoracic region. On axial fused image, we can see there is a soft tissue nodules with FDG avidity seen in left lung region. This is another case. We can see there is a cortical irregularity on X-ray of right femoral shaft. On MIP image, we can see there is a significant increase FDG uptake is noted in the right thigh region. That is primary site. Along with this contralateral side femur is also some medullary deposits is also seen. And additional finding in the thorax region, this is a rib lesion, and one left maxillary lesion is also seen, and the neural soft tissue deposits and is also identified in this patient. So coming to the discussion, prognosis depends on accurate initial staging at the diagnosis, conventional imaging modality, standard diagnostic test employed for the disease staging, but 18F-FDG PET-CT is an optional diagnostic modality in Ewing sarcoma. Advantage of whole body scanning and the combination of functional imaging, functional and anatomical imaging, so that 18F-FDG PET-CT has an incremental value over and above the conventional imaging techniques. Conclusion, 18F-FDG PET-CT perform better than conventional imaging in disease localization, primary and metastatic site. Accurate initial staging important for deciding the further management and the prognosis. 18F-FDG PET-CT can be included among the primary investigation modality for Ewing sarcoma wherever a high suspicion of metastatic disease is suspected. This is relevant references for my presentation, and this is topic of my presentation.
The study was done at JIPMER.
Yes, sir. Yes, sir. It's from JIPMER only.
Did you find any correlation between quantitative parameters like either SUV max or MTV with the presence of distant metastasis?
Sir, SUV max only we have compared, and that only we did for prognostication for baseline, sir. Total lesion glycolysis we have not calculated, sir.
The SUV max, did you find any correlation? Higher SUV max, did they have the higher chance of having distant mets?
Yes, sir. Actually, if it is more than 5, then it is having more probability of distance met, sir.
You said there your 2 cases had false positive. What were the reason for the false positive? What were those?
Yes, sir. Yes, sir. That is extremities, lower extremities lesion was that primary, and ipsilateral side inguinal lymph node was positive on FDG PET-CT, and consequently after that patient underwent histopathological examination for that inguinal lymph node that turned to be reactive only.
Did the additional sites detected in FDG PET-CT change the staging or the management?
Yes, sir. As I shown in the one picture that is already shown, one lung nodule was there, so its stage is already changed. So from staging 1 to it directly went to stage 3. So they will.
In how many percentage of cases that happens, changing of staging?
That actually subgroup analysis I have not put, sir. Sorry, sir.
Okay, thank you.
Okay, what is the role of MRI, exactly MRI in Ewing sarcoma?
Sir, Ewing sarcoma, that is soft tissue contrast is very good. So the primary localization is definitely MRI is better, and that bone marrow deposit is also it's properly delineated on MRI.
But there is one thing in which MRI scores over FDG PET-CT. And that is the reason for which they do basically MRI for Ewing sarcoma.
I'm not sure, sir.
Neurovascular one.
Okay, sir. Neurovascular invasions are correct.
Okay. So any case you have seen anywhere in which you could identify any neurovascular invasion?
No, sir.
Okay, sir.
Okay. Thank you.
Thank you.
Now I invite the next
Good day, sir.
speaker. The name is Jemima Nair. Jemima Nair.
Good morning. I am Dr. Jemima Nair, currently doing my second year PG in the Department of Nuclear Medicine from Christian Medical College, Vellore. My topic is on utility of technetium-99 metastable pyrophosphate scintigraphy in the diagnosis of cardiac amyloidosis, experience in a tertiary care center. Cardiac amyloidosis is mainly caused by deposition of amyloid fibril in the extracellular space of the heart. Nearly all cases of clinical cardiac amyloidosis, that is about 95% of them, are caused by transthyretin amyloidosis, denoted as ATTR, or light chain amyloidosis, that is AL amyloidosis. Scintigraphy with technetium pyrophosphate is a simple, non-invasive, and widely available method in the identification of patients with the ATTR subtype. This was a retrospective observational study done in our institute. The patients evaluated for cardiac amyloidosis with correlative investigations such as echo, cardiac MRI, and biopsy from 2018 to 2022 were included in the study. The procedure for the scan is as follows. Following IV administration of technetium pyrophosphate, imaging of the thoracic region is done. Planar images are obtained in the anterior view at 1 and 3 hours. SPECT images are acquired at 1 hour and a dose of about 740 megabecquerels is given. Coming to the interpretation of the scan, it is mainly based on two findings, that is the visual and the semi-quantitative findings. Firstly, when the myocardial uptake is visually present on the SPECT images, the heart by contralateral lung ratio of more than equal to 1.5 at 1 hour is classified as ATTR positive, and a ratio of less than 1.5 will be considered as ATTR negative. In semi-quantitative finding, a visual comparison to the bone, that is the rib uptake, is done at 3 hours. If it is greater than equal to 2 on the planar or SPECT images, it is classified as ATTR positive, and if the score is less than 2, it is considered as ATTR negative. The following table shows the grades and based on the uptake. That is, if it is grade 0, there is no uptake and there is normal rib uptake. If it is grade 1, the uptake is less than that of the rib, and grade 2 would be equal to that of the rib uptake, and grade 3 would be greater than that of the rib uptake. Coming to the results, a total of 18 patients were taken, out of which 13 were male and 5 were female. The mean age was 54.3 years with a standard deviation of 12.9. The most common clinical presentation was dyspnea on exertion, followed by palpitation and chest pain. The common comorbidities among these patients were hypertension and diabetes mellitus. Most of these patients came under the NYHA classification of class 2 or class 3. The echocardiography findings were mostly a thickened left ventricular wall and diastolic dysfunction. Coming to the discussion, a total of 18 patients had undergone the technetium pyrophosphate scan, out of which 6 were positive and negative, and 12 were negative on the scan. Among the 6 that were positive, 3 underwent cardiac MRI, and it was positive in all the 3, and 2 underwent biopsy, in which 1 was positive for amyloidosis and 1 was inconclusive. Among the 12 that were negative, cardiac MRI was done in 8 of them, out of which 6 were negative, 2 were positive, which were then diagnosed as AL amyloidosis, and 9 underwent biopsy, out of which 6 were negative and 3 were positive, which were also considered as AL amyloidosis. These are the figures of those patients who have undergone cardiac amyloidosis in our institute. The first one is that of a 49-year-old gentleman with ATTR amyloidosis. The scintigraphy is strongly suggestive of amyloidosis. So here we can see that the uptake in the heart is seen clearly here, and it is more than that of the rib uptake. So this will be considered as grade 3, and the heart to contralateral lung ratio was calculated to be 1.72, which is greater than 1.5. So it is considered as ATTR amyloidosis. In the figure 2 is that of a 57-year-old gentleman with AL amyloidosis in whom the scintigraphy was negative for amyloid. And as you can see that we cannot see any uptake on the heart. And this is considered as grade 0. And the heart to contralateral lung ratio is calculated to be 0.9. The third one is that of a 50-year-old gentleman who was later diagnosed with hypertrophic cardiomyopathy. The scintigraphy findings were negative for amyloidosis. It was grade 1 and the heart contralateral lung ratio was 1.18. Now, all the 6 patients in whom it was strongly suggestive of ATTR amyloidosis, they were managed with heart failure medications. The patients diagnosed with AL amyloidosis were 3 and they were managed with a combination of heart failure therapy and chemotherapy. 1 patient had died due to cardiogenic and septic shock, while the others are doing well and are on follow-up. So now, on scintigraphy findings, if it was strongly suggestive of ATTR amyloidosis and a cardiac MRI was positive or negative and a biopsy was also positive or negative, it was probably ATTR amyloidosis. And if the scintigraphy was negative and the cardiac MRI and biopsy were positive, it was probably AL amyloidosis. And if the scintigraphy finding was negative and the cardiac MRI is also negative, then a biopsy can be avoided. And it's usually a diagnosis of another heart condition apart from amyloidosis. So in conclusion, technetium pyrophosphate study is a useful non-invasive imaging modality to diagnose ATTR cardiac amyloidosis. A positive scintigraphy is a clinically relevant finding and it favors diagnosis of ATTR amyloidosis irrespective of the cardiac MRI or biopsy findings. A negative scintigraphy with a positive MRI or biopsy is more suggestive of AL amyloidosis. A patient in whom both scintigraphy and cardiac MRI are negative, endomyocardial biopsy, which is invasive, can be avoided. The limitations of this study was that the number was very small, that is only 18 patients were included, and not all the patients had undergone both cardiac MRI and or biopsy. Thank you.
Yes, sir, please go ahead. I have one question. You have chosen SPECT images to do the quantification heart to contralateral lung ratio. Can I know why? Because ASNC practice points has given that ratio based on the planar images itself. That's one question. And secondly, did you find any difference in the heart to contralateral lung ratio at 1 hour image and 3 hour image?
Okay. So we've done on the planar images itself, sir, the heart to contralateral chest ratio. It's
Your
not.
first slide said that you did the ratio on the SPECT images.
Oh, not all. No, we just, so I said that the SPECT images were taken at 1 hour, but not for all the cases we've done on the planar images itself, sir.
Then you need to change the slide. Okay.
Okay. Sorry.
Did you find any difference in the ratio at 1 hour and 3 hours?
Sir, I did not compare that for both the things, sir, so I cannot comment on that.
What was the most common symptoms which you find with which the patient presented to your department for which this amyloidosis was done?
So the most common presentation was dyspnea on exertion for most of the patients, followed by palpitations and then chest pain. But the most common thing was dyspnea.
Okay. Apart from amyloidosis, what other indication, clinical conditions can be there which can cause all these things?
As in hypertrophic cardiomyopathy, anything that is causing other causes for heart failure can present with dyspnea on exertion.
No, one of your conclusions says that those who are not ATTR amyloidosis.
Oh, AL amyloidosis can have, yes, AL amyloidosis.
Anyway, did you exclude the other diagnosis?
As in AL, sir? AL amyloidosis?
See, if the patient either it comes with a clinical diagnosis to you as amyloidosis, and
yes,
then you have done the scan,
yes,
and it is negative.
Yes.
Okay, so then you have attributed it to be AL amyloidosis.
Yes. Along with supportive along with supportive investigations like urine IFE needs to be done, serum IFE needs to be done, and basically the monoclonal workup for monoclonal proteins also, only with that supportive evidence we can say it is AL amyloidosis.
Okay. What was the renal function status in your study group? Are there patients included who are having elevated serum creatinine? Because your bone soft tissue ratio is going to be variable between these patients, right?
Yes, sir. Yes, sir.
Did you look at that?
I have not looked at that, sir. I'm sorry.
Even the third.
What is the source of your pyrophosphate? Your pyrophosphate is from whom? Is it in-house labeling or it is a vendor supplied?
It's
the third image which you have shown.
Yes, sir.
I felt there's like I could see the stomach there. Can the the labeling, reduced labeling, can it change the ratio?
The labeling of the
technetium pyrophosphate.
It's a retrospective study, we understand. But what was the source of the pyrophosphate? That makes it very important. I think it must be in-house labeling because CMC does a lot of in-house labeling. So it must be pyrophosphate must be in-house, I guess.
Yes, sir. But I have not seen it, sir. But it is done here, sir. I will look at it. Sorry.
No problem.
Okay. Thank you.
Thank you.
Thank you, sir.
Now I call upon the next speaker, Mr. Adhavan P.
Hello everyone, I am Adhavan. Today I am going to present on the topic of radioligand therapy with lutetium-177 PSMA in metastatic castration-resistant prostate cancer patient, a tertiary center experience. Introduction. Metastatic castration-resistant prostate cancer remains fatal despite recent advances. Prostate-specific membrane antigen is highly expressed in metastatic castration-resistant prostate cancer. Lutetium-177 is the diagnostic agent with a half-life of 6.65 days, which emit both beta and gamma energy. Lutetium-177 PSMA is a radioligand therapy that delivers beta particle radiation to PSMA expressing cells and the surrounding microenvironment. Objective. The aim of this study is to report our clinical experience in patients who are treated with lutetium-177 labeled PSMA therapy. Our primary objective was to look for evidence of treatment response and a disease progression in the term of serum prostate-specific antigen level and imaging evidence of treatment response through gallium PSMA PET-CT. The adverse event during treatment and in immediate post-treatment period and in long treatment follow-up were also recorded. Methods and patient selection. Total of 32 patients with MCRPC who are treated with lutetium-177 PSMA therapy from June 2020 to October 2021 were included. Eligibility criteria included previous treatment with abiraterone or enzalutamide, previous taxane-based chemotherapy or chemo ineligibility, and disease progression on PSMA PET-CT. Decision for lutetium-177 PSMA therapy was taken in multidisciplinary tumor board. The patient consent and necessary investigation were done before lutetium-177 PSMA administration. Lutetium-177 PSMA was given for once in 8 weeks with an activity of 7.4 gigabecquerel, that is 200 millicurie up to 4 cycles. Patient serum PSA levels were monitored at 1 monthly interval, bone marrow monitoring at a fortnightly interval, and imaging by PSMA PET-CT in 2 monthly interval. Results. Baseline patient characteristic. The following parameters are age, which ranges from minimum of 51 to maximum of 82 with the median of 68. Gleason score ranges from minimum of 7 to maximum of 10 with the median of 8. Gleason grade ranges from minimum of 1 to maximum of 5 with a median of 4. PSA level ranges from minimum of 6.4 to maximum of 1243 with a median of 7.4 mg per ml. ALP ranges from minimum of 52 to maximum of 3240 with a median of 127 unit per liter. Hemoglobin ranges from minimum of 8 to maximum of 15.1 with a median of 10.9 gram per deciliter. Treatment response. Treatment response was assessed by decline and increase in serum PSA level and imaging assessment done by PSMA PET-CT. PSA decline more than 50% was considered treatment response. PSA increase more than 25% was considered progression, and any other change was considered stable. Around 64% of patients with PSA more than 50% decline after the first cycle. Around 24% of the patient with PSA more than 25% increase after the first cycle. Around 12% of the patient with stable disease after the first cycle. Disease status after the fourth cycle of lutetium-177 PSMA therapy. At the end of the fourth cycle, 60%, that is 19 patients, demonstrated complete response documented from decline in serum PSA level and imaging evidence in PSMA PET-CT scan. Stable disease was seen in 5 patients. Disease progression was seen in 5 patients. 3 patients discontinued therapy. Out of 5 patients who had progressive disease, 3 opted for actinium-225 PSMA alpha therapy. 2 patients showed treatment response and 1 patient showed stable disease after 2 cycles of actinium therapy. The representative image of patient showing treatment response after 3 cycles of lutetium-177 PSMA therapy. The first images were acquired after the first cycle of lutetium therapy, and the second image were acquired after the second cycle of lutetium therapy, and the third image were acquired after the third therapy of lutetium therapy. The comparison between the first and second and third cycle of lutetium therapy. Patient follow-up and safety profile. Median progression-free survival was 13 months. The majority of patients who showed more than 50% decline after their first cycle continued to show good treatment response. The most common side effect reported in lecture, anemia, was not reported in our study. Severe grade xerostomia was not observed in any of the patients. Mild grade xerostomia was observed in 3 patients after the third cycle. The radioligand therapy with lutetium-177 PSMA showed a good response in more than half of the patient with late stage MCRPC without much toxicity. The presence of visceral metastasis and rising PSA after the first cycle were associated with worse treatment outcome. Conclusion. We analyzed the use of lutetium-177 based PSMA radioligand therapy in patients with MCRPC. We found that good treatment response could be achieved in majority of the patient. The majority of the patients showed good tolerance to therapy with no major side effect. We also observed that treatment outcome was worse in patients with organ metastasis and a rising PSA after the first cycle. Thank you. I would like to acknowledge the guidance and support provided by my department, especially to Dr. Kamaleshwaran sir and Dr. Ramkumar sir.
Was any other correlation done with the symptom score, like visual analog score for patient pains before and pain and other symptoms before and after the therapy?
Center is online or not?
Is there Adam?
Otherwise, please unmute yourself. You are muted.
Good morning, sir. Good morning.
Any quality of life or any pain score was compared before and after the therapy, apart from your PSA response?
No, sir.
Okay, other one, how do you explain that the incidence of anemia in your patients is not there compared to the literature? What is the explanation?
Sir, many of the lecture they are saying the major side effect was anemia, but in our study we only observed that a mild grade xerostomia was observed for only for the 3 patients.
How do you explain that? Is there any dosimetry values? Can you explain?
Sir, for what, sir?
Dosimetry values, do you have anything to explain?
Dosimetry for the specific organ you are asking, sir?
Yeah.
Sir, no, sir.
Did your patients have less extensive bone metastasis, marrow metastasis?
No, sir. We have around 10 patients, we have bone metastasis. So those who have visceral metastasis for around 5 patients, the treatment outcome was worse in the treatment.
The similar study was presented in SNM conference also.
Yes, sir. I'm the co-author for that abstract. Okay. So now I am presenting.
So is there any change in number, any change in result as compared to that study?
No, sir. The same study we have done.
Same study. Okay.
Okay, thank you.
Okay.
Thanks for the presentation. I'll call upon the next speaker, Dr. G. Surya Teja, to make his presentation.
Good morning, everyone. Today I'm going to present F18 FDG PET-CT profile of pulmonary and extrapulmonary tuberculosis SWIMS experience. Tuberculosis is one of the leading infectious causes of deaths worldwide, with approximately 1.5 million people dying from TB in 2020. Pulmonary TB is more common and affects almost 80% of cases, and approximately 23% of TB burden worldwide is clinically or radiologically inevident. F18 FDG PET-CT is a molecular imaging modality commonly used for evaluation of cancer patients. Similarly, in TB, due to increase of glucose transporters and glucose utility by macrophages and lymphocytes, increased metabolic activity is seen that can be assessed both qualitatively and quantitatively. By a PET-CT whole body survey, affected sites can be localized in these patients. In this retrospective study, we have evaluated F18 FDG PET-CT scans of TB patients who were referred to Department of Nuclear Medicine between 2012 to 2022 for assessment of the site and extent of the disease. Out of 79 patients, 33 were males and 46 were females with mean age of 40.7 and 41.4 years respectively. All PET-CT studies were retrieved from the database. Positive findings of metabolic and morphological abnormality were tabulated for each patient. 12 patients who were diagnosed to have pulmonary tuberculosis and 67 patients diagnosed with extrapulmonary tuberculosis were referred to our department. Among 12 patients with pulmonary tuberculosis, 5 showed miliary pattern, consolidation was seen in 4, fibrocavitatory nodules in 3, and soft tissue nodules were seen in 2 patients with mean SUV max of 5.76. 5 patients had concomitant extrapulmonary features where nodal, pleural, and bone involvement was detected. 67 patients with extrapulmonary tuberculosis had mean SUV max value of 7.23, where lymph nodal involvement was seen in 44, skeletal involvement in 41. 15 of them had abdominal TB and visceral organ involvement. 5 patients had CNS involvement. Skin and muscle deposits were seen in 3 and 4 patients respectively. Concomitant lung involvement was detected in 12 patients, that was not known before. 44 patients having lymphnodal involvement. Mediastinal lymphadenopathy was seen in 38 patients. Cervical lymphadenopathy was seen in 24 patients. Axillary in 13, abdominal in 8, and pelvic lymphadenopathy was seen in 7 patients. 11 patients had single lymph node stations involvement and multiple lymph node stations were involved in 33 patients. Among 41 patients having skeletal involvement, 52% had vertebrae involvement, pelvic bones, thoracic bones, and limbs were all involved with mean SUV max of 9.85. Among 26 patients with port spine, 24 of them had thoracolumbar vertebrae involvement, 5 had cervical, and 4 had sacral vertebrae involvement. Multiple vertebrae levels were affected in 9 patients, and associated soft tissue component was seen in 23 patients. Abdominal TB and visceral organ involvement was seen in 15 patients with mean SUV max of 6.01. Ileocecal junction thickening, peritoneal deposits were seen in 20% of patients. Liver deposits were also seen in 20% of patients. Adrenal deposits, splenic deposits, ascending colon thickening, pouch of Douglas involvement were all seen. Among 5 patients with CNS tuberculosis, multiple lesions were seen in 3 patients and solitary lesion was seen in 2 patients. Among 3 patients with cutaneous tuberculosis, erythema nodosum were over the shin of left tibia was seen in 1 patient and multiple subcutaneous nodules were seen in 2 patients. Among 4 patients with muscle deposits, psoas muscle was affected in 3 patients and gluteus muscle was affected in 1 patient. Out of these 79 patients, 48 were not initiated treatment and 31 were on treatment. No prior PET scans were available for comparison. Patients with pulmonary tuberculosis were referred for evaluation of any extrapulmonary sites involvement, where F18-FDG PET-CT was helpful. Among 67 patients with extrapulmonary tuberculosis, apart from assessing disease status, additional involved sites were detected. Single organ site involvement was seen in 29 patients and multiple organ sites were involved in 38 patients. Similar studies were performed earlier. Harikrant et al. In 2008 published a pictorial assay in tuberculosis involving various organ studies by F18-FDG PET-CT in a multicentric trial done by Bomanji J et al. Published in 2020. Features of 358 patients with extrapulmonary TB were evaluated by F18-FDG PET-CT. Our study findings have correlated well with the above mentioned studies. This is a case of pulmonary tuberculosis where image A is a maximum intensity projection image of F18-FDG PET-CT showing increased radiotracer concentration in lung parenchyma corresponding to metabolically active fibrocavitary lesion in right lung lower lobe with associated metabolically active bilateral miliary nodules from axial section images B and C. This is a case of disseminated tuberculosis where image A showing maximum intensity projection MIP image of F18-FDG PET-CT showing increased radiotracer concentration in lumbar vertebrae, bilateral pelvic bones, and mediastinal lymph nodes that corresponds to metabolically active lytic lesion with associated soft tissue component from axial section images B and C. And images D and E showing subcarinal and left hilar lymphadenopathy. Image A is a MIP image of F18-FDG PET-CT showing increased radiotracer concentration in abdominal region that corresponds to metabolically active peritoneal thickening from axial section images B and C. This is a case of cutaneous tuberculosis where image A is a MIP image of F18-FDG PET-CT showing increased radiotracer concentration in multiple areas over the trunk that corresponds to multiple active subcutaneous nodules from axial section images B and C. So F18-FDG PET-CT performed in these 79 patients helped in accurately assessing the involved pulmonary and extrapulmonary sites, thus elucidating disease extent and can guide in treatment response assessment. Majority of the extrapulmonary features were associated with lymph nodal and skeletal involvement. Abdominal TB and visceral organ involvement were seen with less frequent involvement of CNS and skin. I thank all the dignitaries for giving me this opportunity.
Did you have any subgroup in your samples, any multi-drug resistant types of tuberculosis and others? Was there any difference in SUV between the responding and non-responding groups?
That we have not evaluated, sir, because some people have completed their not yet completed. Majority of them have not yet completed their treatment duration, and some had empirically started treatment. So there, I mean, much difference was not found in majority of the patients. So we have not completely evaluated that.
Based on your study, can you make any recommendation for looking at clinical predictors? Which patient, when diagnosed with tuberculosis, you should look for other involvement by whole body PET CT? Because you can't, just because somebody is diagnosed as COX, you can't send everybody for a whole body PET CT. Agreed? Because this is just a study, right? I'm sure it will never be in any guidelines as a recommendation. Okay, but you have anything to suggest that this kind of patient should be having this? Because does it have any change in the prognostication or response to therapy?
Sir, some patients, if regarding pulmonary, if I talk about pulmonary tuberculosis, if the patient is not responding well enough, or a patient is complaining additional complaints only clinically, then they can go for PET CT. And regarding extrapulmonary tuberculosis, if the same things are regarding, if the patient is complaining clinically, the additional site involvement for if we talk about POTS pain, if it will be useful for response assessment, like at the end of the treatment we can see the compare with the previous PET CT, and then if we need we can prolong the duration of the treatment. Otherwise, if there are additional complaints like abdominal distension or ascites or any like headache for CNS involvement, to look for CNS involvement, we can go for PET CT, sir.
In your study, there were 20 out of 79 patients. 23 had pulmonary involvement.
Yes, sir. Yes.
12 basic pulmonary involvement, and in extrapulmonary,
11.
This is 11 had extrapulmonary involvement. So, like, what was the indication for those presentation to your department? Like, why were they sent for PET CT?
Sir, most of the extrapulmonary patients came for the site, to localize site and extent of the disease, sir. Pulmonary patients were very few, sir. Normally, many pulmonary patients, majority pulmonary TB will be affected, sir. But where the cases were very few, majority of them who could afford and who want to look for any.
For that, can you think of any reason why more of extrapulmonary had come to you?
Yes, sir. Maybe a referral bias because they want to look for assessment site and etc.
Any biopsy, anything was done to?
Yes, sir. I mean, some of them had, all of them are proven to be tuberculosis only, sir. Then only we have included in this study, sir. Some of them had like sputum assay and gene assay, and some of them had biopsy assay. Yes, sir.
Okay, one image you showed of subcarinal node.
Yes, sir.
Okay, so how do you differentiate that subcarinal node from azygous vein?
Azygous vein, continuity, sir. If we scroll through the CT section, it won't be continuous, and node won't be continuous, and vein will be continuing.
Did the detection of extrapulmonary sites prompt your pulmonologist to give prescribe ATT for longer duration? Did they follow that, or they stick to only standard 6?
We couldn't follow through, sir. We follow up the patients.
Okay.
Yeah.
Can I ask one question?
Yes, sir.
Permission?
Yes.
How many patients did you do response assessment?
Response assessment have not been done, sir. I mean, we have done for a few patients, like 20 patients came for response, but those are not included in the study, sir. Some
do you think there is a role for PET CT in tuberculosis first?
Yes.
Do you think there is a role?
Definitely, sir.
The role is more in diagnosis or in treatment response?
Diagnosis wise, it is not like gold standard thing, sir. Response assessment, it will be more of useful.
It is more useful in response assessment.
Okay, this is more like an observational study, like they are very curious to know in tuberculosis patients, what do they see in PET scan? That's all. Because there is, but it's a good collection of so many extrapulmonary tuberculosis patients. Only thing is, like, do you have any patient with isolated CNS tuberculosis, and how was the diagnosis confirmed?
Isolated CNS was seen in one patient, sir, and CSF analysis showed tuberculosis, and we seen a solitary tuberculoma, CNS tuberculoma, sir. That was done. Only one patient we have found.
Just my humble opinion is, information, good information is not always equal to good management. So any investigation you do, unless it gives you some actionable information, it is, I mean, it's better to not over investigate.
Well, I think you have to start somewhere, Hari. Only when you start like this, then you will know where to go, because they have the tool, they have the patient, and that's how the knowledge is generated. Yeah.
Agreed.
I mean, clinical relevance, that is one relevance, one part of it. That's what we are trying to see, whether patients and the students are able to think and analyze, I mean, this is the beginning. That's how we have to do it. That's the learning process. It's a good attempt. Great.
Okay.
Thanks for the presentation. I call upon the last speaker, Mr. Komal Bishnoi, to make his presentation.
Good morning, moderators. I'm Dr. Komal Bishnoi, resident at the Department of Nuclear Medicine in Bhubaneswar. I'm presenting the study on role of interim technetium per technique thyroid scan uptake in predicting the response of radioactive iodine therapy among patients with Graves' disease. The radioactive iodine ablation is considered a definitive treatment of hyperthyroidism with the target to achieve the hypothyroidism or euthyroidism. The dose of radioactive iodine can be decided empirically or through the uptake-based formula. Few patients achieve early response biochemically within 6 to 8 weeks, and others achieve it later by 6 to 8 months. The second dose of radioactive iodine may be required in some to achieve the desired result. A better modality for predicting the response outcome early after radioactive iodine therapy will be useful for deciding further management. The aims and objectives of our study was to evaluate the role of interim technetium per technique thyroid scan uptake between 6 to 8 weeks post radioactive iodine in predicting early response to radioactive iodine therapy among patients with Graves' disease, especially in those who remain biochemically hyperthyroid at this stage, and also comparing the correlation of the interim thyroid scan uptake at 6 to 8 weeks with the late biochemical response at 6 to 8 months. Correlation of the interim biochemical response at 6 to 8 weeks with the late biochemical response at 6 to 8 months. Comparing the correlation of the initial, that is pre-ablation thyroid scan uptake with the late biochemical response at 6 to 8 weeks. We included patients with Graves' disease who were treated with radioactive iodine empirically and who were biochemically hyperthyroid at 6 to 8 weeks after radioactive iodine therapy. So there were 30 out of total 70 patients who received the radioactive iodine therapy. Rest of the 40 patients were excluded as they became biochemically hypothyroid or euthyroid at 6 to 8 weeks. Thyroid scan uptake was calculated pre-radioactive iodine, which is abbreviated as thyroid uptake initially. The empirical dose was decided based upon the thyroid uptake, which if was less than or equal to 15%, we gave radioactive iodine therapy 10 mg, and if it was more than 15%, we gave radioactive iodine 15 mg, which was given orally. Post-radioactive iodine ablation, thyroid scan uptake at 6 to 8 weeks was calculated for those who were biochemically hyperthyroid at this stage, that is at 6 to 8 weeks. The cutoff for response on thyroid uptake at 6 to 8 weeks was taken as 4%. If the patient was showing the thyroid uptake as less than or equal to 4%, they were assumed to become hypothyroid or euthyroid eventually. And if it was more than 4%, they were assumed to remain hyperthyroid at 6 to 8 months. Pearson's correlation was calculated between the initial technetium per technique thyroid uptake scan, the thyroid uptake at 6 to 8 weeks, and the biochemical response at 6 to 8 weeks with the final biochemical response at 6 to 8 months. The sensitivity and specificity of thyroid uptake at 6 to 8 weeks to predict the end response was also calculated. The sample size was 30, which included 21 females and 9 males. The mean age was 46 to plus minus 8.5 years. We found a strong correlation between thyroid uptake at 6 to 8 weeks with the biochemical response, final biochemical response, and the correlation came out to be 0.82, whereas the correlation between thyroid uptake, initial thyroid uptake, and the final biochemical response was only 0.53, and 6 to 8 weeks biochemical response with the final biochemical response was found only 0.69. The sensitivity of thyroid uptake at 6 to 8 weeks in detecting the end response was found to be 100%, and the specificity was found to be 82.6%. Post-radioiodine ablation, the early biochemical parameters, which was taken within 2 months, may not be reliable to predict the late response, as some patients remain biochemically hyperthyroid during this period. Few of these eventually reach the euthyroid or hypothyroid stage in 6 to 8 months, and few remain toxic during this period and required reablation. Thyroid uptake scan at 6 to 8 weeks post radioactive iodine therapy in Graves' disease was a better predictor of long-term outcome than the biochemical parameter at this stage. Thyroid uptake at 6 to 8 weeks thus can impact the early decision making in such group. Here we present some cases, brief summary of some cases. There was a patient, 55 years old male with Graves' disease. His pre-therapy thyroid uptake scan, which showed the uptake of 14.2%. He received 10 millicurie of radioactive iodine orally. Post-therapy scan showed the thyroid uptake to be 10.4%. And biochemical parameters was also of those of hyperthyroidism. The TSH levels was 0.03 milli international unit per liter. The free T4 was 100 picomole per liter. He was put on nimacazole. He remained biochemically hyperthyroid at 6 to 8 months, requiring reablation. The other case was of 27 years old female with Graves' disease. The pre-therapy scan uptake was 14.9%, which is almost similar to the previous patient. She also received 10 millicurie of radioactive iodine orally. The post-therapy scan showed the uptake of 0.2%. The biochemical parameters of this patient was also of hyperthyroidism. The free T4 was only 4.9 nanogram per ml, which is not much higher than the normal range. She was followed up with symptomatic treatment only, and she became biochemically hypothyroid by 6 to 8 months, requiring thyroxine supplementation. Third case is of 50 years old male with Graves' disease. Pre-therapy scan showed the thyroid uptake 23.5%. As this uptake is higher than 15%, and he received the radioactive iodine as 15 millicurie orally. Post-therapy scan showed uptake of post-therapy. We did the scan at 6 to 8 weeks. The thyroid uptake scan showed the uptake of 0.2%. Biochemical parameters at 6 to 8 weeks were the TSH levels were 0.01 milli international unit per liter, and the free T4 was 1.8 nanogram per ml. He was followed up with symptomatic treatment, and he became biochemically hypothyroid by 6 to 8 months, requiring thyroxine supplementation. The fourth case is of 50 years old female with Graves' disease. The pre-therapy thyroid uptake scan showed uptake of 24%. She received the radioactive iodine 15 millicurie orally. Post radioactive iodine, the scan was done at 6 to 8 weeks and showed the uptake of 10.2%. The biochemical parameters showed TSH levels as low and free T4 high, which was 2.8 nanogram per ml. She was put on nimacazole. She remained biochemically hyperthyroid at 6 to 8 months, requiring reablation. So here we can see that the hypothyroid or hyperthyroid state of a patient at 6 to 8 weeks post therapy was independent of the dose of radioactive iodine received by the patient. So we can conclude it from the study that early thyroid scan uptake at 6 to 8 weeks post radioactive iodine in Graves' disease can be a reliable parameter in predicting the long-term outcome in patients who remain toxic biochemically at early 6 to 8 weeks. It can also impact early decision making in management, that is either wait and watch with symptomatic treatment or to start anti-thyroid drug or plan reablation. However, if we do further large-scale study, this can add to the evidence and to its utility for wider application. Thank you.
Good attempt, doctor. I have one question. Can you explain why, when the uptake is more than 15%, you are given 15 millicurie, when it is less than 15%, you are 10 millicurie? What is the justification for this kind of decision?
So, actually, we gave the dose empirically, as it's written in literature that we can give the dose either empirically or based upon the formula. So we decided to give the empirical dose to the patient, and also there were patients, different patients with different thyroid uptake. So we just gave a standard dose, either 10 millicurie or 15 millicurie.
No, your slide said that more than 15% uptake, you give higher dose, 15 millicurie.
Yes, sir.
It is little contradictory. When the uptake is high, you will expect to give lesser iodine, but you are giving higher the uptake, you are giving higher activity. Can you explain why?
Sir, actually, this is the uptake is based upon technetium per technique uptake, and the formula is based upon radioactive iodine uptake.
Okay, and then you were 2 weeks to 6 to 8 weeks first follow-up assessment.
Yes.
If you see all your patients, your TSH is suppressed.
Yes, sir.
But some of them became hypothyroid and some of them showed low free T4. How do you explain that?
Sorry, sir, I didn't get the question.
Your first follow-up workup at 6 to 8 weeks, all the patients invariably you are seeing suppressed TSH.
Yes, sir.
And then some of them show free T4 is low, some of them show free T4 is high.
Yes, sir.
So how do you explain that? I mean, there is something called a pituitary lag to respond. So TSH will remain suppressed in 6 to 8 weeks. That is not surprising. And if you notice free T4 is low, that patient became hypothyroid. Free T4 remained high, they remained hyper, requiring another dose. So, I mean, the point is, it's not possible to assess them by TSH. And then did you look at the clinical status, at least partial response or in their status in 6 to 8 weeks? Because partial response is there, then it may predict, you can wait and watch. Did you compare it with your technetium uptake?
No, sir, actually, we just took biochemical response of patient and we compared with thyroid uptake.
What about the size of the gland? In many of your patients, the gland looks very big. So what was the reduction in the size of the thyroid gland has any predictive value or not?
Actually, no, we didn't see that.
You didn't look at it. Okay, right. Anyhow, the idea is good that 6 to 8 weeks, when patients come and your biochemically, their reports are not very favorable. I mean, is there worth waiting and watch or something? I mean, you try to use technetium uptake for that purpose. Yeah, so the idea is good. Okay, good.
Dr. Komal, when did you join your course?
Sir, in last July, in July batch last year.
July. So she is one of the youngest persons to present in Professor Arkat Gajraj award paper. She is only 6 months into your course?
Yes, sir.
Yes.
Okay. Just one question. I'm not able to understand, like the inclusion criteria which you mentioned was 30 patients of Graves' disease treated with radioiodine empirically who were biochemically hyperthyroid at 6 to 8 weeks. And you have excluded all the patients who were biochemically hypo or euthyroid at 6 to 8 weeks.
Yes, sir.
Why this exclusion criteria is taken?
Sir, actually, these were post-radioactive iodine ablation patients, and we just took the patient who were biochemically hyperthyroid, and we just these patients can become hypothyroid, euthyroid, or hyperthyroid at 6 to 8 months. So we were comparing the thyroid scan with the biochemical response at 6 to 8 months. So we just took the patient who were biochemically hyperthyroid.
Okay. Do you feel that if the patient, one of the patient, I felt like it could have been AFTN, autonomously functioning thyroid nodule, instead of Graves' disease. So can the, whatever study is this, can there be a difference if the patient has AFTN instead of Graves' disease? At 6 to 8 weeks, if you do a scan?
Sir, at 6 to 8 weeks scan.
If the patient has AFTN instead of Graves' disease, and you do a thyroid scan at 6 to 8 weeks, do you feel there might be any difference as compared to if they have Graves' disease?
Yes, sir, there may be a difference, but I haven't seen that patient.
Okay.
They were all Graves' disease patients.
No, what happens is in AFTN, the normal gland is suppressed. So whatever radioiodine we give, it goes to that AFTN. Once that is you can say when it's treated, the other part of the gland takes over. So in that case, you might have a little higher radioiodine that your thyroid scan uptake at 6 to 8 weeks as compared to the normal Graves' disease. So that factor has to be taken into account. Like, anyways, good study.
No questions. Good study.
Just before we close, I want to that second presenter, Jaya Surya, in which by mistake I said that the refrigerator temperature minus 20 degrees. It is actually 0 degree, and deep freezer is minus 20 degrees. So I apologize for that.
Okay, sir.
Thank you, Chairperson. Thank you, judges. Now we have our President, Dr. Riju sir, who will be introducing Professor Arkat Gajaraj sir, on whose name this award is being bestowed. Over to you, Dr. Riju sir. Before I give to Dr. Riju, I'd like to congratulate all the presenters. We've got extremely high quality papers for today's award presentation. The tuberculosis paper was one of the highest numbers, and the last presenter was one of the youngest presenters. So I'd like to congratulate all of you. The quality of your presentations were absolutely, I mean, it has kept a new benchmark as of now. Over to Dr. Riju sir. Dr. Riju sir. I think he has gone offline.
Yes, sir. Sir is offline.
He was there until now. Yeah, he's back. Dr. Riju, can you take over?
Yes, sir. I am just sharing my screen.
Sir, scroll below and you have to join the.
Okay, and
that web page itself, you can scroll below, sir.
I just put this. My screen is sharing now. Able to see my screen?
Sir, we are only seeing your desktop with all the.
Seeing your desktop.
Yeah, one second.
Sir, you can close all the other things so that it will be easier for you to find out what to share.
Yeah. They laid us with the hospital. Yeah. Hope it is seeing now.
Yes, sir.
Yes, good morning, everybody. So we just completed this the most prestigious event of the conference, Southern Chapter, Society of Nuclear Medicine India, Professor Arcot Gajraj Best Paper Award. So then we all say is that the future lies on the younger generation. So then we have to identify the younger generation who is interested in the subject, interested in the specialty. We have to give them support, encouragement, and token of appreciation to go further. This is what this great gentleman does in his lifetime, Professor Arcot Gajraj. He was a unique person, a pioneer, and a doyen amongst the radiologists in our country. He was perhaps the only radiologist in the country at that point of time who was proficient in all branches and in the specialty of radiology. He born in 1925 and in Mandalay is a place that time it was a part of India, that is Burma. It is currently it is known as Myanmar. And he completed schooling in this St. Anthony's Boys School in Myanmar and returned to India in December 1941. And he completed his schooling, high schooling from Chennai. And he's joined in Madras Christian College. And first he has done his graduation in botany. And he stood as the first in the state in the subject of botany in graduation level. And subsequently, he is joined in Stanley Medical College. He's the 1947 batch of Stanley Medical College, and he was that time he was the general secretary of the college union. And subsequently, he joined. He took a diploma in radiology. The MT radiology is not available at that point of time. And subsequently, he did diploma in radiology and radiodiagnosis and radiotherapy. So he did both, both aspects of radiology. So he became the HOD of radiology in Stanley Medical College, where he has obtained his post-graduation. And finally, he became the director of Barnard Institute of Radiology and Cancer Center of Government General Hospital, Chennai. And he worked in the pathology department for a couple of years, interested in pathology because he felt, then to understand the disease in the microscopic level, that is the best way to learn the disease. So he joined in the pathology department, and he joined at MD General Medicine. Later on, in Madras Medical College, and he has awarded a Masalamani gold medal. So he is a gold medalist throughout in his academic career, and his interest was diverse from radiology to general medicine in pathology. So it's a multifaceted personality. So he worked as a senior registrar in the UK in 1967 to 68 in Getshut, and his service was extended as a visiting professor in the University of Pittsburgh, USA. And he has several firsts of his credit. He has introduced the percutaneous lumbar aortography, venous angiocardiography, brachytherapy for the treating cervix cancer with the radioactive cobalt. So many aspects. He was into radiology, he was into therapy, and he has started so many new things, which probably it just sounds very simple today, but that point of time, that was the only investigation or the path-breaking kind of procedure or investigation or the management modality available. So he was worked as a professor and director for Barnard Institute of Radiology and Oncology. So he is a great teacher and educationist, and as a role model for excellence, making us a golden decade of Barnard Institute of Radiology. So then he has done tremendous contributions in his tenure of 10 years in Barnard Institute of Cancer. He was a founder member of Indian College of Radiology Imaging. And so then Indian College of Radiology Imaging, you all know that it has become like the premium, the association of all the radiologists in the country, then with more than 10,000 members associated. And his contribution to the growth of the Indian College of Radiology is it is it is in the history, and it is in every radiological conference you attend. You will get you can never leave that without getting a mention about Professor Arcot Gajraj. He introduced the logo, the current logo of the Indian College of Radiology in 1988. He was a former chairman of college and president of Indian Radiological Imaging Association. So he was invited as a speaker. Invited as a speaker at several national and international forums, and delivered several endowment and memorial orations. He served as a visiting professor to several foreign universities. So then he was naturally, he was been naturally invitee so into various international forums representing India, and he has been honored by various universities and institutions around the globe.
Sir, do you have any issues?
It is just hanged. One second.
Sir, can you press Control Alt Delete?
Riju, can you just read out?
1 second, sir.
I'll stop.
Sir, sir has gone offline.
Yes, sir.
I think Dr. Gajraj sir's family member is here.
Yes, doctor. I'm Dr. Jayashree.
Dr. Can we ask her to give a few words before Dr. Riju joins back?
Maybe Dr. Riju would like to be there at that time.
I think he is having some trouble with his connection or the computer.
Maybe his laptop got stuck, sir.
Yes, I think he's in the process of restarting. Kumaresan, sir? Yeah, Dr. Riju has joined.
I think if Riju takes time, I think that JST can address the audience in the meantime.
Dr. Riju has joined. Dr. Riju, sir? Sir, you're able to hear me?
ரெச்சு சரியான கோமாளியா இருக்கான் பிரசிடென்ட். நேத்து அப்படித்தான் பண்ணான், இன்னைக்கு அப்படித்தான். ஒரு பவர் பாயிண்ட் ரெடியா வச்சுக்கிட்டு டக்குன்னு அதை 2 நிமிஷத்துல முடிக்க தெரியாம பல அது டெக்னிக்கலா அவனுக்கு ப்ராப்ளம் வருது எக்கச்சக்கம். அது என்னமோ எல்லாரும் வெயிட் பண்ணிட்டு இருக்காங்க. திரும்ப 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 அதே பண்றான்.
Yes, let me complete. I know then he is a founder member, as I just mentioned, in the College of Radiology, and he was invited speaker globally, and he has been well recognized by the global platform, by the various universities and institutions. And so he got several awards to his credit, such as a Distinguished Teacher Award, Lifetime Achievement Award, and Millennium Award. So then he was confirmed FRCR, FACR, and FAMS, and FI. So many international degrees has been conferred to him, considering his long stint and the contribution to the specialty. So he took a voluntary retirement from the government service in 1979 and joined Apollo Hospital, Chennai, and set up the Department of Imaging Sciences. And he also worked in Mallar Hospital and Rai Memorial Hospital Cancer Center. So he is pioneered in introduction of the interventional radiology, CT and MRI, and always felt the pathology and medicine training made him as a good radiologist. So that is an interesting area. That is pathology is imaging specialty is very much interlinked with this pathology. It is a great revelation, and it is very few people has done that kind of combination of obtaining this degree in both specialties. So he served as a president of Indian Radiological Imaging and SNMI India, and chairman of Indian College of. He became the chairman of Indian College of Radiology, and he was a passionate teacher, excellent clinician, loved and remembered by his students. And he passed away in March 2005. And so the why we are all here is because then he's the founder, president of Society of Nuclear Medicine Southern Chapter. So he envisaged this along with the Dr. Pumreshan and the team of the founder team of the Society of Nuclear Medicine Southern Chapter. So then he was endorsed as the president of Society of Nuclear Medicine Southern Chapter, the first founder president of Society of Nuclear Medicine Southern Chapter. He left us in March 2005, and he always inspires the younger generation to go into their specialty with scientific contributions. So that's the endorsement of what we are giving today to this the younger generation is based upon his vision and his support to the younger generation. So his family, he's a very close family man. His wife is late Mrs. Kausalya Gajraj, and she was a teacher. And then he left with us a great personality, that Dr. Jayashree Gajraj. She's a proficient gynecologist working in Apollo Cancer Center, Chennai, and associated with the MGM Healthcare. And she took over the great legacy of Professor Arcot Gajraj of contributing to or inspiring the younger generation in various clinical specialties. So then he has started up Arcot Gajraj Educational Trust, and we started with the various training program launched in 2005. And has done theme-based teaching programs every year, mainly to postgraduates and young radiologists. So then various endorsements are given not only to nuclear medicine, to the various other specialties, especially to the imaging specialties. So the Professor Arcot Gajraj Memorial Oration started in 2005, and it is
Dr. Riju, we are running already half an hour late. Can we just
continues today?
Yeah.
Great. And so we Dr. Esri and to give us another Arcot Gajraj and his message to the younger generation. Dr. Jayasri.
Thank you very much, Dr. Riju. I'm afraid that the connection may not be too good. I'm traveling. Just stopped on the highway to speak to all of you. I would like to thank the Nuclear Medicine Society of India, Dr. Prabhu, who initiated the conversation with me, and Dr. Riju, the current president, for instituting this wonderful best paper presentation and award. I'd just like to say that Dr. Gajraj, actually, as you mentioned earlier, trained at a time when radiodiagnosis, radiotherapy, nuclear medicine were all one. So one person had to be proficient in all. And I remember in my college days, he used to know everything about everything. It was not just like a jack of all trades. He was a master of all trades. He was always on the dot. He liked to read up to date, even till the very end, whether it is radiology or non-radiology or fiction. He had to read for half an hour to 1 hour every day in the evenings. That was his habit right through. And he was happiest when he was surrounded by students and younger colleagues, right from his days in teaching colleges into the Apollo Hospital. He always thought he had to teach. And I remember even in the last few days in his admission in Apollo Hospital, he was trying to pick up an MRI film and try to teach. This was something which amazed even the doctors who were there. And he always said, as you teach, so you learn. Similar to as you reap, so you reap. So he believed very much that when you teach, you had to learn. You had to read and then teach. So that was something he maintained almost till the very end. I was listening to this beautiful talks, the last two talks, and one was on tuberculosis. The presenter and the judges were emphasizing on the clinical aspect. This is something, again, he really, really believed in. He said, radiology is not a subject by itself. It's a clinical radiology which matters. So it was always a symbiosis. He said clinical medicine and radiology went together. So I was really very happy that the judges were emphasizing on the clinical aspects of the presentation. So we started this target, as we call it, the Professor Arcot Gajraj Educational and Training Program in 2005. Even today, we are continuing to do this as orations. And we call it a symbiosis of clinical medicine and radiology. So once again, I know that you are running late. I don't want to waste time, but I'm very, very happy that you have started this best paper presentation, and all the very best for all the youngsters who have taken part in this presentation and all the younger radiologists to come. Thank you very much.
Thank you, Dr. Jayasri, for this, for your inspiring words. And over to Dr. Harishankar for the further proceedings of the session.
Thank you, ma'am. Thank you, chairpersons and judges. All the students who presented in this Professor Arcot Gajraj Award are here. It would have been a wonderful experience for them to know the great man on whose name the award is being bestowed. So without wasting any further time, let us move to the next session. It's the interesting cases session. To chair the session, I invite Dr. Santosh. Dr. Prabhu, our president-elect, will be joining us very soon. And before we start, can we just have present this question? Dr. Sunita?
Yeah, good morning, one and all. Today I will be asking the quiz.
Ma'am, your audio is flaky.
Okay, just wait a minute. I'll just increase the volume. Is it good now?
Yes, ma'am. Please go ahead.
So the quiz today, it's a quiz number 11. So as you all know, you have to answer the quiz by pressing this button and select the options once I ask the question. So this is the pre-therapy scan, anterior, posterior, and the post-therapy scan. So please, so what are the findings? Option A, minimal remnant with bilateral lung metastasis. Option B, minimal remnant with bilateral hip metastasis. Option C, minimal remnant with bilateral breast uptake. Option D, minimal remnant bilateral metastasis. So just have a look. First two images are pre-therapy scan and the last two images are post-therapy scan. And the options are these four. So please select the button and select the option within 10 seconds. Okay, so we'll end up the quiz. So I hope you have answered by pressing this button. Dr. Santosh, please take.
Yes, ma'am. So for want of time, I'll just directly request the organizers to share the presentation of the first speaker, Dr. Ramkesh, to present his case report.
Good morning all. I am Dr. Ramkesh, Nuclear Medicine Junior Resident from Amrita Institute of Medical Sciences, Kochi. I thank Dr. Harshankar sir for giving me an opportunity to present this case in this platform. So going to the case, this is a case about a newborn baby of a 39-year-old mother of 38 weeks in gestation who was delivered in a local hospital by normal vaginal delivery. Soon after the birth, the baby presented with bluish discoloration of tongue, lips and skin, difficulty in breathing, poor activity and feeding. Then the patient was referred to a tertiary care center in Amrita. When the patient was brought here for further management in pediatric cardiology, the patient was found to have severe central cyanosis, tachypnea, tachycardia, skin was cold and clammy, minimal response to stimulation, and on auscultation there was only loud and single second heart sound. When this male baby was further investigated, his ABG analysis was showing metabolic acidosis and respiratory acidosis. ECG was normal. Chest X-ray showed significant cardiomegaly, classically described as Egon string. Echocardiogram revealed aberrant origins of aorta and pulmonary trunk, raising the possibility of transposition of great arteries. So what is transposition of great arteries? Just to recollect, it is a congenital pediatric cardiac defect arising from an embryological discordance between the aorta and pulmonary trunk. So here the aorta arises from the right ventricle and pulmonary trunk arises from the left ventricle, thus creating two parallel circuits incompatible with life. Incidence is about 1 in 3,500 to 5,000 live births. Etiology is often unknown and may be multifactorial. Dextrotransposition of great artery is the most common type and may coexist with the ventricular septal defect, left ventricular outflow tract, mitral and tricuspid valve deformity abnormalities, coronary artery variations. So the baby was initially medically managed with a prostaglandin E1 analog to keep the ductus arteriosus open so that at least the mixed blood can reach the body. The patient, 10 days after the birth, the patient underwent arterial switch operation. That is a cutting of the aorta and pulmonary artery and reconnecting them to proper ventricle and patent ductus arteriosus ligation. Since then, the patient was on optimized cardioprotective medication like aspirin, clopidogrel and carvedilol. Patient was asymptomatic post-surgery with good weight gain and normal development. Follow-up echocardiogram at 10 months showed severe LV dysfunction with a severe hypokinesia, akinesia of the inferior segment, while the posterior apical and septum showed dyskinesia with an ejection fraction of 33%. In order to find the cause, coronary angiogram was done, which showed severe RCA origin, that is the ostium stenosis, and also there was a decreased flow in the LCX territory. Left coronary artery flow was normal. Patient was referred for stress myocardial perfusion imaging to assess the amount and extent of myocardial ischemia and viability in the RCA and LCS territory to decide upon the further line of management. Pharmacological adenosine stress protocol was opted as the patient is so 140 microgram per kg per minute of adenosine was infused IV for 6 minutes. Injection of 3 millicurie of 99 technetium system EB was done at the 3rd minute. Delayed stress and rest gated images were required. So you can see the stress and rest studies of myocardial perfusion showing dilated left ventricular cavity. There is fixed perfusion defect involving the inferior myocardium, denoting the presence of large infarct with no viability. There is moderate to severe peri-infarct reversible ischemia involving the infralateral segments of LV myocardium. The 4DM SPECT confirmed the presence of a significant peri-infarct reversible ischemia. So the PTCA for RCA stenosis was attempted on 2013 but was unsuccessful. On 2016, the patient underwent a successful balloon dilatation of right coronary ostium, and the follow-up echocardiogram in 2016 showed an improvement in the ejection fraction from 33 to 50%. Further follow-up was performed with myocardial perfusion imaging in 2019 and 2022. In 2019, he was 6 years, and in 2022, he was 9 years. So, as he was able to walk, patient underwent a symptom-limited treadmill exercise. He performed the exercise well. He walked for 10 minutes and 15 seconds, achieved a good metabolic equivalence of 7.7. In 2022, also he did a good level of exercise with almost replicating what was done previously. Now we can see that the perfusion defect in the inferior wall, there with no improvement. On the other hand, the extent and severity of the reversible ischemia in the infralateral segment was improving. So when compared to the 2013, it has significantly improved in 2019 and further improvement in the 2022. Again shown here, you can see that the reversible ischemia has significantly come down, with the infarct being shown in the inferior segment. So there are some clinical situations where the myocardial perfusion imaging is significantly relevant, like Kawasaki disease, posterior repair of a tetralogy of Fallot, anomalous left coronary artery from a pulmonary artery, post-arterial operation, and many forms of cardiomyopathies and cardiac transplant. Overall, it is used to assess the severity of myocardial ischemia, viability, and to predict the cardiac events. The prevalence of coronary events following arterial switch operation varies from 2 to 11%. Myocardial ischemia following arterial switch operation is usually due to the proximal narrowing of the coronary arteries, which may be due to the imperfect transfer of coronary arteries to the neo-aorta, aorta pulmonary and bronchial collaterals, or injury to the wall of coronary artery during surgical dissection and ostial distortion. So gated SPECT MPI is a highly effective, reliable tool in children and with the congenital heart disease. It's a non-invasive, safe physiological investigation for the evaluation of myocardial ischemia and viability. It is a best predictor for cardiac event-free survival. Post-op follow-up with the myocardial perfusion imaging is relevant in showing the appearance or aggravation of myocardial ischemia or overall improvement in that. So what is the take-home message? The myocardial perfusion imaging is an important non-invasive test for evaluation of congenital heart disease patient. It has helped to assess the presence of viable myocardium and reversible ischemia. The stress protocol for this patient was done initially with a pharmacological agent and later with the treadmill. And there was improvement of ischemia due to the surgical intervention and optimization of medication. In transposition of great arteries, the overall survival is excellent post surgery, but long-term follow-up is necessary. Thank you.
Thanks, Dr. Ramkesh, for that wonderful presentation. It's a really good case to start with, kind of extremely important case reports, having a temporal collection of events.
Thank you, sir.
And yeah, very well done. We can move to the second speaker, Dr. Brenda.
Greetings from Vishnu. For this current session, we'd like to share two of our interesting cases. So, case one is about a 40-year female. She presented with left-sided abdominal pain in May 2019. Her initial workup and management was done elsewhere. So, initial workup showed left-sided suprarenal mass, which was initially thought to be renal cell carcinoma. So, she underwent left nephrectomy in June 2019. Interestingly, post-op biopsy came to be pheochromocytoma. So she was last to follow up after that, and she was back again in January 2021 to the same hospital, but this time with right upper contract pain. So workup at the time showed hypodense lesion in segmentate of liver as well as left lower para-aortic lymph nodes. So she was FNAC was taken from the segment 8 lesion, which was showed features consistent with paraganglioma, and with this she was referred to JIPMER for further management. So in her initial biochemical workup showed no elevated normetanephrine or metanephrine values, so it was biochemically normal. So to know the extent of metastasis, we have done we have started the evaluation with gallium dodenac scan, and to our surprise, gallium dodenac scan is completely negative. And FDG PET-CT also done. So FDG showed mild uptake in liver lesion, and some right female lesion is also noted. And MABG we have done. So MABG showed intense positivity for both liver metastasis as well as the left parietic lymph node metastasis. And this patient was treated with, as of now, she got 2 cycles of MABG therapy, each 100 millicurie and separated by interval of 3 months. So post 2 cycles, her performance status has improved, and as you can see from the post therapy scan, post second cycle, there is a intense reduction in uptake of MIBG in both liver lesion as well as the left parietic lymph node lesion. And the second case, she is also female, 43-year female. She presented with the left supraclavicular fossa mass with pain and numbness in the left arm. So again, she was initial workup and management was done elsewhere. So CECT was done, showed a large destructive lesion involving left first rib and as well as the transverse process of T1 vertebra. This was present in the left upper hemithorax. So FNAC was taken from that particular lesion and was showed features of metastatic carcinoma, and they given possibility of origin from adenocarcinoma of lung. So with this, we refer to this and for the complete metastatic workup, we started the workup with FDG PT, and it was showing multiple other metastases involving the liver as well as mass in the retroperitoneal region, which is encasing the right-sided aorta. And a biopsy was taken from the left hemithorax lesion, which is left supraclavicular fossa mass. Interestingly, it was positive for synaptophysin in CD56 and features were consistent with paraganglioma. So, our endocrine workup, our blood pressure was elevated more than 220/120 at multiple occasions, and she also had grade 4 hypertensive retinopathy and plasma norepinephrine are very much elevated. So Galen-Doudna scan was done, and Galen-Doudna showed intense SCAR expression in all the lesions. With additionally, it showed other skeletal metastases in compared to digitally, and to all our surface, MABG imaging is completely negative for this case. So currently, this patient is being treated with lutein dotatate. She currently received 3 cycles, each 200 millicurie. So at the end of 3 cycles, she had a good improvement in her performance status. As you can see from the image wise also, there is a good amount of reduction in almost all the lesions. So the teaching, learning points in these cases is this paradigm will have the clinical features will be very diverse. So some can be functional, some can be non-functional. So based on the clinical features and the biochemical features, they can be classified into different classes like silent type, pseudo-silent type, what functional status they are having, whether it is adrenergic or non-adrenergic or dopaminergic, like that, they can be classified. As well as the symptoms also will vary with the site of the lesion, extent of the lesion, as well as the functional status. And more importantly, these paragangliomas, 30 to 50% of times, they are associated with hereditary symptoms. So, like about more than 30 genetic mutations have been noted, which have been involved in the hereditary symptoms. So these hereditary symptoms have been clustered into 3 different clusters. So cluster 1 and 2 and 3, like cluster 1 is called a pseudo hypoxic cluster, and cluster 2 is called a SNAP kinase cluster, and cluster 3 is recently reported. Its significance is yet to be proven. So why to know the clusters? So one thing of knowing the cluster is this will help you in giving the genetic counseling, and secondly, in the management point of view, if the targeted radionuclide therapy is not working or the patient is rapidly progressing, ultimately patient has to go manage with chemotherapy only. So chemotherapy options, to decide upon the which chemotherapy option, if you know the cluster, if you know the phenotype, it will even help you to identify the appropriate treatment regimen for the patient. That is an important thing knowing the clusters. But in India, doing the clustering is financially is not possible. Financially is difficult for not all patients. So to some extent, we can predict the clusters based on the biochemical features as well as the imaging features. So if you see the cluster 1, most of the time it will be, if it is functional, it will be of noradrenergic type. For us, whereas for cluster 2, it is mostly it's adrenergic or adrenergic plus noradrenergic. Like interestingly, in imaging features, cluster 1 will be having high SSTR expression and high FDG uptake, but low to moderate FDOPA and low to moderate MABG imaging. Whereas in cluster 2, it is vice versa, where high FDOPA and high MEBG uptake will be there, whereas SSR imaging and FDG imaging will be of low to moderate type. That is the important thing. So if you see in case 1 and case 2, case 1 initially initial diagnosis was pheochromocytoma, operated at the time of reference, FNC short feature suggestive paraganglioma, and the patient doesn't have any functional symptoms. It's a silent type, and she is positive for MLBG, negative in SSR imaging, and mildly positive in FDG imaging, and no family history of any paragangliomas or pheochromocytomas in the family, and she is currently undergoing imaging therapy. Whereas case 2, her biopsy is paraganglioma metastatic at the time of presentation, and she is functional. That is important. She is functional, non-adrenergic type, and this patient is MABG negative, FDG positive, and SSR is positive. And currently, we are getting treatment with lutetium dotatate therapy. So the take-home points are: remember, paragangliomas will have a diverse presentation, and knowing the types of cluster is important to help you in treatment wise also, as well as for giving genetic counseling wise also. And functional status evaluation is very important because at the time of giving targeted radiation therapy, it might provoke adrenal crisis. So functional assessment is also important, and this metastatic paragangliomas can be treated with either lutetium 127 dotatate therapy or MABG therapy. So that is the take home point, and thanks for this wonderful opportunity. Thank you very much.
Thank you, Doctor, for the wonderful informative work from Jipmar. I could see that the response is also very good after the third cycle of treatment. Just one short question, if you are there. Was there any hypertensive crisis during the treatment sessions?
Morning, sir. Yes, sir. Like second patient, she had actually after the first cycle that was managed with prazosin. And during the second and third cycle, she didn't have any hypertension.
Okay, so alpha blood was located during the first cycle.
Yes, sir. And she was, her entire hypertension in throughout the course till now she is taking prazosin only. Initially only she had, but that time also like subtle mismanagement has happened. Like patient is dehydrated that time, so that provoked that. So after that we have seen to that she has not dehydrated, and she has not shown any other like these features in subsequent cycles.
Thank you very much. So multimodality care is definitely required in such kind of patients. So we can move on to the next speaker, Dr. Ajit from Muslims.
Good afternoon, everybody. I'm Dr. N. Ajit, Senior Resident from Sri Venkateswara Institute of Medical Sciences, Tirupati. Today, we would like to present a case of mobile kidney that has been referred to the Department of Nuclear Medicine for DTPA renography. So it's a case of 33-year-old female patient who came with complaints of pain, abdomen, and occasional dysphagia since 1 year. Patient was apparently asymptomatic 1 year ago. Later, she noticed pain in abdomen that is dragging in nature, radiating to back, predominantly on the right side, with no associated symptoms or aggravating or relieving factors. Also, she had a history of occasional dysphagia. There was no other significant history like fever, chills, nausea, vomiting, hematuria, pyuria, uria, or any abdominal distension, puffiness of face, edema of lower limb, or an history of cough or breathlessness. On evaluation, patient underwent ultrasound followed by ultrasound Doppler that revealed compression of the left renal vein at a compression ratio of greater than 2.5. Based on these findings, the patient was diagnosed with Nutcracker syndrome. For Nutcracker syndrome, the patient underwent stenting of left renal vein under fluoroscopic guidance. However, the symptoms of dragging pain persisted in the patient. The patient has no other significant comorbidities like diabetes, hypertension, tuberculosis, asthma, epilepsy, or CVA. Personal history: patient takes mixed diet, regular bowel movements. Patient has regular menstrual cycles. On examination, patient was conscious, coherent, and cooperative. The vitals were stable with a blood pressure of 124/74 millimeters of Hg in sitting position in right arm, a pulse rate of 82 per minute that is normal volume and character of a bell, and a respiratory rate of 13 per minute. On abdominal examination, there was no guarding, rigidity, palpable swelling, or organomegaly. Both kidneys were bilateral, and other system examinations were normal. The investigation undergone by the patient was serum creatinine, which was 0.8 milligram per deciliter, and ultrasound abdomen that should violate a normal shaped thickness with maintained protection and normal pelvic calcium systems. X-ray KUB in sitting and supine position showed no significant change in position of both the kidneys. The patient was later referred to Department of Nuclear Medicine for DTPA renewal. So the patient underwent 9 technician DTPA F0 protocol diuretic renography on 2 separate days. On the day 1, the scan was performed in supine position. On the day 2, the scan was performed in erect position. This is the image showing the 9 technician DTPA renography that was performed in supine position. We can see there was normal perfusion in both the kidneys, followed by normal irritation uptake in bilateral inner parenchyma. The clearance into pelvic calcium system and subsequent drainage of the pressure appears normal. As we can see here, the GFR of the left kidney is 35.8 and of the right kidney is 34.8. The Tmax being 2.2 and 2.0 and the Tf being 5.4 and 5.6 respectively. When the scan was performed on the second day in erect position, we can see that the right kidney there is slightly lower place compared to the scan of the previous day. Also, when we come to the GFR, the right kidney GFR is 31.3 in erect position and it is 34.8 in supine position. For left kidney, it is 34.3 and 35.8 respectively. Also, when the delayed images were performed, here we can see 2 images. A is the static images in supine position and B is the static images in erect position. And when the tip of the right kidney is measured from tip of the left kidney, in supine position it was 40.2 millimeters and in erect position it is 54.4 millimeters. We can see a shift of close to 1.4 centimeters in the kidney in erect position. So nephroptosis is a condition where there are mobile kidneys, either one or both the kidneys. When one or both the kidneys drop by greater than 5 centimeters or 2 vertebral body depth breadth below their correct position in the abdomen, when a person stands up, it is called renal ptosis. Dietary cases characterized by symptoms of acute nephroptosis as episodes of acute abdominal pain, vomiting, and orthostatic hypotension. It was first described in 1984. If the patient has symptoms, it was treated as nephropexy. However, surgery is not recommended in asymptomatic patients. Symptomatic nephroptosis is more common in females compared to males, with the ratio ranging from 5 to 10:1. Also, in 2/3 of the cases, right kidney is more affected than left kidney. Similarly, in our case, it was a 33-year-old female patient where there is mobile right kidney. Usually, diagnosis is suspected based upon patient symptoms or incidentally and confirmed by erectance supine IV pyelogram. But IV urography is useful in anatomical diagnosis and drainage of the kidney, but does not comment on the function of the kidney. So, in order to see if there is any change in the function of the kidney with change in position of the person, renal scintigraphy is used. So, renal scintigraphy not only confirms the diagnosis but also demonstrates reduction in renal blood flow, altering function, drainage in different postures, and aids in the decision making of nephropathy. Thank you.
Thank you, Dr. Ajit. For the sake of students and young people here, can you kindly explain how you did your erect imaging? Whether the patient was sitting or the patient was standing, how did you do it and in which camera did you do it? Can you please unmute yourself? Please unmute yourself. You got
Yes,
my
sir.
question, right?
Yes, sir. Yes, I got the question, sir. So we did the DDP renogram on 2 separate days, sir. One was a regular protocol in supine position using anterior and posterior both detectors, sir. On the second day, we... Hello, sir?
Yeah, can you explain only the erect?
Yes, sir. On the second day, the patient was made to stand and the detectors are rotated into a lateral position and both the detectors are activated and the DTP dynamic renogram was performed, sir.
Almost like your esophageal transit time position.
Sir?
Almost like your esophageal transit time position.
Sir, yes, sir.
Okay. Thank you. Dr. Santosh, would you like to have give any
vivid demonstration? Just did the patient underwent any procedure after that scan, like nephroplexy or something like that?
No, sir. No, sir. The patient did not undergo nephroplexy later.
Thank you.
Okay, thank you, sir.
We can have the next presentation from Nizam's Institute, Dr. Vinod.
Very good morning to everyone. At the outset, I want to thank the organizing committee and SNMI Southern Chapter for giving me this opportunity. I would like to present a few interesting cases which we did in our department. Case 1 is a 57-year-old female patient presented with nasal stuffiness. On evaluation, she was found to have a unilateral polypoidal growth in the nasal cavity in the right antroconal region. The biopsy was done and report, we'll reveal it in short time. And she was advised PET CT. In the PET CT, you can see the MIP image. It more or less looks normal. And these are the actual images which reveal the polypoidal growth in the nasal cavity. The polypoidal growth is FDG avid located in the right antroconal region, mostly arising from the bony septum. These are the coronal images. Usually the nasal polyps are bilateral and mostly they arise from chronic, in the setting of chronic rhinosinusitis and with asthma or aspirin sensitivity or cystic fibrosis. When we should consider for alternative diagnosis when the polyps are unilateral or congenital. In our case, it is a unilateral polyp. So the differentials usually are benign or malignant. Benign could be Sneurial papilloma, AC polyp, angiofibroma, encephalocele. And malignant could be squamous cell carcinoma, esthesioneuroblastoma, nasal lymphoma, and abdominocarcinoma. But to our surprise, the diagnosis was Ewing sarcoma, which was CD99 positive, FL1 positive, and synaptopathy negative. And coming to Ewing sarcomas, these are Ewing sarcomas and PNET. They belong to small round cell tumor family. They usually seen in children and adolescent, and the male and between age and 10 and 20 years, and the male to female ratio is 1.5 to 1. Usually, in this case, it was 57-year-old female. And coming to location, they are usually found in lower limbs, pelvis, upper limb, but very rarely found less than or else around 2% in skull and face. Considering the location and the age, it was a very rare thing to see. And coming to the next case, this is a case, a 35-year-old female patient. He presented with shortness of breath, and after evaluation, she was found to have multiple lung nodules bilaterally on HRCT. And she was able for a PET scan suspecting metastasis. And on PET scan, this is a MIP image. You can see there is uptake in the mediastinal region, mostly mediastinal nerves, and there is mild uptake even in bilateral lung fields. And on the axial image, we can see multiple round, discrete nodules in both lung fields with minimal or no FDG uptake. And we scroll down the scan, there are no significant other FDG avid lesions. Then on looking further, we found enlarged uterus with multiple fibroids. Correlating both and this biopsy of leiomyoma from the uterine mass, we came to a conclusion of benign metastasizing leiomyoma because the lung nodules were not so FDG avid, and in a patient of reproductive age with leiomyomas and with discrete nodules, benign metastasizing leiomyoma could be one of the entity. As you see, these BMLs are benign leiomyomas which metastasize to distant organs such as lung, kidney, bone, and etc. Usually, these patients are asymptomatic, and sometimes they may have cough and SOB. The diagnosis is made by biopsy, which shows spindle cells, and IHC shows muscular markers like desmin, and sometimes ERPI positive receptors too. And the BML, as we discussed, in a reproductive age females, if we find pulmonary nodules and uterine leiomyoma, we should consider possibility of BML after excluding other possibilities like spindle sarcoma, nerve sheath tumor, or malignant melanoma, where in these conditions like sarcoma, malignant melanoma, we usually come across FDG, very FDG avid nodules, which is not in this case. And these BMLs are usually treated with anti-estrogen management like oophorectomy or GnRH analogs. Now we'll move to case 3. This is a 41-year-old female patient, known case of shear right breast, and she underwent CTRT and a wide local excision axillary clearance in 2019 itself. And after that, she was on regular follow-up. And in 2021 October, she developed cervical lymphadenopathy, FNAC reactive lymphadenitis. Then the patient was referred for FDG PET scan in October 2021. This is the scan, and we can see focal FDG uptake in the mediastinal region. And on the axial image, this FDG uptake correlates the internal memory location. We mention it as an internal memory node. After that, she came for another scan after 3 months. What they did in the 3 months, I'll come across after some time. But she didn't receive any treatment in these 3 months. So usually we suspected progress. Then we did the PET scan in January 22 and October 21. More or less they look same, and even on the axial image, the location and the FDG uptake more or less same. And as I said, once after the October 21 PET scan, they did an ultrasound to get FNAC from that left internal memory node or uptake. But for the surprise, there was no node identified on the ultrasound. So she was kept on observation for 3 months. Later, to analyze the disease status, they went ahead with PET scan. And the PET scan also status quo. So there is no progression in even PET scan. And it is a right breast, and the uptake is on the left internal memory region. So based on considering all these things, we examined the patient clinically, and which revealed focal uptake in the chest wall region, especially in the left fourth costochondral junction. And considering all these conditions, no node on USG, no progression on PET scan, and clinically the pain, we came to the conclusion of Tietz syndrome. What is Tietz syndrome is an inflammatory disorder. It's also called as chondropathia tuberosa costochondral junction syndrome. And there is mild to severe localized pain, especially in the upper 4 ribs, 1 or more 4 ribs. And mostly it's idiopathic. It can be sometimes preceded by chronic excessive vomiting or coughing, like that. The treatment is usually it resolves on itself, some cases, but some may need NSAIDs and even steroids. The pain is usually lasts for several weeks or months. In our case, the first scan was in October and the second was in January. The uptake was more or less the same. Thank you very much. Rare things may not be so rare as you think. Thank you very much for your patient listening.
Thank you, Doctor. Dr. Vinod, I'll give you a very quick comment. One thing is that, the third case that you labeled as Tietz syndrome, I hope that you are right, but untreated disease might still be present. So this should not be a rule. It should not be a rule that you see an internal memory lesion and then if it doesn't progress, you label it Tietz. I think you gave the point correct, but I'd like to emphasize that focal uptake in the internal memory region in the case of CA breast is still internal memory lymph nodal metastasis, more likely than Tietz syndrome. Santosh?
To add the same case which you had just discussed, I think you are smart enough, the presenter was smart enough, didn't show the CT scan, but if you closely observe, it is more over the perichondrium, periosteum region rather than the internal memory region. So I think the epicenter should have been probably described as around the periosteum or costochondral junction, something like that. That would even make us think more in favor of Tietz syndrome. But what Dr. Hari has added, that we have to closely check the other differential sign in known malignancy. Thank you.
Regarding your case 1, Any nasal septal lesion, always consider possibilities of NK T cell lymphoma and vaginous granulomatosis also, especially if they are FDG.
Okay.
Okay, thanks, Doctor. You can have the next presentation from CMC Vellore, Dr. Asha.
My pen.
A very good morning to you all. I'm Dr. Asha Rose-Jose, PG Registrar from Christian Medical College, Vellore. Today, I'm here with a case presentation, In Search of the Three Musketeers. Coming to the history, we have a 38-year-old lady who was apparently normal till August 2020 when she was tested positive for COVID with a mild illness. On admission, her BP was detected to be 180 by 100 millimeters of mercury, and chest X-ray showed a well-defined opacity in the right lung lower lobe. Her vitals were stable, no other specific complaints. A CT scan done 2 months after discharge showed lesions in the right lung, in lesser curvature and greater curvature of stomach, in retroperitoneum and the right adrenal, and so she was admitted for further investigations. Past history, personal history, nil significant. Her family history, father and 3 paternal sisters were hypertensive. A younger brother was diagnosed hypertensive at the age of 32 years. On examination, her BP was 160 by 90 millimeters of mercury. Other general examination and systemic examination was normal. To summarize, we have a 38-year-old lady who was completely asymptomatic with incidentally detected hypertension and a lung opacity in chest X-ray. CT scan done showed lesions in the lung, stomach, retroperitoneum, and the adrenal. A paraganglioma pheochromocytoma workup was done, which showed elevated normetanephrines. Metanephrines was 52 and normetanephrines was 1,175 micrograms in 24 hours. Adrenal hormonal workup revealed normal DHEA. Serum electrolytes were normal. Workup for Cushing syndrome was negative. Chromogranin A was elevated, 399 nanograms per ml. She was started on salt and water loading and taprazosine. Regarding the stomach lesion, gastrin levels were normal. Endoscopic ultrasound was done. She also underwent a succinate dehydrogenase X demutation analysis, which proved to be negative. The findings of endoscopic ultrasound, there were 2 submucosal gastric lesions with echo features suggestive of a gastrointestinal stromal tumor, and another hypoechoic lesion near D1, which could not be characterized on ultrasound. So to confirm all these findings, we did an FTG PET. After an overnight fasting, the blood glucose was found to be 180 milligrams per deciliter. 316.35 megabecquerels of F18 FTG was administered intravenously and imaging was done after 70 minutes. The PET findings. Firstly, there was a hypodense lesion with SUV 4.60 with peripheral coarse chunky calcifications in the lower lobe of right lung, 32 into 31 millimeter size. Secondly, there was an enhancing 25 into 30 millimeter lesion in the periportal region with an SUV of 46.24 abutting the proximal duodenum. Thirdly, an enhancing 30 into 24 millimeter soft tissue lesion in the anterior perigastric region with an SUV of 45.63. Then an enhancing soft tissue mesenteric lesion with SUV of 16.76 along the inferior surface of the distal body of stomach, similar to the lesion in anterior perigastric region, 12 into 13 millimeter size. And lastly, there was a hypodense lesion in the right adrenal, SUV of 5.02 and average attenuation 27 Hounsfield units in CT. Size was 28 into 36 millimeters. To summarize the PET-CT findings, 2 lesions which were considered benign because of their low SUVs. One, a lesion in the lower lobe of right lung with chunky calcification, which was likely a pulmonary cartilaginous lesion, and a right adrenal lesion, which was likely a adrenal adenoma. And 3 other significant lesions, a lesion in the periportal region abutting the proximal duodenum, which was likely a neuroendocrine tumor, and the location-wise it favored a gastrinoma. A soft tissue lesion in the anterior perigastric region abutting the distal body of stomach, possibly a gastrointestinal stromal tumor, and an enhancing soft tissue mesenteric lesion along the inferior surface of the distal body of stomach which was similar to the lesion in the anterior perigastric region, possibly another GIST. So based on all these findings, she was diagnosed to have a Carney's triad. She underwent surgical management. A right adrenalectomy and excision of paraganglioma and the multiple GIST was done. The histopathology proved to be adrenocortical adenoma in the right adrenal, paraganglioma in the right paracaval region, and 3 nodules of the gastric serosal surface was confirmed to be multifocal GIST. Abdominal lymph nodes were negative for malignancy. After a follow-up of 1 year, the metanephrines lowered from 52 to 45 and normetanephrines from 1175 to 143 micrograms in 24 hours. A CT thorax was done to assess the pulmonary lesion, which showed a mild interval increase in the size of the previously seen pulmonary chondroma. And regarding the abdominal post-op site, there was no evidence of any disease recurrence. So because of the increase in size, enucleation of the lung tumor was done, which histopathology proved to be a pulmonary chondroma, and the pulmonary lymph nodes were negative for malignancy. So discussion about Carney's triad. Carney's triad is a triad of paraganglioma, gastrointestinal stromal tumor, and pulmonary chondroma, which was initially described. And later, 2 subsequent tumors were added were adrenocortical adenoma and esophageal leiomyoma. Carney's triad was first reported by Dr. J. Aidan Carney in 1977. It is a multiple neoplasia syndrome. Most patients present with 2 out of 3 parts of the syndrome, which is known as incomplete Carney's triad, the most common combination being a GIST and pulmonary chondroma. There is no specific ethnic or geographical predilection. A dyad of paraganglioma and GIST is known as Carney-Strategy syndrome, which has an equal incidence in males and females. The most common presenting tumors are gastric lesions in 75% of cases, followed by lung lesions in 15% of cases, and paraganglioma, the least, that is 10% of cases. Prognosis, the mean survival time is estimated to be 19.6 years. Now, few words regarding the role of FDG PET-CT in GIST and paraganglioma. Regarding GIST, FDG PET is frequently used for staging purposes, particularly indicated in cases of ambiguous CT or MRI. The sensitivity for detection is 86% and positive predictive value is 98%. False negative views are mostly related to low mitotic index or a low Ki67 score. FDG PET is capable of detecting tumor lesions up to 1 centimeter and also epiploic metastasis, which is usually undetected in CT. It is sensitive and specific to assess early response to imatinib treatment also, where the tumor size alone is unreliable. Regarding FDG PET-CT in paraganglioma, the sensitivity is mainly influenced by the genetic status of the patient, like patients with succinate dehydrogenase H subunit B or von Hippel-Lindau mutations are highly FDG avid. False negatives can occur in cases of sporadic pheochromocytomas and retroperitoneal extraadrenal paragangliomas, MEN2-related pheochromocytomas, and head and neck paragangliomas. The sensitivity and negative predictive value is supposed to be very high, close to 80 to 100%. Positive predictive value is low due to the lack of specificity of FDG. And compared to conventional imaging techniques, FDG PET may also detect other syndromic lesions. Now, I would like to discuss some common findings in our case as per literature. Firstly, the young age of the patient. Carney's triad, the mean age of presentation is 20 years. There is a female predilection. 85% cases of Carney's triad patients are females. Here our patient was also a female, and also the non-familial association in this case. Now some findings which were unique in our case and concordant with the existing literature. Firstly, our patient was asymptomatic. The most common initial manifestation on Carney's triad is upper GI bleeding or any associated symptoms. Here in our case, patient was completely asymptomatic. Secondly, there was a complete manifestation of the triad. Now, fewer than 30 cases worldwide has been described till date. Paraganglioma itself is a rare combination in the Carney's triad. And if at all present, the most common location will be an aortopulmonary body. But here in our case, it was a retroperitoneal location. Here we also had a non-functioning adrenocortical adenoma, which is only seen in 13% of cases of described of Carney's triad. And around 73% cases in Carney's triad will have association with succinate dehydrogenase X gene mutation, which was negative in our case. So the learning points. Carney's triad is a rare condition that can present deceptively with an appearance of widespread disease. However, the progression is surprisingly indolent. Key features to aid or prompt recognition are the young age at presentation, preponderance in women, and multifocal lesions. Treatment involves surgical removal of the components of the triad as well as long-term follow-up for possible recurrence. And PET-CT can be a one-stop investigation to probe into the components of the triad when suspected and also to characterize them. Thank you.
I would say that you are lucky enough to get a good collection of all the syndromes, all the manifestation in this case. Just you told that in your case, it was SDH mutation negative.
Yes, sir.
However, the FDG was showing intense uptake.
Yes, sir.
It's somewhat against the existing norms, I believe.
Yes, yes. Usually, SDH mutation positive cases show high FDG avidity.
And I think there are 3 or 4 different types of SDH mutations.
Yeah.
And probably you have done maybe 1 or 2 type of mutation. Probably the other type of mutations they are not explored. That could be one explanation.
Okay.
I may be wrong, but you have to check about that. And what is the presenting symptom? Hypertension in this patient?
So this patient was completely asymptomatic. She was admitted for COVID mild illness, and then on examination, incidentally detected hypertension. And then the chest X-ray done for COVID showed this pulmonary lesion.
How much was the hypertension value?
180.
Was
180 was a systolic when she presented.
Okay. Okay. Thank you.
Thank you, Dr. Asha. The message that everyone should get from this presentation is that you have to have something what is called as the gestalt psychology. You always try to fit everything into one diagnosis. The whole is more than the sum of the parts. So instead of giving multiple diagnoses for different findings in each region of the PET scan, always try to fit every finding into a single diagnosis. Thank you.
Thank you, sir.
So we can have the final presentation from Dr. Ruby from KMC Manipal.
Good morning to one and all. This is Ruby Sara presenting case report, defective system or source. As we are all part of the nuclear medicine community, we may be well aware that calibration or check sources are essential for the quality check of any imaging or non-imaging modalities. One among such is the cyclotron-produced cobalt-57, the mock source of technetium-99m radionuclide, which is widely used as a check source to assess the performance of gamma camera and other modalities. Imaging modalities such as the gamma camera itself help us in diagnosing and treating diseases by providing optimal images. The quality and detail of such images obtained by gamma camera are dependent on several parameters, which are listed here. We have from energy resolution to spatial linearity and so on to dead time. NEMA under IAEA has specified guidelines for the optimal functioning of gamma camera. One among these guidelines is the uniformity test, which is routinely carried out by a technologist. So coming on to the uniformity test, what is uniformity? The ability of gamma camera to produce a uniform radioactive distribution of a uniform flood source. As stated prior, cobalt-57 is one of the widely used check sources. This is because a calibrated and certified cobalt-57 check source gives a high degree of consistency in terms of photon flux per centimeter square. When this bar is not met, the uniformity in the images decline. So let's see the various factors due to which non-uniformity in an image can arise. There are several reasons, few of which are listed here. The first one is a defective crystal, second, defective collimator, third, non-linearity, fourth, non-uniform detection efficiency or differential response of the PNT, And the last one is a defective check source. Here we see that there's a small region of photopenia, and this image was acquired using and it was found that the check source itself was defective. As nuclear medicine technologists, we carried out our routine performance checkup on our gamma camera. We first started off with the intrinsic uniformity test. With these parameters in place, we used a technetium-99 endpoint source without the collimator in place, and our system generated uniformity results. These were the images acquired. As seen here, the images appeared uniform and the values were well within the limits. Next, we performed the extrinsic uniformity test with the newly procured cobalt-57 flood source. The same parameters were applied, but here we mounted the collimator and our system generated uniformity results. Moving on, we see here that the images acquired by the extrinsic uniformity test. Here we see that the images appeared non-uniform. There was a slight region of photopenia seen at the edge of both images. And also the values were not within the limits, neither satisfactory. Since the intrinsic and extrinsic images did not match, it posed us with a challenge, which was the question, is it the collimator at fault or is it the newly procured cobalt-57 flood source which is at fault? To address the challenge, we acquired some static images, but this time by flipping the cobalt-57 flood source. The same parameters were applied and the images were acquired. The second set of images, these were the images acquired after the flipping of the cobalt-57 source. On comparing both the set of images, we see that there was a shift of pattern from the first one to the second one. But the same photopenic region was seen, but now on the opposite side, revealing that it is in fact the cobalt-57 flood source which was at fault. To conclude, the test revealed that the newly procured cobalt-57 flood source was defective and steps were taken in contacting the vendor for the replacement of the same. Now, what do we infer from this? On the procurement of any calibration source, a quality check for acceptance must be carried out by nuclear medicine physicists to rule out any defect caused by the vendor side. That is the end of the report. Thank you.
Thank you, Ms. Ruby. It's really appreciable that you had a good common sense and lateral thinking to address this issue. Had the source been tossed back to the vendor? I'm still with you.
What is the cost of the source?
Ruby, please unmute yourself.
Yes, sir. The source is currently with us, but the vendor has been contacted for the replacement. The cost of the source, sir, I'm just aware that it's expensive. And also, just for clarification, I'm only a student pursuing my bachelor's in nuclear medicine, final year. So.
The apt topic, the apt name for your topic should have been quality control of quality control sources. Thank you all. Thank you, Dr. Santosh, for chairing the session. We have had 13 talks from very young people of our community. All the talks have been excellent. They've been above par. So we'll move on to the next session. Before we move on to the next session, which is one of the highlights of this conference. The next session is called the UVA session, which was conceptualized somewhere, I think around 2013 or something, where I attended UVA Foxy, a separate conference for young gynecologists. And that was when I was having it in my mind that even for our nuclear medicine conference, we should have something called UVA, where young nuclear medicine physicians are given the opportunity to talk. So we have 4 young dynamic nuclear medicine physicians here. Some other young physicians have already given the talk in yesterday's conference also. So this session will be chaired by Dr. Maitri Shankar ma'am from Karnataka. Dr. Kashi Vishwanathan sir, who is senior consultant hematologist from Madurai Meenakshi Mission Hospital, and the famous Dr. Lakshmipati sir, who I have to thank him a lot because his team from HCG Cyclotron had given me a very important seed money for organizing the conference. Thank you very much, sir. So before we move on to the session, can I ask Dr.
What is the age limit for youngster Harishankar?
Sir, I consider myself also young, sir. Sorry. Sir, we have kept as less than 5 years after passing their degree. Not the age limit of the speaker, but the experience of the speaker, sir.
Okay.
Over to
Sir, sir, I am young. That's why put me in the Yuva group.
You are always young, sir.
Thank you.
Age is just a number. You know, I always ask people, how young are you, even if it's at heart.
So let's move on to the quiz. I think people are very much interested to answer the quiz. We are getting good number of responses to the quiz. So first I will announce the winner for the quiz number 11. It is Dr. Kanaya Agarwal from AIMS Bhubaneswar. So the next question is question number 12. So hope you all know that we have to answer by pressing this quiz button, selecting the option. So 10 seconds will be given after I explain the question. Within that, you have to give the responses. So this is the vasculature, abdominal vasculature. So a patient with involvement of vasculature. So you have to detect which vessel is involved. So this is the video showing left para-aortic mass encasing the vessel. So I will play the video again. Sorry. Left para-aortic mass encasing the vessel.
We can also show the MIP image if possible.
Okay. MIP image is not available. So 4 options. First option is celiac axis. Second option is superior mesenteric artery involvement. Third option is inferior mesenteric artery involvement. And fourth option is abdominal aorta involvement. So I'll just run the video again for the sake of repetition. So these are the options. So we'll wait for 10 seconds before we conclude this quiz number 12. Hope you have answered the quiz. Shall I reveal the answer?
Yes, ma'am. Please go ahead.
So the answer is celiac artery. So the nodal mass is encasing the celiac artery. Over to you, the chairpersons. You can go ahead with the next session, which is interesting one. You are.
I'm kindly, yeah.
Very nice, Dr. Harishankar. A very good program. The first one is on melanoma, right, Dr. Soumya?
Yes, ma'am.
Yeah, great. So on a Sunday morning, I think all of us would rather be on the beach soaking up the sun. We also know sunlight has UVA and UVB rays. One of them causes melanoma. So typically, PET-CT is nuclear medicine. There is a very significant role PET-CT can play in staging of melanomas. Also, it's a very important prognosticating factor. PET-CT can stage the patients and refer to appropriate immunotherapy or radiation therapy or chemo. About 99% survival if it is localized disease, about 60% if it has spread to the lymph nodes. I think our next speaker is Dr. Soumya, who will speak upon melanoma. Over to you, Dr. Soumya.
Good morning. The topic of my presentation is F18-FTG PET-CT in melanoma. I'll be briefly covering about the role of F18-FTG PET-CT scans in staging, in the changing of management, in prognostication, in response to therapy and follow-up of these patients. As we know, melanoma is a highly metastatic neoplasm of the skin, and when detected early and when amenable to surgical management, there is a high 5-year survival rate. But in those with regional or distant metastasis, the therapeutic options are limited. We also know that nearly all patients with distant metastasis and 50 to 80% of patients with loco-regional metastasis have a disease recurrence after treatment. The usefulness of FDG PET scans is already well established in imaging of bone, soft tissue, and visceral melanoma metastasis. It is superior to conventional CT alone and MRI, especially in the detection of metastasis, with the exception of brain and liver mets, where MRI fares better. With the advent of the next generation therapies, that is mutation-driven therapies and immunomodulation therapies, F18 PET scans play an important role in the therapeutic response and post-treatment surveillance. When we look at the AJCC 8th edition clinical and pathological criteria for staging, the TNM staging, in the end stage, we find that it is further divided into micrometastasis, macrometastasis, and another criteria of in-transit or satellite metastasis is also seen, which is detected only with lymphadenectomy or lymph node biopsy. The T stage is divided further based on the thickness of the tumor, where T4 is melanoma thickness more than 4 mm, and they're further divided into A and B criteria, where A is without ulceration and B is in the presence of ulceration. The nodal metastasis is divided based on the number of metastatic nodes involved. They are also further divided into A, B, and C, where A is clinically occult nodal metastasis. B is when they're clinically detected, that is, they're palpable on physical examination and then confirmed on biopsy. And the criteria C means there is a presence of MCI, which is micrometastasis, satellite, or in-transit lesions noted in the nodes. The M staging is divided based on the organ of involvement. And in addition, there is an incorporation of serum LDH levels. So a value of 1 means there is an elevated serum LDH levels in addition to the M staging. So staging is basically both clinical and pathological. And with the involvement of nodes, it becomes stage 3, which is further divided based on the histopathological characters into A, B, C, and D. And in the presence of metastasis, it becomes a stage 4 disease. There are several prognostic criteria for staging. More importantly, the Breslow thickness of the primary tumor, presence of ulceration, the mitotic rate, presence of nodal involvement or distant metastasis. There are several other prognostic indicators that have been listed as well. We also note that as the stage increases, there is a considerable drop in the 5-year survival rates. The NCCN guidelines states that imaging is not recommended routinely when it is stage 0 to 2. However, if there is a higher suspicion of lymph node involvement, especially in an equivocal setting, the sentinel lymph node biopsy is the modality of choice. But with higher stagings, that is from stage 3 and upward, a cross-sectional imaging is warranted both for baseline imaging and post-treatment surveillance. So like I already mentioned, in stage 1 and 2, there is a low yield for detecting occult mets, and so it is not recommended. However, in advanced stages, the scan is recommended because it is both sensitive and specific. We also note that smaller the tumor size and lesser the thickness, that is lesser the Breslow thickness, that within 4 mm, there is a lesser chance of picking up disease on the scan. In these cases, a sentinel lymph node biopsy is warranted. But whenever there is palpable or macroscopic locoregional nodal metastasis, the PET scan is useful for staging. We also note that in those patients who have locoregional nodal metastasis, almost 60% of them will develop distant metastasis. And in these patients, a timely detection impacts survival. This is an example of a 50-year-old gentleman who had presented with the right parietal scalp swelling, diagnosed with malignant melanoma. He had presented with cervical lymph nodes and lung nodules upfront in the baseline staging imaging. PET scans are also useful in changing management strategies. One study noted that there is almost 15 to 64% of changes noted in the management strategies, especially in advanced cases, that is stage 3 and stage 4 of melanoma after a PET scan is done. And also in initial staging in palpable disease, warrants earlier intervention, and this definitely confers a survival benefit. If you look at the overview of management, we find that up from stage 0 to 1B, the primary treatment is wide excision. This can be followed with or without sentinel lymph node biopsy. From 1B to 2, again, the treatment of choice is wide excision with or without sentinel lymph node biopsy, and these patients are further followed up or loco-regional radiation therapy is offered. From 3A onwards, that is when sentinel nodes are positive, we have to do an additional BRAF mutation testing. And apart from that, the patient also undergoes a complete lymph node dissection and is also offered systemic therapy. In stage 3 disease, where there's clinically positive nodes, there's a wide excision of the primary tumor along with therapeutic lymph node dissection. And after this, systemic therapy options are considered. Also, we can also consider neoadjuvant therapy upfront itself in the context of any clinical trial. In the setting of metastasis, if it's an oligometastatic disease and if it is amenable to resection, a resection is done first. Otherwise, the patient is subjected to systemic therapy options. So we look at PET in response assessment, and we find that FDA-approved indications for immune checkpoint inhibitors in melanomas include ipilimumab, nivolumab, pembrolizumab, and further combinations. BRAF-targeted therapies like dabrafenib and vemurafenib are also used, and they can also be used in combination with BRAF or MEK inhibitor combinations. So all these are used in the setting of unresectable or metastatic melanoma. Immunotherapy, the principle of action is that when there is an inhibitor which blocks the PD-L1 or PD-1, that is programmed cell death protein, it initiates a T cell killing of the tumor cell. So this immune checkpoint inhibitors initiate a T cell killing of the tumor cells once the inhibitor acts on them. The most common PD-1 inhibitors used are nivolumab and pembrolizumab, and CTL1A, that is cytotoxic T lymphocyte associated protein inhibitors, are ipilimumab, and so on. However, there are some challenges in the response assessment in PET scans when immunotherapy is initiated. The first one being atypical response patterns. Pseudoprogression is often noted. This is nothing but a tumor shrinkage has been identified after an initial increase in the tumor burden or the appearance of new lesions. This is primarily because of treatment-activated immune cells that infiltrate the tumor. Hyperprogression is when there's a tumor growth that is faster than the rate at which it was previously under the previous treatment. Dissociated responses are when there are regression in some target lesions but progression in others. In addition, confounders can be because of immune-related adverse effects. The endocrine, lung, cutaneous, and gastrointestinal systems are most commonly affected. So patient presents with hypophysitis, thyroiditis, dermatitis, colitis, and these are common things that we see after a patient is initiated on immunotherapy. This is an example of a patient with melanoma and lung mets. After 2 cycles, we find that new lung nodules developed. But after 6 cycles were completed, they regressed. And this patient also had possible colitis. So this is an example of a pseudo-progression, an apparent increase in disease, but it was actually not progression. This is primarily because even though after immunotherapy is initiated, there is a drop both in the metabolism and viability of the cell, there is an apparent increase in the diameter of the tumor during that interim period. But it will reduce with time, and at the end of the treatment cycles, we will find that that disease has disappeared. This is a patient demonstrating hyperprogression, that is with treatment we find that new lesions develop and the disease worsens over time. These are examples of immune-related adverse effects where we find uptake in the thyroid, gastritis, colitis, and enthysopathies are all common manifestations of IREAs. This is an example of a patient who had melanoma of the arm that was resected, but was restaged because he found avid lung nodules on the baseline PET scan. And following treatment, we find that the disease still remains stable. So PET scans are very useful for response assessment. So there were several metabolic response criteria that were brought about to assess response in PET scans after immunotherapy initiation. Few include PERCRIT, IM persist, and PERSIMT, which is response evaluation criteria for immunotherapy. When we compare all these criteria, we find that there are several studies that have looked into all of this. But if you have to look at progressive disease, according to Perkrit, it is an increase of 30% in the SUL peak, or more than or equal to 20% increase in the target lesion or new lesions. But PERSIM says a functional diameter should increase more than or equal to 10 mm in at least 4 new lesions, or 3 more lesions with more than 10 mm functional diameter, or 2 or more lesions with more than 15 mm functional diameter increase. So this renders the criteria whether there is clinical benefit or no clinical benefit. So when there is progressive disease according to the criteria, there is no clinical benefit. So several studies looked at the usefulness of these criteria, and few of them I have mentioned here. This article that came up said that PERSIM criteria was more sensitive predictor of clinical response than the application of the EOR-TC criteria. When we look at pattern prognostication, we note that SUV max, the MTV and the TLG are good parameters. So higher the values at the baseline and higher the values at 3 and 6 months after the initiation of therapy, the worse the survival. In follow-up, I present a case of a 55-year-old lady who had right heel melanoma post-excision. In 2017, her scan did not show any hypometabolic activity. She had a recurrence in the popliteal fossa nodes in July 2018, following which the disease worsened. New lesions were noted in the external iliac nodes and the thigh, following which she started nivolumab, and this scan showed regression of the disease. But again, recurrent lesions were noted in the scan done in 2021. So this highlights the importance of FDG PET scans in the surveillance of patients after treatment. So according to NCCN guidelines, they say that after stage 2B to 4, for up to 5 years, the patient should be imaged every 6 to 12 months. This is because the rates of recurrence are very low in up to stage 2A disease, but subsequently they increase. And stage 3 and above, there is more than 30% recurrence rate, and they occur mostly in the first 5 years. So if you look at the recommendations of imaging from stage 1 to 2A, it is not routinely recommended, but cross-sectional imaging is done for specific signs and symptoms. From 2B to 4, it is not only done as routinely for specific signs and symptoms, but also it is done for the first 2 years every 3 to 12 months, following which for the next 3 years, the imaging is done every 6 to 12 months. So to summarize, PET in staging is very useful, especially in advanced cases, stage 3 and 4 disease, because it is both sensitive and specific. And if it is a disease lesser than that, a sentinel lymph node biopsy is more useful. It alters management. Again, in advanced cases, it is useful. And as a response assessment, we find that there may be confounders because of atypical responses and immune-related adverse effects, especially in the initiation of immunotherapy. Several metabolic response criteria are there to look at response assessment in PET. And to prognosticate, we know that SUV max, TLG, and MTV are good clinical parameters to look at prognostication. And the follow-up always depends upon the stage. If it is 2B and beyond, imaging should be done every 3 to 12 months in the first 2 years, and subsequently for the next 3 years, every 6 to 12 months. Thank you.
Ma'am, you need to unmute yourself.
Yes, sir.
Dr. Hari, can I put any question?
Sir, please go ahead, sir.
I want to know why it is titled as a black sheep.
Sir, melanoma. Dr. Soumya, you want to answer?
Melanoma mainly maybe because it's a skin lesion, which probably looks like black sheep head presentation. But yeah.
I was wondering where to connect this black sheep.
I can explain the reason. The second talk is about pediatric tumors. So
okay.
It's petting the baby. So
petting the baby. That is a very nice name. I think title given by Hari or
when I was thinking of petting the baby, then what came into my mind was Baba Black Sheep. So that's why I named it this.
No, how I looked at it was, Dr. Harishankar, melanoma, it's a mole, a black
color.
First of all. And also black sheep, it itself is a metaphor. It usually shows, talks about something which doesn't measure up or something negative. It's not a something which you give as a compliment. And if you look at melanoma and other cancers, melanoma is the one which can be most easily seen. It's on the skin and it is so thin and it doesn't look like cancer. It's not like growing as a mass lesion.
Maybe that suits.
Yet we have such big metastasis inside which sometimes cost life. I mean, so in that true sense, when you compare it to all other cancers, it has a black sheep connotation is what I felt, and also the color matches. So we can move forward, and Dr. Lakshmipati, if you could introduce the next speaker.
Yeah,
can we show one quiz question now, because it is raining?
Please proceed.
The judges have already finalized the top 3 prizes of Professor Arkat Gajraj Award. And in addition to that, we are also giving 10 more prizes. So 13 prizes totally, and 20 questions, quiz questions, and 5 separate questions for technologist quiz. It will be coming at the end of the session. Dr. Arun?
Yes, sir. So before we move on to question number 13, I'll announce the winner for question number 12. It is Dr. Madhur Srivastava, and the answer was celiac axis. So quickly on to question number 13. I think by now everyone knows how to answer. Being a Yuva session, we expect a lot of youngsters to be present, and it's kind of fast finger question. So whoever answers it fast and correct obviously gets the prize. So we have the question here. It's a transplant renogram. Have a quick look at the images. Okay. These are the template images. Once again, if you want to see. Okay. Now the question is, give your diagnosis. Normally functioning graft, acute tubular necrosis, graft rejection, or graft outflow obstruction. If you want to have a quick look at the images. Okay. That's it. Thank you.
Sir, please take over, sir.
Okay. Can I see the display of the next speaker? Betting the, yes, Dr. Tansir, NTK, Consultant Nuclear Medicine from MER Cancer Center Research Institute, Kerala. So I request Tansir to proceed his topic for presentation. Yes, Tansir. Go ahead.
Welcome all. Topic of my presentation is role of PET-CT in pediatric tumors. Pediatric cancers behave differently from adult cancers. Types and treatments are also different. Most pediatric cancers are highly curable. Radionuclide imaging in pediatric cancer should be used wisely because of concern of radiation exposure. Oncologic indications of PET-CT include staging, restaging, response assessment, biopsy site planning, end of treatment evaluation, and confirmation of a discrepant finding on other studies. The most common cancer in children is blood cancer. Second commonest being the brain tumor. A lymphoma consists of a third most common pediatric malignancy. Hodgkin's lymphoma seen in 55%, usually seen in older children and adolescents, classically involving contiguous nodal groups. The overall 5-year survival rate is 91%. Non-Hodgkin's lymphomas usually seen in less than 9 years of age. Burkitt lymphoma is the most common, followed by lymphoblastic lymphoma, DLBCL, and anaplastic large cell lymphoma. 5-year survival rate is about 72%. And Burkitt lymphoma and DLBCL are treated using Burkitt lymphoma treatment protocol. And lymphoblastic lymphoma is treated like ALL, and anaplastic large cell lymphoma has a separate treatment protocol. FDG has a role in response adaptive treatment to maintain the cure rate of more than 90% in Hodgkin's lymphoma and to reduce the treatment-related morbidity and mortality. Because of radiation has 14-fold increased accumulators for second malignancy in or around the field of radiation, like breast cancer, thyroid malignancy, and sarcoma. So use of radiation therapy can be limited or avoided in children demonstrating early response to chemotherapy on FDG PET. So Hodgkin's lymphoma is classified into low, intermediate, and high risk based on the PET-CT finding and presence or absence of B symptoms and bulkiness of the disease. So low risk include non-bulky disease stage 1A or 2A, and high risk include stage 3B or 4B, and rest are included under in intermediate risk group. So according to the Euronet Pediatric Hodgkin's Lymphoma Study Group, they have a certain recommendation for treatment of Hodgkin's lymphoma. They have divided into 3 treatment groups based on the stage of the disease. Treatment group 1 includes stage 1AB or 2A. Treatment 2 group 2 for stage 1EAB, 2EA, 2B and 3A, and treatment group 3 for 3EB, 3EAB and 3B for AB and B. Then treatment group 1, for treatment group 1, they suggested 2 cycles of OEP regimen chemotherapy and follow-up and assessment using FDG PET. If the PET is showing adequate response like duals 1, 2 or 3 and no need of radiotherapy, and dual inadequate response, then radiotherapy is indicated. And for treatment group 2 and 3, they suggested 2 cycles of OEP regimen chemotherapy, and for treatment group 2 cycle of COPDAC, and for 3 cycle of COPDAC, and reassess using FDG PET. If the patient has adequate response, no need of radiotherapy. If the response is inadequate, then radiotherapy is indicated. But in the most of the centers in India using ABVD regimen protocol for treatment of Hodgkin's lymphoma because of concern of cost. Then there is no role for surveillance FDG PET. This is a 13-year-old girl with Hodgkin's lymphoma. This underwent staging PET in August 2021. There's multiple hypermetabolic lymph nodes in the bilateral cervical region and mediastinum. And in RIM-PET, after 2 cycles of ABVD shows dual 4 lesion in the left level for cervical region, because she had some treatment interruption because of COVID infection in between chemotherapy. So then she received 2 cycles of escalated BIACOP regimen chemotherapy, and of PET shows complete metabolic response. And coming to the next malignancy, neuroblastoma, it is the most common malignant extracranial solid tumor in children. It arises from the primitive neuroblast of the embryonic neural crest, and 50 to 60% of children present with metastatic disease at presentation. And it causes the 15% of pediatric deaths from the oncology causes. Imaging plays a crucial role. The indications of radionuclide imaging include confirmation of suspected neuroectodermally derived tumors, staging, therapy planning and assessment of response, follow-up after treatment, and before planning radionuclide therapy. There are guidelines on nuclear medicine imaging neuroblastomas. Then International Neuroblastoma Risk Group Staging System has 4 stages. L1 means localized tumor not involving the vital structures. L2 means loco-regional tumor with the presence of 1 or more image-defined risk factors. And M means distant metastatic disease except MS. MS means metastatic disease in children less than 18 months with metastasis confined to skin, liver, and or bone marrow. So treatment depends on the stage of the neuroblastoma. MABG has high sensitivity and specificity for neuroblastoma detection, but 10% of neuroblastoma does not demonstrate MABG uptake. And a mixed pattern of uptake is possible with the foci of MABG avid and non-avid areas in the primary as well as metastatic lesions. And initially, MABG avid neuroblastoma can lose MABG avidity after chemotherapy while retaining their malignant potential. Small lesions, especially those showing low-grade uptake, may be missed if they are smaller than the resolution of a gamma camera. So in these cases, FDG has a role. FDG has a complement role, especially in negative MABG scan. And intensity and extent of FDG uptake is useful for tumor characterization and prognostic assessment. Older patients with advanced stage or MIC and amplification usually shows higher FDG uptake. Progression-free survival is negatively related to the primary tumor Cmax and tumor to background ratio on pre-therapy FDG PET-CT images. Somatostatin receptor PET-CT imaging. Somatostatin receptor are expressed in 77 to 89% of neuroblastoma cells. And experience suggested that sensitivity of gallium-68 DOTA peptide PET-CT is higher than MABG scintigraphy for staging. and restaging of neuroblastoma. MABG of deletion show higher SSTR expression than non-MABG of deletions. Well-differentiated neuroblastoma shows a higher SSTR expression followed by poorly differentiated and undifferentiated neuroblastomas. And SSTR expression in ganglioneuroblastoma and ganglioneuroma is lower than neuroblastoma patients. And DOPA is one of the best PET alternative to MABG for evaluation of neural crest tumors. And the preliminary study has shown that overall DOPA PET is superior to MABG planar scintigraphy. Then 18F metafluorobenzyl guanidine has similar biodistribution to I-123 MABG with much faster blood clearance. In a pioneer study, 5 patients with recurrent neuroblastoma, 18F MFBG has significantly higher sensitivity than MABG scan. Then C11 hydroxyephedrine, it is a catechol analog. Disadvantage include prominent activity in the liver and urinary tract and less sensitive and has very short half-life of C11. This is a 5-year-old female child with neuroblastoma referred for FDG PET CT staging. There is intense FDG of the lobulated lesion in the left suprarenal region with multiple areas of necrosis and multiple retroperitoneal lymph nodes. This is another case, 8-year-old male child, neuroblastoma post-surgery, post-multiple chemo and bone marrow transplant. Child complaint of pain in the skull, and on FDG PET there is non-FDG of the lytic lesions in the right frontal bone and multiple mixed light sclerotic lesion in the skeletal vertebra. And this child underwent FDG PET, gallium-68 DOTA PET CT and found a multiple somatostatin receptor expressing metastatic skeletal lesions. And coming to the next malignancy is Langerhans cell histiocytosis. Most common between 1 and 3 years of age, and the clinical cause varies from self-limiting disease to rapidly progressive disease that may lead to death. So prognosis and treatment options vary depending on the extent and severity of the disease. So accurate risk stratification and diagnosis is essential, as management can range from watch and wait in a single system lesion at low risk for CNS involvement to intensive chemotherapy regimen for multi-system high-risk disease. What is the role of FDG PET? It is the only investigation which gives a functional assessment. It's indicated in baseline for evaluation of response to therapy and reactivation. It identifies all active site of disease and exclude active disease even if bone scan is positive. And PET-MR may be better, especially for brain and spine. MR and CT alone may show lesions, but this has no relationship with the activity. Lesion may be inactive following therapy, but no morphological changes. So size may not change quickly. And bone scan shows osteoblastic activity, which is a response of bone, may be negative in early stages and maybe show high uptake in reparative stage. So bone scan doesn't correlate with the disease activity. SCV max level may give quantitative assessment. This is a 5-year-old female child with LCH. There is a lytic lesion with a soft tissue involved in the left base occiput and occipital condyle. This is a follow-up PET CT after chemotherapy showing complete response. Sarcoma is arising from the connective tissue cells and generally classified as bone or soft tissue tumors. FDG has role in staging, response, and recurrent evaluation. Localized tumor has event-free survival rate close to 70%, and metastatic disease has a poor prognosis with overall survival between 10 and 40%. And osteosarcoma is the most common sarcoma and malignant primary tumor of the bone in the pediatrics. The most common metastatic site is lung, followed by the bone. And FDG PET has increased sensitivity, specificity, and diagnostic accuracy or bone scan for detection of skeletal metastasis. And ratio of SU max at diagnosis to that following neoadjuvant chemotherapy can predict the histologic response in patients with osteosarcoma. High SU max following NACT is associated with poor overall survival. And Ewing sarcoma is the second most common malignant tumor of bone in the pediatric population. And unlike osteosarcoma, tumor can metastasize to other soft tissue site as well as the bone marrow. This is a 10-year-old female child with Ewing sarcoma of the left scapula. There is a lesion in the primary lesion scapula and metastatic lesions in the right proximal femur and few vertebrae. And rhabdomyosarcoma is the most common soft tissue sarcoma of pediatrics and adolescents. Low risk has an excellent prognosis with event-free survival of 90% and high risk has a very bad prognosis with the EFS less than 30%. WHO classification of RMS like embryonal, which is the most common type, followed by alveolar, botryoid, pleomorphic, and spindle cell. And FTG has a role in the evaluation of nodal metastasis and marrow metastatic lesion in the RMS. This is a 14-year-old female child with a RMS. There is a lesion in the intensely FTG of the lesion in the posterior part of her proximal forearm and enlarged right axillary lymph node and metastatic marrow lesions, which is proven by biopsy. And coming to non-rhabdomyosarcoma, soft tissue sarcoma, synovial sarcoma, desmoplastic round cell tumor, and malignant mixed peripheral nerve sheath tumor, they have a role of FTG PET. Other indications include Wilms tumor, germ cell tumor, hepatoblastoma, brain tumors, neuroendocrine tumors, and insulinomas. This is a 1-year-old female child with right renal mass showing moderate FTG uptake. There is a 1-year-old female child with evaluated for hypoglycemia. There is a DOPA avid lesion in the unstable pores of pancreas. Conclusion: PET-CT is very important in the non-invasive evaluation and treatment monitoring of many pediatric cancers, and radiation is a concern in pediatrics. PET imaging, which can reduce by latest PET-CT technology. PET-MR is very promising in pediatrics. Thank you.
Dr. Tansir, very good presentation. I really liked your presentation, all the illustrative. I want to know how you manage this between toddlers between 3 and 5 years of age. How you position them in the PET-CT? They do not cooperate and they will jump.
Before giving the appointment, we send the patient to anesthesia department, and they will see the patient, and they will come for the anesthesia.
That's very nice. We tried our oral, the cough syrup and all, they never sleep. They make us to sleep, they will be jumping.
Yes, sir.
Anyhow, it's a very beautiful coverage of the pediatric, and it's a good petting of the pediatrics. Nice.
We have our clinical hematologist and the head of bone marrow transplant unit of Meenakshi Mission Hospital as one of the chairpersons. Dr. Kasi, sir, you want to give your inputs?
Yes.
Sir, you will have to unmute yourself, sir.
Hi, everybody. Dr. Tansir, that was a very good presentation. You covered it very well, the short time span. As the presenter pointed out, the Hodgkin's lymphoma is very much useful in deciding the treatment. If there is a very good early response, we can cut short the chemotherapy cycles, as well as it will help us guide to give radiotherapy to larger bulky lesions or residual lesions. And it's evolving, especially neuroblastomas. It has a role in deciding refractory patients to help us decide in further therapy, even after they have relapse after post bone marrow transplant.
Yes, sir.
So, Tansir, can I ask you a quick question? If you have iodine 131 MIBG, you have FDG, and you have Dodanoc, which would be your first choice in a child with neuroblastoma?
Gallium-68 Dodanoc PET-CT, sir.
Okay, thank you. Before we go to the next talk, can I ask our quiz master, Dr. Arun, to go ahead with the quiz question?
Sure.
So before we move on to question number 14, I'll announce the winner for question number 13. It is Mr. Arun, and the correct answer was graft rejection. Okay, so again, I think everybody knows straight away to the question. It's a slow video, so I'll play it maybe once or max twice. Have a careful look at the video. CT first. Once again, just have a look at the relevant parts of the lesion. Okay. So this is the PET-CT part of the video. Okay, I think everybody is ready with the diagnosis. Okay, so these are the choices. Identify the pathology: the ruptured pericardial cyst, teratoma, thymic carcinoma, or a mediastinal lymphoma post chemoradiation. Okay, just show the relevant part of the video. Okay, I think that's it. Thank you.
Good.
Can we have the CV of next? Yeah.
Dr. Maitri, you want to introduce him?
Yeah, sure. Sir, actually for our hospital about the pediatric, we have a conscious sedation protocol. Anesthesiology comes and takes over. Just like CT contrast protocol, that's another protocol you might be fine. And on the question on the MIBG, I think it's mainly the cost and availability. We used to use that a lot more previously. Now with DOTA, I think it's very hard to do one-on-one comparative studies also, mainly because it's so difficult. You have to order it and once a month or once it comes. So moving on, we after singing Baba Black Sheep and petting the children, we can now go play some cricket, some sixers and fours. I actually don't know what this CXCR4 means. I googled it. It says it is a receptor which directly controls cell proliferation of non-hematopoietic cells. So Dr. Arun Prashant, working in Miyot International Hospital from Coimbatore Medical College, he will enlighten us more with on these CXCR4. So.
Thank you for the introduction. I am Dr. Arun Prashant, and my topic today is 6S and 4, CXCR4. And let's start with the question. What do you know the common link between HIV, cancer metastasis, tissue regeneration, stem cells, myocardial infarction? Do you know there is a common link? And if there is a common link, what is the link? Can anyone take a guess? Yeah, that's right. Now the topic of my presentation is CXCR4 and the CXCR4 CXCR12 axis is the answer for the question. So in this presentation, we are going to see about the mechanism of the axis, what are the implications of the axis on clinically, and various studies results, as well as the images from our department, as well as the summary and take home. So what is CXCR4? CXCR4 is basically a cell receptor, cell surface receptor. That's it. It is a transmembrane receptor. As you can see in the image, this transmembrane receptor has 3 intracellular and 3 extracellular domains. It has a intracellular C terminus, extracellular N terminus. It is simply a receptor. And what is CXCL2? It is in the name. The name is a giveaway. L has a ligand in it. CXCL2 ligand is a receptor is CXCR4 and the ligand is CXCL12. So what is so special about this is this receptor and ligand in chemokines there are multiple chemokines, and the chemokines act on various numbers of receptors. Even the naming of this is based on cysteine. For example, one C is cysteine, the other C is cysteine, and the X is the amino acid in between the cysteines. That's how the naming system is there. So this mechanism is special. What is special about this mechanism? The specialty is that CXCL2 is a canonical ligand for CXCR4, which means that it is only a biunivocal ligand. There are no other ligands which activate this receptor, and there are no other receptors which match this ligand. This type of unique combination is quite rare in chemokines, and this combination is used to exploit a lot of things which we'll discuss. The first and most important is we need to see where the receptors are located and where the ligand is located. Then we can see about the function of them. So CXCR4 is a universal receptor, which means it is seen in hematopoietic cells, stem cells, endothelial cells, neurons, bone marrow, liver, spleen, kidney, brain, any organ you name it, it has a CXCR4 receptor. Cells have the receptor. CXCL2 is basically seen in bone marrows, and it is secreted by the hematopoietic cells, especially in the bone marrow as well as in the bloodstream. It is seen in the bloodstream. It is also released at the site of infection, stress, inflammation, everywhere. So here we see the cellular structure of the pink transmembrane, as you have already seen, is the CXCR4 receptor. And this yellow diamonds, yellow hexagons are the ligands, CXCL2. When the ligand sits on the receptor, what happens? The same thing which usually happens whenever a receptor ligand interaction happens. Downstream activation of cascade of events. This RAS, RAF, MERK seems familiar because it is the sorafenib or the lenvatinib which acts on the tyrosine kinase pathway. The mTOR is the everolimus inhibitor. Everolimus is the inhibitor of mTOR, and this pathway is also activated. There are multiple other DA3, IP3 pathways, JAK-STAT pathways, and NF-kappa beta. These pathways result in transcription of the cells, and this transcription leads to proliferation, angiogenesis, cellular migration, chemotaxis, and this type of situation leads to immortality of cells. Basically, the cells can survive longer because these are all growth factors for the cells. For example, NF-kappa beta inhibits the apoptosis. So it leads to immortality. What are the functions of this axis? The main function starts with the homing of HSPCs. HSPC is hematopoietic stem cells, peripheral cells. Homing, what is homing? Everybody has a special bond for their home. Wherever we are, we tend to come back to our home one day or the other. So similarly, stem cells start from bone marrow, hematopoietic stem cells. This bone marrow stem cells go into the peripheral circulation, and homing is the process where these cells come back to their original place. Like, for example, when there is a high concentration of CXCL2 in the bone marrow niche, the stem cells come back to their own position. Next is proliferation and survival. The survival is dependent on this axis because even the baseline homeostasis is dependent on CXCL2. This receptor ligand interaction leads to survival and immortality, as we have already discussed. Even new vessel formation is based on the hypoxic induced fracture. Whenever there is hypoxia, this axis comes into play. Chemokines are secreted. This attracts a lot of stem cells from the marrow. This leads to proliferation of vessels. What happens? The same thing happens inside a tumor. Tumor leads to metastasis and proliferation of tumor. It gives immortality to the tumor cells because tumor cells are also kind of a stem cells. It has a similar properties. It has unlimited growth potential. It has unlimited differential capability. So this axis plays an important role in oncology. For example, let's take an example of a myocardial infarction. It is a double-edged sword. Numerous studies have shown both the protective effect as well as detrimental effect. Protective effect in the form of stem cell recruitment. For example, if there is an MI and the ischemic area needs healing, stem cells are recruited and it differentiates into fibroblasts and mesenchymal cells, which leads to healing. However, this also leads to interfering with the re-endothelialization. For example, neoangiogenesis happens, and some studies have shown that it leads to detrimental effects. MI, there is a double-edged role. We don't know for sure yet. But what we know for sure is in HIV, because this receptor was first seen in HIV. When this HIV enters into the T cell, this CXCR4 acts as a co-receptor. And based on that, the discovery and acceleration of CXCR4 took place, because they were thinking they have found a way to stop the HIV cells entering into the body by stopping the CXCR4 axis. However, it did not materialize, but it gave rise to other wonderful scenarios where CXCR4 is helpful. For example, in inflammation, see, leukocytes are potent expressors of CXCR4, and the ligands of CXCR2-12 leads to chemotaxis. For example, whenever there is a site of injury or some infection or bacterial inflammation, whatever happens at a peripheral site, chemotaxis occurs. Chemotaxis is the migration of leukocytes or dendritic cells and other immunocapable cells into the site of injury. This chemotaxis is mediated by this axis because lot of chemokines are secreted at the local site. This circulation of chemokines acts on the leukocyte receptors, which leads to migration into that site of inflammation. So why tumor? Because tumor is a wound that never heals. It is similar to a wound. It has all the properties of wound. In fact, it is so much similar to a wound that the fibroblasts, cancer fibroblasts, are being studied by the FAPI study. The FAPI acts on the tumor stromal cells. It is similar to inflammation. It's similar to healing. The thing is, it never heals. And how the CXCR4 axis plays a role in cancer is by decreasing apoptosis. As we have already discussed, in the NF-kappa beta prevents the apoptosis of cell. It also increases the proliferation of cell, angiogenesis, and even it causes metastasis. The migration of cells from one region to other. For example, the homing. What happens if myeloma or lymphocytics, where there is a stem cell mutation, any hematopoietic malignancy? If the CXCR12 axis is activated, this axis leads to movement of cells from the peripheral circulation into a bone marrow niche, which means it is going to do a bone marrow deposit, which leads to metastasis. So in cancer and oncology, this axis plays a major role. So if it plays a major role, then we can stop it based on, we can start with medication. Yes, Pentixafor and Plerixafor. Plerixafor, these are second generation small molecule antagonists. These receptor antagonists are so specific that even a slight modification in structure leads to loss of affinity. Because as we have already discussed, CXCR4 and CXCR12 are so tightly bound. It's like they are made for each other. This Pentixafor, it has been labeled with copper, F18, technetium. First generation has been labeled with technetium and iodine. This Pentixafor is a second generation antagonist. The majority of the studies have been focused on gallium-68, but labeled Pentixafor. Pentixafor is a CXCR4 antagonist. And now there are small molecule, like in PSMA, first generation, second generation, third generation, we have small molecule urea-based, thiol-based. Now we have small molecule PSMA antagonists and even GUL PSMA. Similarly, currently we are in second generation with Pentixafor. However, majority of studies are done with the Pentixafor, so we'll proceed with Pentixafor. Plerixafor is actually an FDA-approved drug for the treatment of myeloid leukemia, AML, because in leukemia, the same thing of homing happens and we need to prevent the homing. What is this 175 versus 8? There are currently 175 registered clinical trials for Plerixafor, whereas only 8 for Pentixafor. This shows that there is a huge potential for studies in the diagnostic part of the imaging. Therapeutic part, it's already taken care of. There are a lot of studies going on, whereas the diagnostic part of it is still lacking. Coming to inflammation, in myocardial infarction, as I've already told, while the healing studies have been done, and it has been shown that concentration in LVEF after healing leads to a correlation of LVEF outcomes. Basically, it is an independent predictor of outcome. If CXCR4 is concentrating, it will lead to better EF. Atherosclerosis, for example, it can visualize the plaques, even it can differentiate between stable and unstable plaques compared to FDG and F18 imaging. Idiopathic pulmonary fibrosis is a condition where the stem cells are recruited and leads to fibrotic factors in the lung. This imaging studies have been done and has been shown that it is very sensitive for early detection. It is also used to evaluate the response for therapy. Next is the infection imaging. This chronic osteomyelitis, UTI, COVID, studies have been done in these conditions to find out the expression of CXCR4. For example, leukocytes are the major driver in osteomyelitis, any form of infection for that matter. However, in chronic infections, neutrophil level decreases and lymphocyte level increases. This leads to, when WBC labeling is done, this ratio difference leads to some false negative results. Why not label directly the lymphocytes or all the leukocytes with CXCR4? Because they are already expressing CXCR4. You label the antagonist Pentixafor, it directly leads to infection imaging. There is no need for additional imaging with WBC. Let's start with an example of infection imaging. This is a normal distribution of, this is a blood pool, excretion of the tracer through the kidneys. Spleen shows the highest uptake apart from the excretion bladder. Here, this is a 59-year-old gentleman, had a complaints of left knee pain, and the transplant, total knee transplant replacement has been done. And the patient complained of pain in the process is decreased range of movement. When a study was done to find out infection, we can clearly see there is a focus of uptake. In the sagittal and axial images, we can clearly find that the tracer is concentrating around the lesions. So a diagnosis of infection made, even we can see some there are some lymph nodes out in the left inguinal region. But after a surgery, the patient has been operated and is afebrile, the counts are low, and patient is fine now. They have done arthrodesis, they have fused both the joints, and the process has been reviewed. Coming to our major oncology, hematological malignancies, as I've already told you, CXCR4 axis plays a major role. Even in solid tumors, there have been studies. However, the studies have been erratic because some studies show better uptake compared to FDGs, but most of the studies show equal or even less uptake or less number of lesions being picked up, because this might be due to the tumor heterogeneity and heterogeneity of the lesions in the CXCR. Coming to multiple myeloma case done in our department, this is a stage 4 myeloma. We can see some extramedullary deposits here in FDG. When we did a CXCR4, there was a slight uptake in the CXCR4. Marrow also shows some uptake. It's not very good as compared to the FDG. FDG was better in this case. Another patient, 60-year-old male with multiple myeloma, he had a stage 4 disease. We can see there are some focus of uptake. Both shows bone marrow lesions. However, there are active marrow lesions more in the CXCR4 compared to the FDG. This case is a 70-year-old male with multiple myeloma. He had a stage 3B disease. If we see the FDG, there is diffuse uptake. However, the lesions are not quite clearly visualized. But if we see the pentexi4 images, gallium images, we can clearly see there are multiple foci of uptake. Okay, this is a case of a 59-year-old female. This patient had stage 3 disease, IgA gammapathy. The patient has been treated with chemotherapy, 2 cycles. She came for pre-transplant evaluation. We can see some slight bone marrow uptake here in the FDG images. So we thought we'll do a pentexi4 image. And because this sagittal images also show no much change in the spine. But when we did the pentexi4 images, we can clearly see it is simply like a bone scan, extensive marrow involvement. This patient had in sagittal images, we can see at similar levels of intensity, excellent uptake in the marrow. The plasma cell percentages was 80% in the bone marrow. Patient was deferred, the stem cell transplant was deferred, and patient was kept on further chemotherapy. AML studies have been done, PET-MR studies have been done in AML. The upper row shows excellent uptake of marrow. AML is usually not imaged. However, with pentexi4, we can image the AML. This lower row shows no uptake. This is the difference between the AML positive and negative patients. Coming to NHL, the role of pentexi4 has been extensively studied in NHL. Any type of lymphoma, lymphocytic lymphoma, marginal zone follicular. As you can see, most of the things, the pentexi4 has some good uptake. However, for example, in follicular and other type of lymphomas like NK T cell lymphoma, here FDG shows a better uptake. The differentiation between FDG and pentexi4 is not because of the tumor mechanism, because some cells might be also because of therapy, tumor heterogeneity, multitude of reasons. Because not all multiple myeloma patients shows FDG and not all multiple myeloma patients show pentexi4. There is a spectrum of changes between them. Yes, of course, you are thinking about theranostic, because as you have seen excellent uptakes in like this in images, you will obviously think about the therapy part. That is actually people will have tried therapy for pentexi4 based on pentizather. Pentizather is the lutetium labeled, similar to pentexi4. This is endoradiotherapy, patient with FDG, pentexi4 images. You should see after 14 days, excellent response. Entire marrow disease has been wiped out by the lutetium. This not only in one patient, multiple dozens of patients, 2-3 dozens of patients have been treated with pentoxacin. The only problem is current till now is the bone marrow toxicity. But since stem cell transplant is being done for those patients, it is not an issue. No other significant organ toxicity in dosimetry was found. Coming to the final take-home points, CXCR4 axis. CXCR4 is simply a receptor. CXCR12 is a ligand for that receptor. The axis is involved in chemotaxis, homing, inflammation, and metastasis. The gallium pentoxy-4 is used for imaging of hematological malignancies and inflammation, whereas there is a high potential for theranostics with pentoxacin. Thank you for this opportunity.
Yeah, very nice talk. Can you hear me?
Yes, ma'am.
Okay, I cannot turn on the video, I think, for some reason. Anyway, very nice talk, Dr. Arun. Actually, you know, I frequently we all, I think, tell our patients, cancer is something which you can control. There's really not, it's not in a phase where we can say it's curable. And what we don't know about cancer is so much more than what we actually know as of today. And it's good to see all these new markers. I think that is where nuclear medicine will grow significantly in theranostics, where you can even diagnose and treat with newer markers and such. So all such 6s and 4 scores, I think, will help us bridge this gap between what we know and what we don't know. And you know, with all the new recent research advances. So thank you for that. I was also curious to know about the cost and availability of it. How many centers are doing this in India as of today? You know.
Ma'am, Pentex4 is available from vendors. It can be wherever there is gallium generator, we can do Pentex4. The cost of scan is similar to other gallium scans. And the cost of peptide is marginally less comparative to the peptide DOTA or PSMA tracers. It is available, ma'am. Currently, wherever the centers doing gallium scans, we can order the peptide and we can do the scans. The most usefulness as
in-house labeling, you label it in-house or it comes free?
I'm sorry, ma'am. I couldn't hear the question.
No, it's in-house labeling, right? So you order the peptide and you label it.
Yes, ma'am.
How much time does it take?
Ma'am, we have automated synthesizers where we can label with lutetium, gallium, all type of PSMA, DOTA, Pentex4, extendin, everything can be labeled. So if any center has semi-automatic or automatic, fully automatic synthesizer, easily it can be done.
Doctor, yes, sir, please go ahead.
I want to appreciate Dr. Prashant. He is a super nuclear medicine physician in Chennai available. I really amazed to see his the background, and he has done a DM in nuclear therapy. I think it's the first time I'm hearing our specialty has gone to the DM level, and he deserves, and he is. I'm very happy. I brought him for this forum. You are. I am really excited to see his presentation. Is wonderful presentation. Thank you, Dr. Prashant.
Two quick comments I'd like to make regarding what Dr. Maitri Shankar ma'am asked. All the sponsors of our conference are actually supplying CXCR4.
Okay.
So, all the persons who are supplying for CXCR4 have contributed this to this conference also. And Dr. Arun, I must say that you have hit so many 6s and 4s that you are now reached double century and not out. Thank you. It was an excellent and brilliant talk.
Brilliant. Thank you for the opportunity, sir. Thank you, everyone, sir.
Arun, can you please go ahead with the quiz?
Yeah, please. So we move on to question number 15. Before that, I'll announce the winner for question number 14. The correct answer was teratoma, and the winner is Dr. Santosh. Everybody knows how to answer the quiz. Question is, it's a 5-year-old boy with a history of high-grade fever and abdominal pain. Urine culture shows growth of E. coli. Have a quick look at the images. Everybody knows it's a DMSA scan. I will look at the images. Now here is a question. Once again, the options. DMSA is contraindicated during acute pyelonephritis. DMSA is a chelator. DMSA is useful in identifying hypertrophic columns of Bertini. DMSA for applications is DMSA 3.
They have to choose the wrong answer.
Yeah. Which among the following statements is wrong? Okay. I think that's it. Thank you.
Can we have the CV of the next person?
Okay. This is Ram Kumar, Registrar, Kovai Medical Center Hospital, nuclear medicine physician. So his presentation, I will proceed because of shortage of time. Please go ahead, Doctor.
Good afternoon to one and all present here. I'm Dr. Ram Kumar. I am extremely thankful to Dr. Kamleshwaran and Dr. Harishankar for providing me this platform. And my topic today will be pipes and tank, the role of PET-CT in urinary bladder and ureteric malignancies. These are all the various guidelines available for the management of urinary bladder and ureteric carcinoma, and my presentation will be based on it. A small introduction. Urinary bladder and ureteric carcinoma by default mean urothelial carcinoma or transitional cell carcinoma because of its 95% dominance over the other subtypes. Likewise, though TCC can arise anywhere from kidneys to urethra, more than 95% of TCC arise only from bladder. Ureteric TCC is very rare and its presentation is similar to bladder TCC. So by default, transitional cell carcinoma means urinary bladder transitional cell carcinoma. Staging of carcinoma bladder. The four histological layers of urinary bladder are namely lamina propria, muscularis propria, detrusor muscle, and adventitia. And detrusor muscle infiltration is one very important factor which determines the treatment of carcinoma urinary bladder. For treatment purpose, carcinoma urinary bladder is divided into three subgroups: non-muscle invasive bladder carcinoma, non-metastatic muscle invasive bladder carcinoma, and metastatic muscle invasive bladder carcinoma. The common investigations used for staging start with cytology and investigation for hematuria, then cystoscopy followed by transurethral guided biopsy, single most investigation, MR and CT pelvis including abdomen for upper urinary tract evaluation, CT thorax, bone scan, and FDG PET-CT all are used for metastatic workup. Coming to the first entity, the non-muscle invasive bladder carcinoma, which represents 80% of all cases. Very good prognosis, no infiltration of detrusor muscle. The risk of recurrence is also low. The treatment in this subgroup is curative, which is TURBT followed by intravesical BCG. Then, what is the role of imaging in this particular subgroup? Only one indication, that is to ensure no multifocal tumor is present in the upper urinary tract, and for which CT urography is used. Do FDG PET-CT have a role in this subgroup? Yeah, maybe. If the pathology turns out to be high-grade non-muscle invasive bladder carcinoma, because of its recurrence rates, metastatic workup need to be done, for which most of the guidelines recommend CT thorax. But in the same clinical situation, in view of higher recurrence, NICE guidelines from UK suggest FDG PET-CT can be used in the baseline itself. Coming to the second entity, the muscle invasive bladder carcinoma. Muscle invasive bladder carcinoma can be divided into two distinct subgroups, the non-metastatic one, which includes stage 2 and stage 3 disease, for which curative intent is still possible, with radical cystectomy and pelvic lymph node dissection being the standard of care. And the second category, which is metastatic muscle invasive bladder carcinoma, in which only palliative chemotherapy is possible, with systemic cisplatin being the standard of care. What is the role of imaging in this subset? Imaging in this subset has to answer about T-staging with respect to muscle invasion and extravesical infiltration, the lymph nodal spread, the tumor spread to the upper urinary tract, or the multifocality in the upper urinary tract, then the distant metastasis. Okay. Do FDG PET-CT have a role? Yes. If FDG PET-CT has to be considered a good imaging modality, FDG PET-CT has to answer all the above mentioned parameters. Let us see. First is T staging. Advent of multiparametric MRI and diffusion weighted imaging has offered MRI better soft tissue contrast. Because of this property, MRI is better than CT in assessing muscle invasion and perivesical fat infiltration, thus making MRI the imaging modality of choice for local tumor staging. But several studies have also investigated the role of FDG PET-CT in tumor staging. However, it is important to be aware of the pitfalls, the main pitfall being the urinary FDG activity interference with T staging in the genitourinary region. But is that all? No. FDG PET-CT can still stage the local tumors in urinary bladder. Multiple interventions have been tried, but the most commonly used intervention is the use of LASIX and then taking delayed images after LASIX. There are two rows of images. The first row of images, the images occurred at usual 60 minutes after FDG administration, and we can't differentiate the FDG activity in the normal urinary FDG retention with the bladder tumor in the bladder. But after administration of LASIX and after voiding of the hot FDG urine, in the delayed images, we can see a focal FDG avid lesion in the right lateral wall, thus delineating the tumor from urinary bladder FDG activity. So, FDG PET-CT can also stage the local tumors in urinary bladder. These are all the modalities used for T staging. We can see in image A, that is CT showing a nodular growth. We cannot see the muscle clearly. And B, it is an MRI image. We can see multifocal tumors within the urinary bladder and also the white arrow pointing towards the enhancing component, that is the muscle, detrusor muscle. So MR clearly gives us information about muscle invasion. And the bottom series of images are FDG PET-CT images, which also is like the CT only. That is, we can see FDG avid lesion in the posterior wall of the urinary bladder, but we cannot see the muscle. So muscle invasion. The very primary argument urologists and oncologists use against FDG PET-CT is FDG PET-CT is unable to detect muscle invasion in carcinoma bladder cases. Muscle invasion is one of the important properties to determine the treatment strategy for carcinoma bladder patients. But yes, do we have an answer for muscle invasion right now, today, from FDG PET-CT? No, the answer is no. But will we have an answer in the future? The answer may be yes. Yeah. Dynamic PET-CT can give information about the status of muscle invasion. Yun et al. Employed a technique, a dynamic imaging, dynamic acquisition technique to predict about the muscle invasion. So he acquired three sets of images. One is early dynamic imaging, that is 10-minute imaging immediately after FDG injection, and that is reconstructed into 5-minute frames of 2 minutes, 5 frames of 2 minutes each. Then is regular imaging after 60 minutes, and third is delayed imaging. And the conclusion is increased SUV max in the first 2 frames of dynamic imaging showed a positive correlation with muscle invasiveness when compared with TURBT results. On the left-hand corner, you can see MRI showing muscle invasion. On the right-hand corner in the topmost image, you can see increased FDG uptake or increased SUV max in the first frame of the image. So this property is correlated with muscle invasiveness. So coming to lymph node staging, both CT and MR mainly use size criteria, which leads to high false negative rates. But in bladder carcinoma patients, metastasis usually involve metastatic lymph nodes without size enlargement. And these lymph nodes can be easily picked up by FDG PET-CT than CT or MR. So this is a study by Musa et al. In which he compared CT versus PET-CT in 300 patients for lymph node staging. And he found that PET-CT is superior when compared to CT, and also PET-CT clinically impacted more than clinically impacted the clinical decision in more than 68% of the patients. So in view of incoming evidence from various literature, multiple associations have started incorporating FDG PET-CT as a tool for lymph node imaging in their own guidelines. like NICE from UK and European Association of Urology. Distant metastasis evaluation. 12% of all bladder cancer patients present with metastasis at some point of their life. This is one area where there is a universal consensus that distant metastasis evaluation is best assessed by FDG PET-CT than any other modality. Kim et al. Demonstrated FDG PET-CT is better than CT, and FDG PET-CT alone changed the clinical management in 40% of the study population. And guidelines recommend FDG PET-CT in case of high-grade muscle-invasive bladder carcinoma or suspected local recurrence to estimate the metastatic burden. Recurrence detection. Like distant metastasis evaluation, this is one indication where FDG PET-CT has got no competitor. FDG PET-CT is winning hands down against CT and MR in cases of local recurrence. So this is an image depicting a local postoperative bed recurrence in postoperative bed post-radical cystectomy. And multiple studies have also demonstrated the superiority over FDG PET-CT over CT and MR. Response assessment. Response assessment after neoadjuvant chemotherapy may change the clinical management. That is, after response assessment, the patient can be divided into 3 groups. One is responders, non-responders, and progressive disease. Responders will go for cystectomy and other surgery. Non-responders will go for additional chemotherapy, and progressive disease will go for second line of chemotherapy. And this pattern is helpful, and this pattern is helping the patients in long term by helping the patients getting the right treatment. And this pattern of response assessment can only be assessed better by FDG PET-CT, because FDG PET-CT identifies the microtumor deposits and non-enlarged metastatic lymph nodes better than the anatomic modalities. And once again, there is a consensus among the clinicians that FDG PET-CT is better for response assessment than CT and MR. There are 2 novel applications of FDG PET-CT as far as muscle-invasive bladder carcinoma is concerned. There is an ongoing phase 2 trial, it is known as EFFORT MAPC, which intends to risk stratify the patients with muscle-invasive bladder carcinoma based on FDG PET-CT. So they basically divide or risk stratify into 3 groups, and they're trying to correlate the overall survival and disease-specific survival. And they tend to prove that based on this risk stratification, the treatment can be tailored according to the groups, and that will help improve the patient's outcome. And this is another application of FDG PET-CT as far as muscle-invasive carcinoma is concerned, bladder carcinoma is concerned. Immunotherapy as of now is changing the cancer management in every cancer. Likewise, pembrolizumab is one agent which is being used in muscle-invasive bladder carcinoma, but pembrolizumab is actually acting on the PD-L1 and PD-1 immune checkpoint. It is an immune checkpoint inhibitor. So there was a study which correlated PD-L1, PD-1 expression based on FDG uptake. The study concluded that high FDG uptake is directly proportional to PD-L1, PD-1 expression. This was conducted by Chen from China. I quoted the study, the top one. And this in turn is proportional to FD, that is, the study implies that FDG uptake is directly proportional to PD-L1, PD-1 expression, which in turn signifies the patients who show increased FDG uptake are candidates of pembrolizumab therapy. And this trait has been used in the PURE-1 trial, where pembrolizumab was given to metastatic muscle-invasive bladder carcinoma patients. Urothelial carcinoma or upper urinary tract malignancy, extremely rare. Guidelines and regimen remain the same except the type of surgery, like nephroureterectomy in place of cystectomy in upper urinary tract tumors. No guidelines recommend FDG PET-CT for staging, but 60% of urothelial malignancies are aggressive and present with local and distant recurrence. In those cases, FDG PET-CT can be offered even in the baseline, depending upon the clinical situation. But the disease is rare, and because of its rarity, there are no large-scale studies to reach consensus to supplement or to advise the use of FDG PET-CT in staging. And these are few of the non-FDG tracers: 11C choline, 11C methionine, and 11C acetate. Now all are investigational tracers, And availability and operational feasibility is also a factor. There is no large-scale data to give us some good credible evidence. And 18 of fluoride bone scan is being compared with the regular technetium MDP bone scan to evaluate bone metastasis in urinary bladder. The same thing, there is no large-scale data to give us evidence. But some pilot studies have shown promise about the role of 11C choline in reduction of local recurrence after TURBT. There is an image showing the focal uptake is of 11C choline showing recurrence after TURBT inside the bladder. But since the same thing, there is no large-scale data to support or give us credible evidence to take this forward. So the take-home message, if it is a low-grade non-muscle invasive tumor, no role of FDG PET-CT. If it is high-grade non-muscle invasive tumor, FDG is not mandatory, but it will be helpful in case-to-case basis. If muscle invasion is the parameter to be assessed, no, FDG PET-CT has got no role right now. In muscle invasive bladder carcinoma, T staging, MRI is the undisputed choice. Lymph node staging, distant metastasis, response assessment, FDG PET-CT scores better than MR and CT. And this has been helped by the guidelines and clinicians becoming more receptive towards PET-CT by incorporating the use of FDG PET-CT in various guidelines. If dynamic PET-CT is evaluated in large scale and if it gives more favorable results with regard to muscle invasion, then yes, FDG PET-CT do have a scope for being a one-stop imaging investigation in muscle invasive bladder carcinoma. Thank you to Ms. Alexandra, the founder of SciHub, for helping me in this presentation. Thank you once again.
Doctor, it is a very good presentation, no doubt. I got one doubt. What about a FAPI in bladder CAs? FAPI role?
Sir, regarding FAPI, sir, the FAPI is also getting excreted to the urinary bladder. So no large-scale studies have been done regarding the role of FAPI in the bladder. But we can do it in the future, sir. With some interventions and delayed imaging, we can do some studies and bring out some results.
And my another small doubt is technical. You said urinary bladder, you give the Lasix, then post-void study you would like to study. That is correct. But why Lasix? You can just empty the bladder and take, no? Because if it is ureter and pelvic health system, we will say Lasix is ideal. But for bladder, I don't think we need to give intervention of Lasix. Just post-void is sufficient.
Accepted, sir. Accepted.
Yeah, but it's a beautiful presentation. You covered it, everything. Thank you for your presentation. Hari, proceed next.
Thank you.
Thank you, chairpersons. Ma'am, would you want to ask some questions?
No, I think it was a very detailed, very specific, and these are very common clinical questions we get asked. So typically, we just many times it's very difficult to ask for the differentiation whether you need an MRI or PET without. Most of the time, it comes to us first, and then we typically end up ordering MRI. Many times, MRI is already done, but they don't refer to PET. If muscle invasion is a question, we can answer much better. I think those referrals also will start feeding in.
Yes, well covered.
Thank you, chairpersons. When we discussed about this UA session in our general body meeting, not the general body, sorry, executive committee, all the members of the executive committee strongly backed me. So I was having certain doubts. Sir, can you? Okay, when we had certain doubts if the youngsters will be able to live up to the mark, because it is a big event and we have seasoned nuclear medicine physicians who are sitting and listening, and we have faculties from top faculties from other other specialities also. But I can comfortably say that all expectations have been completely, I mean, you have gone way above the expectations. And you are not a practicing cricket team, you are a World Cup winning cricket team. So thank you, youngsters. Thank you, chairpersons. Before we move on to the next session, which is the PET session, I'd like to invite my colleagues, Dr. Paul Vincent sir, who is a senior consultant urologist from Meenakshi Mission Hospital, Dr. Krishna Kumar sir, who is a senior consultant and head of oncology, radiotherapy department of Meenakshi Mission Hospital. Sir was the brain behind the event. If we had conducted live event, you would have seen Sir more than myself during the event. So he was silently working from the behind and giving me all the inputs. So thank you very much, sir. And we also have our dynamic surgical oncologist, Dr. Vijay Bhaskar, sir, who will be joining as chairperson. Arun, do you want to show one quiz now?
I'll show a quick quiz question before we move on to the next session, if you permit.
Yeah, please go ahead.
Okay, so this is question number 16, but before that we need to announce the winner to question number 15. But before announcing the winner, yesterday Dr. Hari had mentioned that our conference had crossed 700 registrations, which is probably the highest number for our chapter conference so far. So it's a big congratulations to Dr. Hari and the team, and also courtesy to the online platform for such a great participation. So this opened up another possibility of getting overseas registrations also. And Dr. Hari was successful in getting quite a good number of overseas registrations, especially from Asia Pacific region, and a few registrations even from Europe as well. Now, why that is again a great commendable job from Dr. Hari and his team. Now, why I'm mentioning it at this point of time is because the winner of the previous quiz, that is quiz number 15, is Dr. Katie Veljanova. I don't know if I'm pronouncing it correct. Dr. Katie Veljanova. She is from North Macedonia. Okay, so North Macedonia, for anybody who does not know, it's a country in the Balkans, southeast of Europe. And basically the currency, since it's a cash prize is being given, Dr. Hari may please note the currency there is a Macedonian dinar. And one Macedonian dinar is approximately 1.4 Indian rupee. So the treasurer and the Dr. Hari may note that. So with that, congratulations to Dr. Katie. We will move on to question number 16. Okay, question number 16. Now everybody knows how to answer. It's a 50-year-old with a known case of old treated intra-abdominal malignancy complaining of back pain. You can see the MIP images. Now have a look at the video. I'll play the video. Sorry, I'll play the video again. Okay, there. Now have a look at the mark structure. The question is, identify the structure. The option is a celiac lymph node, esophagogastric junction, diaphragmatic truss, or a retrochoroidal lymph node. We want to have a look at the image again. Identify the marked structure. The options are celiac lymph node, esophagogastric junction, diaphragmatic truss, and retrochoroidal lymph node. That's it. Thank you.
So the chairperson can take over.
Good afternoon to everyone. Thank you, Dr. Hari, for the opportunity. I welcome you all to the PET1 session. There will be two talks in this. The first one is quite an intriguing talk, to poke or to see. Let me have the privilege to introduce the speaker, Dr. Shagos GS, who is the lead consultant, Department of Nuclear Medicine, Aster Medicity, Kochi. Madam did her graduation from Alapi Medical College and Diploma in Radiation Medicine from INHS Aswini, Mumbai, and further did DNB Nuclear Medicine from AIMS, Kochi. Madam heads the Department of Nuclear Medicine, Aster Medicity. Her areas of interest being imaging in movement disorders and targeted radionuclide therapy. And Madam is going to talk on the role of PSMA in the initial diagnosis of prostate cancer. Very interesting topic. Over to you, Madam.
Good morning, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to speak in this conference. Today, I'm asked to speak on the utility of PSMA PET-CT in the initial diagnosis of prostate cancer, to poke or to see. PSMA, prostate-specific membrane antigen, as we know, it's a transmembrane protein that is overexpressed in 90% of the prostate cancer cells. The functional hypothesis is that it's involved in folate transportation and metabolism, The extramembrane part of PSMA hydrolyzes the glutamated folate released by dying tumor cells, which is then taken up by the healthy prostate cancer cells, facilitating further cell proliferation. PSMA has a strong role as a driver of cell growth in prostate cancer. High levels of expression is associated with poorer prognosis, and PSMA expression is upregulated when castrate-resistant phenotype evolves. And PSMA-11 is the most common tracer that's used. There are n number of PET tracers that has been thought of which is used in PET-CT imaging, of which FDA-approved 68 gallium PSMA-11 is the most common one that is used. So in the next few minutes, we'll briefly touch upon biopsy techniques, the Gleason score and grading, the guidelines, and then go on to PSMA PET imaging as such. So what is the most common site that is involved by carcinoma in prostate gland? That's the peripheral zone. And transitional zone is the site that is most commonly involved in benign prostatic hypertrophy. Malignancy is most commonly in the peripheral zone. And coming to biopsy techniques, transperineal biopsy is there, which is more sensitive, and transrectal biopsy is there, which is less sensitive compared to perineal, but still transrectal is the one that is most commonly used technique these days. And when we speak about biopsy, it's a 12-core biopsy that's commonly used. The prostate from the base to apex is then divided into 12 different zones. And from each part, biopsy is taken, amounting to a total of 12 core biopsy. And based on the cells that you see in histopathology, the grading is given in Gleason's grade from 1 to 5. Gleason's grade 1, the cells are pretty much well differentiated. As we climb higher up the ladder, the architecture is lost. And when you reach up to Gleason's 5, there is minimal glandular differentiation. The most common pattern that is seen in the histopathology assessment is denoted first. The second most predominant one is given second. So Gleason's 7, 3 plus 4 means 3 is the most predominant and 4 is less predominant. Theoretically, Gleason's score ranges from 2 to 10, but scores 2 to 5 are never assigned. Gleason's score 6 is low grade, 7 is intermediate grade, and 8 to 10 is higher grade. Coming to International Society of Uropathological Grading, ISUP 1 becomes Gleason score less than 6. And look at ISUP grade 2 and 3. Both are Gleason score 7, but Gleason score 3 plus 4 becomes ISUP 2, and 4 plus 3 becomes ISUP 3. So that's the difference. And coming to the guidelines, according to the Joint EANM SNMI guidelines 2017, PSMA PET can be used in primary staging in high-risk malignancies, where Gleason score is more than 8, PSA of more than 20, and clinical stage 2C to 3A. It can be used before radical intent surgery or RT. The emerging indication is that targeted biopsy can be used after previous negative biopsy in high suspicion of malignancy. Otherwise, the guidelines say that it can be used for biochemical recurrence, which is the most common used one. Look at this guidelines that's published recently in 2021. In the initial imaging and biopsy, this consensus guidelines, PSMA PET-CT doesn't figure anywhere in the scheme of events. Only the multi-parametric MRI is advocated. But if you look closely at this area where there's recommendations prior negative biopsy, when NPMRI is negative and PRATS is less than 2, and clinical suspicion of prostate cancer is high, perhaps before doing systematic biopsy, this is one area where we might stand a chance in the whole scheme of events. So can we differentiate it based on the uptake between benign and malignant? In this recently published study, where there is retrospective analysis in 135 patients, comparing PET-CT results with histopathology, they found that SUV max cutoff value of 5.3 can be best used for discriminating between clinically significant carcinoma from benign disease with high accuracy in those which are suspected with prostate cancer. And the same cutoff value can be used to discriminate in such patients between metastasis and those without metastasis. And it has a sensitivity of 83.3% and specificity of 81.2%. So in initial staging, PSMA PET-CT can be used in high-risk disease as per DMICO classification. High-risk disease, we know that PSA is more than 20, Gleason's more than 8. And increased detection rate is found with higher PSA levels. And when you look at the intraprostatic lesion extent, you can find that in this study, which was published in 2016, though only 6 patients were done, biopsy-proven cases, if you compare the uptake pattern in the PSMA PET and histopathology, they found that you can find with a reasonable accuracy, high accuracy, you can find the intraprostatic localization or extent of prostate carcinomas. And this can be used to target biopsy or to support decision making prior to focal or radical therapies. And this is another case where there is elderly male evaluated for urgency incontinence and no obstructive symptoms. PSA was 12.9. PET-CT showed a focal uptake in the left peripheral zone, and Gleason score on biopsy was 7. There was no nodal or distant metastasis. He underwent radical RT on follow-up since 2016, doing good. So the significance of accurate staging is that 5-year survival rate for patients who are initially diagnosed with local or regional prostate cancer is almost 100%, but it falls to 31% for those with an initial diagnosis that has metastasized. And SUV max and aggressiveness, when you look at the relation, SUV max may predict clinical significant prostate carcinoma with a clear difference in mean values between ISCP grades 1 and 2 and grade 3 and 5. The higher uptake, higher the grade. Let's say have a look in such a case. Their PSA level was 19.2 here, and MRI showed a T2 weighted moderately hypointense lesion in the mid-right posterior transition zone. This is the PSMA images, prostate gland. You can see the diffuse uptake here, not just confined to the right side, but to the left side as well. And if you look closely, you can see uptake going into the seminal vesicles as well. High SUV max of 24. The final histopathology said the Gleason scoring as 5+4, 9. And you look at the pattern of distribution, you can see that it was not just confined to right side, but left side was also involved. So PSMA PET can fairly, with reasonable accuracy, tell us about the distribution of malignancy as well within the gland. When you look at MRI, you know that MRI has got high resolution and better sensitivity and specificity for extraprostatic extension, seminal vesicle involvement, and neurovascular bundle involvement. And PET-CT, when it's compared with MRI or a PET MRI, if you have the luxury, can help in targeting biopsy and planning radiotherapy in personalized treatment approaches. So this is one such case which we attempted to do in our hospital. A 74-year-old male, PSA was 8.4, Gleason score 7. MRI showed a solitary T2 weighted hypointense lesion on the right peripheral zone, showing diffusion restriction. When you fuse the PSMA and these MRI images, you found that there is uptake on both sides, right side and left side, which is corroborated by the final histopathology report showing the tumor in both the right and left lateral sides as well. Coming to nodal staging, the importance is that low-risk disease for lymph node metastasis can undergo definitive treatment with curative intent surgery without lymph node dissection, whereas in higher risk for systemic disease, they need to undergo nodal staging, and which is done by pelvic lymph node dissection, which is invasive, and nodal mets can sometimes be outside the field of dissection as well. So extended pelvic lymph node dissections also been shown to miss up to 13% of metastatic nodes. MRI looks at nodal invasion by using diameter and morphology. Short axis more than 8 mm in pelvis and more than 10 mm outside the pelvis are considered malignant. Problem is that nodes harboring metastatic disease may be nodal sized, and non-metastatic nodes may be enlarged due to reactive hyperplasia. PSMA PET has got improved detection of radiologically occult nodal metastasis in intermediate to high-grade malignancies. As evidenced by this scan, you can see that multiple nodes are there, which shows intense uptake. The nodes are actually subcentimetric, too tiny in size if you look at the size criteria, but uptake shows metastatic involvement is there. Pro-PSMA study, when it looked at the subgroup of patients who compared with PET-CT and lymph node sampling, they found that PET-CT PSMA PET has a negative predictive value of 95.2%. Which is agreed upon by these studies as well, of showing high negative predictive value for PSMA PET. When it comes to MRI, if you compare PET and MRI, PET-CT has got a higher diagnostic efficiency compared to standalone MRI in intermediate or high-risk prostate cancer. Sensitivity is 65% as against 41% of MRI. Specificity is comparable because MRI is better for the exclusion of false positivity. In end staging, as conventionally bone scan is used or abdominal CT can be used, PSMA PET-CT has got a better sensitivity than conventional bone scan in identifying skeletal metastasis, especially in detecting non-sclerotic bone and marrow metastasis. Sensitivity and accuracy is 90 and 97 as against 73 and 86 of bone scan. This is one such case. You can see that there is, apart from the prostate, there's a solitary skeletal metastasis here. And this is a rib metastasis. In this case, you can see a sclerotic lesion, but many times we don't see a sclerotic lesion also. A marrow metastasis better picked up. Look at the pro-PSMA study, which was used for staging high-risk prostate cancer prior to radical indent surgery or RT. They randomly assigned 1:1 ratio patients to either conventional imaging using bone scan or CT, and the other arm was PSMA PET. They found that PSMA PET CT has higher sensitivity and specificity, and which is true for pelvic nodal as well as distant metastasis. One or two specific scenarios encountered commonly in clinical practice. 79-year-old with lower urinary symptoms, high PSA at the outset, 76 per nanogram, clinical suspicion of carcinoma, but difficult rectal examination, no other investigations or biopsy, send straight to PET CT, fine, diagnosis is there, nodal staging is there, as well as distant metastasis is also picked up in this. Another scenario where known case of benign prostatic hypertrophy, recurrent prostatitis, slow PSA level rise over 3 years, latest is 9. History of previous negative biopsy, MRI is negative. You see the PSMA uptake, focal uptake in the right peripheral zone, targeted biopsy attempted again, came out to be SNR adenocarcinoma. A look at false negativities. We know that aggressive forms of primary neuroendocrine prostate carcinomas can be PSMA PET negative. Up to 5% of prostate adenocarcinomas, even otherwise, do not express PSMA PET. And this article recently published said that such tumors have significantly lower immunohistochemical PSMA protein expression than PSMA PET positive tumors. Before coming here, I asked my urologist experience in our institute. He was of the opinion that in biopsy-proven cases, when serum PSA level is more than 20 nanogram per ml and high grade, they prefer to do PSMA PET before decision making to avoid surgery if meds is there, and no meds, proceed ahead with surgery. In the right-sided lesion seen in PET CT, nerve sparing is done on the left and vice versa. And if there is a right-sided lesion alone, they go for a wide resection on the affected site, including nerves and periprostatic tissues. In transitional zone lesion, PSMA PET is better than MRI. And lymph node metastasis, PSMA PET CT is better than MRI, especially in small nodes. This is what our experience is. To summarize, clinical symptoms, direct digital rectal examination, serum PSA levels are clinical pointers towards malignancies. Initially, most often, transrectal ultrasound and MRI is done before biopsy. But in certain high-risk cases where it's biopsy proven, high-risk malignancies, upfront PSMA PET CT helps to make a better decision regarding the therapy modality. And in specific scenario, high clinical suspicion with significantly elevated PSA and biopsy need, perhaps straight away PSMA PET CT can be looked at. Thank you very much.
I'll request the chair to take over.
It's a nice presentation. Hari, can we proceed?
Yes, sir, please, sir.
Thank you, Hari, for the opportunity. And it's a very nice presentation, madam. I just have one a quick case which we had and I wanted to share with you. And I want to have one more question also. The thing is, we had one patient with metastatic prostate cancer who was on hormonal therapy continuously for 2 or 3 years. And this patient had done a PSMA PET serially over a period of 6 months or 1 year or so. But once the patient came, on follow-up, and suddenly the patient appeared to us with a CA rectum. I think Hari will remember this patient. We had a discussion with Hari also. The patient turned out to be a CA rectum, and he had done a PSMA PET just 1 month back. Of course, there's nothing to comment about it, but there was a difficulty in convincing the patient at that time because the patient was literally asking us too many questions. The patient was from US. The attender was from US, and they were asking why it did not PET. It should have picked up. No, it should have picked up the malignancy much earlier and all those things. And we do understand that PSMA PET picks up more of prostate rather than this one. So I had discussed with Hari at the time and then counseled the patient. That was the one comment I wanted to share. And I just want to have an opinion. What is the difference if you do a PET scan or a PSMA PET in a prostate cancer? What difference it will make, or what will be the sensitivity or specificity?
Shagos, ma'am,
Yeah. Can you come again, doctor? I just missed out the question.
No, the question is in a prostate specific, I mean, prostate cancer patient, what would be the difference if you would have a PSMA PET or a PET scan? We know we all do PSMA PET regularly. I mean, to counter such kind of situations or to handle such kind of, would PET be equally effective, or is there a direct comparison, or there is no direct comparison?
There was a time when we used to do FDG PET CT, but that was pre-gallium PS generator advent in the country. Now, since we have generators and we have the facility, we always go for PSMA PET CT. But you should also notice that in the presentation I had mentioned there are about 5% of prostate cancers, but it's just a small number when compared to the larger subset. 5% of prostate cancers and neuroendocrine differentiation, maybe we can miss PSMA. In such cases, if we find that it is negative, if we require, we can go for a PET CT as well. Otherwise, generally, we prefer doing a PSMA PET CT. It helps better because otherwise sometimes we miss the uptake in nodes and all, because many times we have encountered such scenario where prostate cancers together with lymphoma, but we could clearly make out so that the uptake is there in the prostate, which specifically says that it's prostate, but the lymph nodes didn't show so much of uptake even though the nodes were increased in size. So we point out to the urologist saying that this may not be metastasis from prostate CA, which in fact turned out to be true. It turned out to be lymphomas. We have had such experience as well.
Okay, I mean, this is a little different. You know, the PSMA PET was done, the patient had a CA rectum.
Understood. Yeah.
That did not pick up.
Yeah.
That was the scenario. The prostate was fine.
That's
prostate
expected because
because nowadays we see a lot of second malignancies coming during the treatment.
Exactly.
That is the problem.
That is expected because PSMA PET would show uptake in prostate, CA rectum may not show it.
Yes.
So in that case, to prove it further, CT suggests that there is another malignancy. Maybe we'll have to go ahead and do the PET CT as well.
I mean, on the front, we all are correct. But thing is, on the patient perspective, why it did not pick, it should have been better. I mean, it's difficult for us to convince them on that area. That is what I'm trying to tell.
True, convincing
I mean,
them.
of course, we are not wrong in any way doing that.
True. Convincing the patients, a layman about the nitty-gritty of all these.
Because when we say PET scan, it picks up a little early. That is what we say. And why it did not pick up? Such kind of scenarios do arise sometimes in our clinical practice. Thank you very much, madam. If anybody else, Hari.
Dr. Paul, sir, you want to add something?
Hari, can I have one question?
Yes, sir. Please, sir.
Say PSMA low uptake means that doesn't mean no disease. I think not all the cutoff value above 5, 6 only will be become seen, and there may be this thing, but more than the 50% of the cases, there are low PSMA avid. So we should not ignore those below cutoff value, what she said, 5 SUV. If they are below SUV, around 3 or 2 or something should be re-evaluated. I have seen many MRI positive, but PSMA is low avid. So it is mentioned 50% of the cases are low PSMA avid. We have to keep it in this mind.
Sir, the ideal one would be to go with a visual score. Any lesion which is having an uptake more than the liver should be considered significant. Ma'am, would you like to add anything?
Absolutely, what they said is true. Like, low risk malignancies with low Gleason score can sometimes show lower uptake. It is just a study showing that what is the best cutoff value in such scenarios, but definitely low risk malignancies with a low Gleason score can show lower uptake as well. We will not take one just modality alone. We'll always compare with clinical scenario, and this it's a whole thing together that reaches a diagnosis, right? And as liver uptake, you can compare with the liver and see whether it's more or not. That's another way.
Almost 50% of the cases. Sir, can I complete?
Yeah, please.
Yeah, almost half of the cases of gallium PSMA that I do in our hospital are for any intervention naive suspected prostate cancers. So I think the cutoff value of liver visual scoring of anything more than liver has given us very good results.
Yes, that can be another approach to it.
Especially when you are taking these images in the delayed phase, if it is showing a progressive uptake than this initial image in low SUV, so then that will add on more valuable,
There are multiple other methods also. Dynamic PET imaging is there, where dynamic study is done, where there's increase in uptake in those prostate cancer region can can be suggestive of malignancy. There are different ways are there, and of course, in all PSMA PET we take a delayed as in the sense 3 to 4 hours delayed, because urinary bladder uptake will be there. So there are all these together should be done if you are in doubt.
Ma'am, your audio is flaky, ma'am.
There's some issue with the audio, Dr. Maitri, but I believe you're asking about 50%. 50% would be too high a number, I think. It's just 5 to 10% of normally itself they show low PSMA uptake. It's not 50%. That's too high a number. 5 to 10%.
10 to 15%.
15, yeah.
Okay.
Neuroendocrine tumors, as I said, doesn't show uptake. And normally, otherwise, normal prostate adenocarcinomas, 5 to 10, maybe up to 15% can show low PSMA.
Yeah, what I said was that we have cases where there is distant mets, both has been done, some local uptake in the prostatic bed, multiple lymph nodes, and the bone metastasis. And clinicians still feel PSA was normal, so they are still not thinking of prostate as primary. It can happen. It can still be prostate, but PSA is normal. That's what I was trying to say.
I'm sorry, I didn't get the question. Could anybody understand what? There's some issue with your mic.
Dr. Maitri ma'am, can you please use headphones? Dr. Maitri ma'am, can you please use headphones?
Maitri ma'am, can you please send it in chat box? We will have that discussion at the end of the next talk. Can we proceed to the next talk?
Am I audible?
Yes, sir.
Yeah, good afternoon all. It's a nice talk which we had now. The second talk is equally interesting, yellow, difficult fellow. It's my privilege to introduce the speaker, Dr. Senthil, who is currently the consultant and head Department of Nuclear Medicine and PET-CT from Lakeshore Hospital, Kochi. He is from my alma mater, prestigious Institute of PGI, Chandigarh. He is a fellow of Asian and European boards of nuclear medicine, and he is currently working as a consultant at the BPS Lakeshore Hospital, Kochi. Dr. Senthil, can you proceed?
Hi, I'm Dr. Senthil from BPS Lakeshore Hospital, Kochi. I'm going to talk about cholangiocarcinomas are malignant tumors arising from the biliary tract. These are the second most common primary hepatic tumors, next only to hepatocellular carcinomas. More than 95% of cholangiocarcinomas are adenocarcinomas. There are various classification types available. We will consider on two types of classification which are relevant to imaging. So first one is based on the location, so from where the tumor arises. So if the tumor arises from the intrahepatic part, that is within the liver, that is called intrahepatic tumors, they usually arise from the distal bile ducts. And all those tumors which arise around the hepatic hilar region are called perihilar cholangiocarcinomas, and all those tumors which arise outside the liver are called extrahepatic cholangiocarcinomas. The perihilar cholangiocarcinoma can be further subdivided into 5 types like this based on the location from where it arises. And based on the growth pattern, again, it can be classified into 3 types. One is Mascombe type, which are primarily intrahepatic cholangiocarcinomas arising from the distal bile ducts. The other 2 types are usually arising from relatively proximal bile ducts. The perirectal infiltrating type will usually present as irregular wall thickening with associated perirectal soft tissue with distal dilatation. There will be luminal narrowing at the site of disease involvement. Whereas intraductal growing type, the tumor grows inside the lumen. So there will be luminal dilatation in that particular segment with the distal dilatation. So whenever we get a patient for a liver lesion and evaluation, it's a very challenging job because a lot of liver lesions are there. Characterizing them is a real task. So we need to take various tumor marker levels while history taking. because this will help when there is overlapping of findings or equivocal findings on the imaging. And also during image acquisition, try to acquire three-phase of the liver, CT of the liver, unless the IV contrast is contraindicated. And whenever you suspect cholangiocarcinomas on the initial phase of the CT, then acquire delayed CT of the liver at the end of PET CT. So coming to interpretation, the main differential diagnosis for intrahepatic cholangiocarcinoma is hepatocellular carcinoma. So most of the time, the cholangiocarcinomas are moderate to intense FDG away, whereas HCCs are less or non-FDG away, and except for the poorly differentiated ones, which can show good uptake. So coming to the CT component, the intrahepatic cholangiocarcinomas usually show irregular peripheral enhancement with gradual centripetal filling, whereas hepatocellular carcinomas show arterial phase hyperenhancement with washout in the portal or delayed phase. So this is a typical example of a cholangiocarcinoma where there is hypodense lesion in the liver with the peripheral irregular enhancement with the central non-enhancing area. On the PET also we can say similar pattern of uptake where the periphery is showing increased uptake with the central photopenia. In normal cases, most of the time we will call this photophilic hypoenhancing area as necrosis. But in cholangiocarcinomas, in addition to necrosis, there is one more specific feature which is called abundant fibrous trauma in the center. That might be the reason for this photopenia in most of the cases. So how to confirm it? Then that helps the delayed CT of the liver. This was taken after the completion of the FDG PET CT. You can see all those non-enhancing area in the initial CT has become hyperdense. So the contrast enhancement of this fibrous component happens very late. So that's why we have to take delayed imaging. So this is one of the positive finding which towards the diagnosis of cholangiocarcinoma. The other finding is capsular retraction, which is very common in cholangiocarcinomas, whereas in hepatocellular carcinomas there will be tumor capsular enhancement. Here the hepatic capsule is usually retracted. And other features which are associated with cholangiocarcinomas are distal IHBRD and satellite lesions. This is another case where typical typical cholangiocarcinoma with capsular retraction and all is there, and there is distal IHBR dilatation. Because these are tumors arising from the biliary tract, there will be obstruction at the level of involvement with distal dilatation. And also there are some hypodense lesions similar to the primary one. They are also showing uptake. Even such smaller lesions will show uptake. These are satellite lesions. In HCC, usually this kind of smaller lesions do not show much uptake. And other factor which we have to look into is vascular encasement. In most of the time, cholangiocarcinomas, the tumor will encase the vasculature like this, but rarely we see any thrombus within it. Even vessel may get attenuated like this, but tumor thrombosis is very, very rare. But in hepatocellular carcinomas, it is tumor thrombosis commonly seen. So these are the factors which we have to look into imaging to differentiate HCC from the cholangiocarcinomas. So this is a case where there was a perihalar mass extending into liver with the distal IHBRD, almost looking like a cholangiocarcinoma. But when you look into dual phase imaging, there are areas of arterial hyperenhancement with washout. So there is this is a feature of HCC. So we should not forget that there is one more entity called combined hepatocellular carcinoma and cholangiocarcinoma. So these tumors arise from bipotent hepatic progenitor cells. So they can have features of both HCC and cholangiocarcinomas. And they may present with rise in both CA 19.9 level as well as AFP. And also imaging based, there will be IHBR dilatation, which is specific, which is usually seen in cholangiocarcinoma, along with vascular thrombus, etc. So we need to be aware of this subtype also. And coming to extrahepatic cholangiocarcinomas, mostly these will present as irregular wall thickening of the biliary ducts. Maybe because of the size, we don't usually see much uptake in this unless there is the associated periductal soft tissue where we can see some amount of uptake. And for intraductal type, I don't have my own image taken from the literature where you can see the tumor is growing inside the lumen, so that there is a luminal dilatation instead of narrowing, but still IHBRD is seen. This is the mucin secreting type. Most of the intraductal tumors are mucin secreting tumors. So there will be some areas of enhancing soft tissue also seen. So this case, interesting case, referred as ovarian carcinoma because patient presented with abdominal distension. CT done outside showed a lot of fomental deposits, ascites, perihepatic soft tissue thickening, and lesions in the bilateral neck side, and also in intrahepatic liver lesion. So when we did PET CT, all those areas showed increased uptake, as we see here. But when you look at the liver, just distal to the liver lesion, you can see IHBRD, which is not very common in ovarian carcinoma metastasis. And also, if you look at the ovaries, they are very small lesions. They don't look typical of primary lesions. So the suspicion of liver malignancy, particularly cholangiocarcinoma, also was raised, and further IHC and biopsy and IHC from momental lesions proved to be metastatic cholangiocarcinoma. And this is another case where the patient was referred as suspected hilar cholangiocarcinoma. You can see a lesion in the hilar region with distal IHBRD. When we did PET CT, you can see all those areas showing increased uptake with a lot of lymph nodes and skeletal lesions. But if you look at the spleen, this is almost typical of a lymphoma. So the possibility of lymphoma was raised, and biopsy finally proved to be lymphoma, that is DLBCL type. After 6 cycles of R-CHOP, we can see complete metabolic response. So, yeah, diagnosis which was sent as cholangiocarcinoma can turn out to be something else, which was referred as something else can turn out to be cholangiocarcinoma. So, PET can give really useful information towards the correct diagnosis. Just we need to look into each and every detail to come to the correct diagnosis. So coming to staging, these tumors usually metastasize to lymph nodes. Almost 50% of the cases are metastasized to nodes at the time of presentation itself, followed by lungs, peritoneum, and bones. So this is a case where even smaller lymph nodes which are insignificant or indeterminate on CT also shows uptake, and also a tiny lung lesion also is showing uptake. So it definitely increases the sensitivity of detecting this metastasis. And more than that, apart from detecting these nodes and lung metastasis, in this case you can see a focal increased uptake in the scapula. This is the only bone site. On CT, there is no lesion at all. So almost absolutely normal. So PET is very helpful in detecting this kind of skeletal lesions where structural imaging is almost normal. So this is one of the major advantage in staging. So coming to response evaluation, most of these tumors usually don't respond very well to the chemotherapy. But this is an interesting case where the tumor has shown almost resolution of uptake with significant reduction in size. But this kind of response we rarely see. Most of the time, the response will be like almost stable disease or minimal response or partial response at maximum. And also there will be progression frequently. This is a case where after 3 cycles of chemotherapy, there wasn't much change in the CT size. So it was referred for PET. Usually that was sent for interim evaluation because tumor size has not changed, but tumor markers have come down. And when we did PET CT, you can see there is reduction in the uptake. Almost 20% reduction in SUV was there. With not all areas are showing persistent uptake. Some areas show reduction in the uptake. So this patient is responding. So the further 3 cycles of chemo also was continued. in this case. So PET can help in such way. And coming to the surveillance, especially in post-op setting, there will be a lot of non-specific findings along that section margin. So whenever there is a rise in tumor markers, so it's very difficult to characterize which is important or which is not important. And when you do FDG PET CT, you can see this area is not showing much uptake, but this area is showing uptake. Again here, this area is showing this uptake, and this is not showing. So image guided biopsy was taken from this site and proved to be local recurrence. So having said that, PET has limitations in identifying some lesions, especially in smaller lesions on the background of cirrhosis. We can have negative FDG negative lesions. Again, extrahepatic cholangiocarcinomas can show less uptake, and mucinous tumors can show less uptake. And there can be false positive uptake also after interventions like biliary stenting. So all these things we need to keep in mind. And I will be curious to know how this fibroblast activator protein imaging will work in this tumor, because it has got a very high content of fibrous tumor within tumor content. Initial study has shown very high ability, but we have to see how it is going to outperform FDG, and is there any role for diagnostic purpose. So to conclude, recognizing various imaging features of liver lesions is very important for characterizing them. And also FDG PET CT seems to be useful in staging, response evaluation, as well as surveillance. Thank you so much.
Nice, concise talk, Dr. Sendil. Any questions from the audience?
Dr. Sendil, definitely. So then, as you mentioned, that the PAPI is distinctly a better choice, and the only problem is about this labeling is a little tricky. And
PAPI, we are having a talk next. We'll discuss PAPI along with this.
Yeah. So then do you require a large, then gallium to get one single dose of PAPI. That is one problem. So we'll see better in our next talk about PAPI.
Yeah, sure.
Any comments from our oncology team?
Nothing, Hari.
Nothing. It's a difficult disease to treat anyhow.
Hari, unmute yourself.
With your permission, we'll move on to the next session. Before moving on to the next session, I'd like to thank Dr. Krishna Kumar sir, Dr. Vijay Bhaskar sir, and Dr. Paul Vincent sir for chairing the session. And special thanks to my dear friend Dr. Sendil and our senior Dr. Shagos ma'am. Thank you. Dr. Sunita ma'am has some very interesting announcement to make. Over to you, Dr. Sunita ma'am.
Thank you, Hari. As usual, the answer for the last question, that is quiz number 16, was answered by Chu Kai Wei from Malaysia. I'm sorry if I'm pronouncing it in a wrong way. So it's very happy to see students or doctors outside India answering our questions. So next, move on to the question number 17. Hope you all know how to answer. So it's a button in the right-hand corner. A 10-year-old male child with a history of abdominal pain and the ultrasound showing left hydroureteronephrosis with no obvious calculus, and creatinine is normal. This patient had undergone EC renogram. These are the upper images are the dynamic initial flow images, and the lower are the dynamic images. Please see the values. ERPF is 1/3 the value of the GFR is 1/3 the value of ERPF. So this patient had undergone 2 hours delayed image. These are the dynamic and pre-void and 2-hour delayed image. So once again, I'm showing you the dynamic images. Upper one are the flow images and lower one are the dynamic images. And these are the otherwise how we draw, and the pre-void image followed by the 2-hour delayed image. Now the options are, what is the diagnosis? Option A, left VUR, that is vesico-ureteric reflex. Option B, left lower ureteric calculus with obstruction. Option C, left obstructed megaureter, and option D, retroperitoneal fibrosis. So you can have images again, upper dynamic and delayed images lower down. So you can answer by pressing this button. So we'll wait for 10 seconds before we move on to the next session, the interesting topic PET2. Okay, we'll move on to the next session.
I have one announcement to make. As we have announced several times before, we have a separate quiz for the technologists. We will have 5 separate questions which will be open only to the technologists. And just reminding all of you, we have our sponsor booths in the main page. You can kindly visit the sponsor booths, and you can also directly interact with the sponsors if you have any queries. So thank you, Sunita ma'am. We move on to the PET2 session. For that, we have 2 young and dynamic colleagues of mine. Dr. Anand Sellakumar sir, who is Senior Consultant of Radiation Oncology, Meenakshi Mission Hospital, and Dr. Narendran, who is the neurologist of our hospital, Meenakshi Mission Hospital. Now I request the chairpersons to take over the session.
Hi, Hari. Good afternoon.
Good afternoon.
It's my pleasure to be a part of this national conference. Hi, Naren.
Hello, sir.
Hi. Without wasting the time, I want to introduce the speaker, Dr. Piyush Chandra. He's a nuclear medicine physician from Aarti Scans, Chennai. He had done his MD from Tata Memorial Center. He's a gold medalist, and he has 8 years of experience in hybrid cancer imaging, and he had done publications of nearly 40, which were indexed in PubMed, and he had done his fellowship also from Germany. So, hi, Dr. Piyush, you can go forward.
Hi, one and all. I'm Dr. Piyush Chandra from Chennai. I thank Dr. Harishankar and the organizing team to give me a chance to share my experience with FAPI. Yes, we are all happy and excited about this new molecule and the avenues it opens for both oncology and non-oncology conditions. So what is FAP? Basically is a type 2 transmembrane protein. It resembles an enzyme called dipeptidyl peptidase 4. FAP expression is extremely low in normal adults. We hardly see any background uptake when we do FAPI scans. But sometimes we see in healing tissues, pancreas, atherosclerotic disease, in the heart. Then we see in the lung fibrosis and in cirrhosis, sometimes in the orbit, we see FAP expression physiologically or pathologically. And we all know that FAPI is expressed abundantly in the tumor stroma of epithelial and non-epithelial cells. So we have moved from imaging the tumor to imaging the tumor microenvironment. So oncology and non-oncology applications of FAPI, in the last 2 years, there are multiple reports. Diagnostically, we use FAPI-04 as the subtype which has a higher tumor retention and a better tumor binding compared to the previous FAPI-02. So gallium-68 labeled FAPI-04 is now available in India. There are a lot of papers in literature supporting its use in peritoneal carcinomatosis, gastric cancer, colorectal cancer, mostly abdominal cancers and breast cancers. Therapeutic use studies are very less, limited to some anecdotal reports. And our AIMS group has done multiple therapeutic studies, and they published it with SA-FAPI and SA-FAPI-2. And there is one study going on in US, which is financed by Clovis Oncology. The study is called Lumiere study. It uses a different FAPI subtype called 2286, which has a better tumor retention and a higher effective life in tumors. Non-oncology applications are heavily used in IgG4 disease. Now, recently, there's a paper published its role in idiopathic lung fibrosis, and there are potential applications like coronary artery disease and cirrhosis. So first such study of FAPI was published by Kratochwil et al. From the Heidelberg group. They showed very good FAPI expressions in almost 90% of the tumors that we see, including sarcomas, thymic carcinomas, medullary thyroid carcinomas. After this, multiple comparison studies came with FDG and FAPI, where especially in abdominal malignancy, FAPI was shown to have significantly better detection sensitivity, whether it's primary nodes or those difficult to detect peritoneal metastasis. And there was a study specifically for peritoneal carcinomatosis, and this study in EGNM in 21 showed that FAPI outperforms FDG PET, especially for detection of peritoneal metastasis. So we must remember that all abdominal malignancy elicit a very high desmoplastic reaction. So the tumor bulk may be less, which is the reason of not seeing on PET, but because of the desmoplastic reaction in the peritoneum, we can pick up nicely on FAPI compared to FDG. We have done multiple comparative in multiple patients comparing across tumors, FAPI and FDG. And in this case, you can see CS stomach, very intense uptake in the primary as well as peritoneal metastasis compared to FDG. Another case of CS stomach, very intense uptake compared to FDG. You can see hardly any uptake. So normally we see with PET stomach, it is very bad, but FAPI detects nodes, peritoneal disease, distant mets, everything much better than FDG. So stomach is a very genuine indication for FAPI. Even in stomach, we can use for response evaluation. Sometimes PET may show complete response, but FAPI shows correctly if it is complete or partial, as we can see in this case. Other colon tumors with peritoneal mets also can be better visualized with FAPI. You can see in this case, peritoneal disease nicely picked up on FAPI with a much higher tumor to background ratio. Carcinoma ovary, we have done 3-4 patients with high-grade serous carcinoma, and we found that FDG and FAPI performed equally well. So the same cannot be told for ovary, where intense uptake is usually seen, especially in high-grade carcinomas. For pancreatic ductal adenocarcinoma, recently published in JNM, they showed FAPI better than normal CECT in changing management, especially for detection of distant metastasis. And it was also shown to have higher incremental value than FDG. We did a study in MIOT comparing FAPI and FDG in locally advanced and early operable breast cancer, and we presented this work in the recent ENM Congress. Very significant finding in our study was FAPI outperforms FDG both for detection of primary as well as axillary nodes as far as hormone receptor positive tumor goes. In hormone receptor negative tumors, where FDG uptake is usually high, FAPI and FDG were not significantly different. You can see here luminal A, intense uptake in the primary, very hardly any uptake in the primary in the FDG PET. Again, one luminal A, intense uptake, very minimal uptake on FDG PET. So FAPI is very good for luminal A disease. For HER2 amplified, you can say, okay, the liver disease are better seen on the FAPI because of low background on the liver. Primary also shows higher uptake, but this difference is not as marked as we see with luminal A and luminal B tumors. Triple negative, again, FDG and FAPI relatively equal, but in this case, we found bone metastasis much better detected by FAPI compared to FDG. So breast cancer across types, FAPI seems to have a upper hand. This patient, you can see starking difference in the images. This patient presented with myelofibrosis and transfusion-dependent anemia with extensive bone mets, but FDG PET hardly shows because of hormone receptor positivity, and you can see FAPI showing intense uptake. This area we are seeing photopenia because of irradiated marrow, because of pain palliation done previously. So you can see starking difference as far as luminal B and luminal A disease, and FAPI is significantly better in this condition. Also, now we know when we give GM-CSF, we have to wait at least 8 weeks completion of GM-CSF so that we don't see any background marrow activity. In this case, you can see bone marrow metastasis, which are not seen on the PET. On follow-up, seen as partial regression in the follow-up imaging at 3 weeks chemotherapy. Normally, post 3 weeks GM-CSF, we will still see marrow picture like this, and it will be hard to pick up residual disease in the bone marrow. So earlier assessment can be done with FAPI compared to FDG. Mucinous carcinoma, we felt FAPI may perform better than FDG, but 2-3 cases we were disappointed. It was almost having similar uptakes. Carcinoma lung, we found no significant difference in primary as well as brain metastasis detection, which was surprising because we thought FAPI may show incremental value there. So in this case, you can see equally seen on the MIP image also, you can see, and in the transaxial images. Second case of CA brain mets, lung with brain mets, you can see equivalent, and sometimes FDG signal is much better than FAPI signal here. Some bone fractures, traumatic fractures, we saw uptake on FAPI. So this is one of the false positive, and you can see degenerative arthritis showing FAPI uptake. So again, one of the false positive on FAPI. Carcinoma rectum, almost similar uptake, no significant difference. Prostate, many times we can get PSMA non-avid prostate cancers, and in that scenario, we can use FAPI in this, as we see in this case, which was biopsy proven Gleason score 6, and some uptake in the lungs, which was because of tuberculosis. Now, hepatocellular carcinoma, yes, genuine indication for FAPI because FDG is very bad. We all know that. And in this study done in 35 patients, they showed significantly better SUV max values and detection capability of FAPI compared to FDG. But the most incremental value of FAPI were seen in tumors which were large in size, and the smaller tumors were not detected either on FAPI or FDG. So hepatocellular carcinoma, we too found a slightly better tumor to background ratio with FAPI compared to FDG. But we found, and in this case also you can see this was incidentally detected SCC on a PSMA scan, where we did FAPI and showed moderate grade expression. But many times we see diffuse liver uptake and we don't know whether it is cirrhosis or non-cirrhosis, because many patients don't have cirrhosis, also have diffuse liver uptake. And we have done LFT correlation. We found that most patients have raised SGOT, SGPT suggestive of hepatitis. So are we looking at stellate cell hyperactivation? Because stellate cells are known to physiologically accumulate FAP alpha. So if they are activated, they may express and we may see diffuse liver uptake. So it may not be, and in such scenarios to pick up HCC may be difficult because we know cirrhotic livers are prone to develop HCC. So non-alcoholic fatty liver disease and NASH imaging, that's, there's no imaging modality which can image NASH. And I think FAPI has been shown to have some role, not by imaging sense, but there was some serum fibroblast activation protein and correlation with liver biopsy. And those they showed that patients with low serum FAP alpha values have less chance of developing NAFLD and NASH. So probably we can use FAPI for NASH, and that might be a game changer, especially in gastro-oncology, because that's a commonly encountered condition. And now we know false positives in FAPI. A few of the papers have published, especially in EGNM recently came solitary fibrous tumor of the lung and lung fibrosis, tuberculosis. These are specific conditions where you may get, and always immediate post-op, you can get high intense FAPI uptake. Fibroadenoma may be a challenge if you're staging CA breast patients with FDG. So in this case, we can see patient with HCC with a low-grade expression of FAPI and also having a fibroadenoma, which was biopsy proven. Tuberculosis, chronic fibrosing condition, so definitely may also express FAPI, and it may be seen in many of our Indian patients, so we have to be careful. Myocardial ischemia, sometimes any uptake in the myocardium seen in FAPI would be abnormal. So in this case, CA breast staging, we can see better uptake in the primary in the breast, but we found incidental focal uptake in the distal LED segment of the myocardium and also on FDG. And we did a tovitamin stress thallium the next day, and we found inducible ischemia in the distal LED territory. And coronary angiography done the next day showed a block in the mid and the distal LED. So, and we published this data, and I think FAP may be of use in detecting ischemia or maybe implicated in cardiac failures. Idiopathic pulmonary fibrosis, again a very deadly condition, and many times CT cannot differentiate between NSIP or UIP pattern, and I think UIP or the IPF pattern may be nicely picked up on FAPI because these fibroblasts are known to express FAP alpha compared to NSIP and other fibrotic disease of the lung which do not express FAP. I think this may be a game changer indication for FAPI. Another so similar study which to say that they have done in systemic sclerosis patient ILD, and they have used FAPI to predict which patient may respond to an antifibrotic drug called nintedanib. This drug binds to FAP alpha, and so that we can see the follow-up and serial examination of FAP images and see if the patient improves. And so in this patient, the baseline uptake, if it was high, FAPI on the lungs, and these patients were more likely to progress even on the antifibrotic drug. So very useful study published in Lancet recently. And the IgG4 disease, as I told you earlier, it has significant better value because it's a fibrosclerosing disease, so it will express FAPI, and you can see disease better compared to FDG. But in this study, they showed that although FAPI is good in all the conditions, it is not good so good for lymph node inflammation in IgG4. So for lymph node, FDG is better, but other lacrimal, pancreatic, kidney inflammation, FAP is much better. So now going to theranostic domain, you can see there are multiple studies with lutetium, DOTA, FAPI4, and then SA-FAPI and SA-FAPI2 by the Ames group. SA-FAPI and SA-FAPI2 is significantly better than the FAPI4 because it has higher retention in the tumor and for a longer time, matching the half-life of the lutetium-177, which is very important. So, and in these studies, they have shown that almost effective half-life of 88 hours that they have seen with these sort of FAPI subtypes, and this may be useful for meaningful tumor response. And the same Ames group published a paper in in thyroid in this year, where they showed in 15 patients, almost most patients had a thyroglobulin decline and 4 patients had partial response. And the effective half-life of the isotope in the tumors was 88 hours. With FAPI-04, we do not see beyond 8 hours to 12 hours uptake. So this particular isotype FAPI-2 may be very useful for therapy. Other advantage, obvious advantage of FAPI is we can make it in-house. We can do the scans faster and give patient much more less effective dose, and there's hardly any patient preparation involved. So keeping in theme of the Congress and the conference, some questions for the audience. So non-tumor expression of FAPI is seen in all except pancreatic alpha cells, healing wounds, atherosclerotic plaques, arthritis, Kupffer cells in cirrhotic liver. The answer is Kupffer cells in cirrhotic liver. It's actually stellate cells in cirrhotic liver. And one question to the general public, not to the students per se, but so in these questions we see routinely in many of the editorial of these many journals, will FAPI ever replace FDG? And I think it's too early to tell that, because FDG, we have 4 decades of experience with FAPI. We just are starting, and we don't know many false positives and false negatives. And though FAPI may add more diagnostic information, will it be of any relevant to patient treatment? I mean, FDG gives a lot of good prognostic information in addition to diagnosis. So I think a lot has to be researched on about FAPI. So early days to say that, and I don't think it will ever replace FDG. So thank you for your patient listening. Stay happy, stay safe. Thank you.
It was a fantastic presentation by Dr. Chandra. I have 2 comments, quick comments, and 2 questions. Being an oncologist, I am happy about this FAPI because I couldn't see the background uptake in the liver as well as the brain. I could see the enhancing lesion very well, but we have some problem with FDG definitely in those areas. And I am happy about the peritoneal uptake also. So probably in the near future, we will avoid unwanted staging laparotomies. We can reduce the number of staging laparotomies. So with the help of FAPI, we'll be identifying more peritoneal meds. And I have 2 questions also. Is there any issues with the scanning period? Because for the FDG, we will wait for 4 to 6 weeks. I could see the increased uptake in the inflammatory areas also. So the fibroblast will come in the inflammatory process. So should we wait beyond 6 weeks in a post-op situation or a post-radiation situation?
Yeah, yes, sir. So post-op situation, I will guard against, because I think we have seen in mastectomy incision site intense uptake. So immediately post-surgery staging, it's not advisable, and it may be even coming later than FDG because fibroblasts are chronic inflammation related. So you may even get after 3-4 weeks, which FDG may not. So I think that we have to closely monitor. I think pre-op staging should be the theme. And secondly, in the NACT setting, NACT RT setting, maybe in the rectum and all, we have seen that. I think it may perform better because inflammation related, whether FAPI uptake is there in 2 cases of NACT RT in rectum, we found that FDG was showing some uptake inflammation, FAPI was not. We don't know what was the reason, but I think NACT RT, we need to explore this. I don't have numbers behind me to tell this, but I think early assessment with, and sometimes we have false positive. We say post NACT RT partial response, and then we get a complete response. So all these things, I think FAPI may add. We need more research into that. Yes.
My second question is, how feasible is this? Because we are currently having PSMA, FDG, DOTA. We are having. How feasible is this in any institution?
Yes, sir. I think it is as feasible as PSMA and DOTA-NOC. Labeling issues are sorted out because many institutions are doing now, and it is readily available in every center which has gallium generator. And sir, beauty is you don't need to wait, no diabetes, nothing. But yes, for the reporting and everything, I think need experience with this because there are a lot of false positive. What are the implications? Sometimes you see very intense uptake, and I mean, it may not add that, oh, okay, it is an aggressive tumor, like in breast we see, oh, this is triple negative. But FAPI may be very intensely expressing, but it may not have any prognostic value. You are not looking at the tumor, you are looking at the tumor stroma. That we should never forget.
Anand sir, earliest we can do FAPI is tomorrow morning, 9 o'clock. We already have it in our department.
It's a happy news. It's a happy news.
Piyush, one quick comment. almost like a decade ago, we from the PGI team, we started one study of cocktail PET scan. We injected FDG and F18 together, and we did publish it. But I think this is the time for doing a cocktail FDG and a FAPI. I think that should be seriously explored, because whatever that is missed with FDG, I think it might be possible to pick it up with FAPI. So I thank you.
Who doesn't like cocktails?
Virtual cocktail as of now. Okay.
I have a question, sir.
Yeah, please.
Will this be useful in pachymeningitis, sir? IgG4 related pachymeningitis?
Yes, sir. Yes, sir. Any IgG4 related disease, I think FAPI, that study that I showed you, but they usually did an abdominal IgG4, but there'll be no background of a FAPI in the brain. So definitely it will be better than FDG for pachymeningitis.
Because we can avoid biopsy if it's possible.
Yes, sir. I think, but there are hardly any studies to say that, so I can't tell you right now. Thank you.
Any more questions?
We will just borrow a quick 20 seconds from you, sir, to show the quiz number 18. Dr. Sunita, ma'am, please.
Yeah, so first I will announce the quiz winner. The question number 17 is Dr. Karthikeyan Subramanian. So the answer is left obstructed megaureter. So we'll move on to the next question number 18. So hope you all know now, because after 17 questions, a 60-year-old female with a history of recurrent neck swelling during the follow-up of carcinoma thyroid, and there is no history of breathlessness. This patient had iodine scan negative but elevated thyroglobulin level, that is around 534 nanogram per ml. So this patient had undergone F18 FDG PET-CT study. This is the MIP image, which shows recurrence in the neck, and the lung image. Sorry. So these are the coronal images and transaxial images, CT, and fused images. So the options are: option A, metastatic neck nodes with a lung metastasis; option B, metastatic neck nodes with bacterial pneumonia; option C, pulmonary tuberculosis with a thyroid cancer cervical metastasis; option D, metastatic neck nodes with a COVID pneumonia. This patient had no breathlessness. And these are the coronal and transaxial images. And I'm just repeating again the CT images. So these are the options.
So to add to that question, all the images that are shown are all our own patients. So we have the follow-up data also.
Okay. So try to answer. We over to the chairpersons now.
Dr. Naren? Yes. Yeah, you can take.
I would like to introduce Dr. Arun Kumar Reddy Gorla. He's a consultant head of nuclear medicine in American Oncology Institute, Hyderabad. And he's alumnus of PJ Chandigarh. And his areas of interest is hybrid imaging, radionuclide therapy, and over to you, sir.
Good afternoon, everyone. I am Dr. Arun Kumar Reddy, working as consultant at American Oncology Institute, Hyderabad. Today, I will be discussing about dually and other scoring systems available for PET-CT interpretation. The learning objectives of this presentation would be to summarize the structured reporting and scoring systems available for PET-CT interpretation, to understand the purpose, evolution, the current status and challenges of dually score, to overview, understand the current available similar scoring systems for other malignancies, and I would summarize the entire topic once. This slide shows the summary of the structured reporting and scoring systems in PET-CT interpretation currently available. The conventional tracers, that is the F18 FDG, when used for solid malignancies, we use the PERSIST criteria, and for lymphoma, we use the Lugano criteria with the dually score, and for head and neck malignancies, new criteria called as the Hopkins criteria and neck imaging rats have been proposed. And for myeloma, there is impetus scoring proposed by an Italian group. While using the novel traces like gallium dotatate FDG for neuroendocrine tumors, Krenning score, NetPet score, and SSTR rats have been proposed. For interpretation of PSMA imaging in prostate cancer, recently PROMISE criteria and PSMA rats have been proposed. The SSTR rats and PSMA rats have been recategorized into a single molecular imaging rats in recent studies. So for the purpose of this presentation, I'll be skipping the PERSIST and discussing in detail about the Dewey score and briefly overviewing the rest of the scoring systems. So to understand lymphoma, I need to take you through the happenings in these beautiful cities, including the Ann Arbor, Michigan, Cotswolds in England, Lugano in Switzerland, and Dewey in France. So it all started in 1971 during the Ann Arbor staging, where there was clinical and pathological staging, and even there was a component of laparotomy for the purpose of staging the abdominal disease. And the radiographs and few isotope studies were components of this staging system. In 1989, the Cotswolds modification included the CT for the evaluation of the lymphoma, extent of disease of lymphoma. And at the same time, descriptor X was used for bulky disease, and the notation of CRU has been introduced. In 1999, the gallium scan was added to the lymphoma evaluation, and the International Working Group criteria mentioned that gallium scan can be a valuable adjunct in lymphoma evaluation, however, needs expertise. And in the year 2007, PET found its place in the lymphoma evaluation through the International Harmonization Project criteria. With the advent of PET in lymphoma, more people started using it for interim evaluation, and for the purpose of interpretation of the interim scans, the Dewey score has been proposed. And this Dewey score, though proposed for the interpretation of interim scans, was later used for both the interim and end of treatment PET, and has been incorporated into the Lugano classification of 2014. In 2016, lymphoma treatment patients treated with immunochemotherapy were proposed to be interpreted by a new criteria called as the Lyric criteria. In 2017, a group of experts from USA have proposed a newer criteria called as the response evaluation criteria in lymphoma, the RESIL criteria. However, to date, Lugano classification is the most widely accepted and practiced criteria for lymphoma evaluation. The Lugano classification. These two articles published in 2014 in the Journal of Clinical Oncology document the complete recommendations of this classification for various steps of management of lymphoma, including the initial evaluation, staging criteria, the prognostication, assessment of response, and follow-up. For the purpose of this presentation, we will limit ourselves to the assessment of response. So what was the need for the proposal of Dewey criteria? In IHP criteria of 2017, the end of treatments for treatment PETs were reported as PET positive and PET negative. So if there was a residual mass or node which is more than 2 centimeters and showing a activity that was more than that of mediastinal blood pool, it was considered as positive. And for the lesions that are less than 2 centimeters, surrounding background was the reference, and if the activity was more than surrounding background, it was considered as positive study. However, with the increasing use of interim PET to assess the early response, a newer response criteria was needed. Also, this dichotomous classification of PET positive versus PET negative was not appropriate for the interim setting. And a simple, reproducible, and easy to implement criteria was needed, which was relevant to the prognosis. And hence this Dewey score has been proposed at an international conference. Is the Dewey visual 5-point scale. In this, the scores of 1 to 5 are given based on the uptake of the pathological lesion. And X was given when new areas of uptake are noted, which are unlikely to be related to lymphoma. A score of 1 is given when there is no uptake in the pathological lesion, residual lesion, and a score of 2 when the uptake in the lesion is less than mediastinal blood pool. Score of 3 for uptake more than mediastinal blood pool, but less than or equal to liver blood pool. 4 and 5 when the uptake is moderately or markedly higher than the liver blood pool. And whenever there is new lesions related to lymphoma, a score of 5 is given. The scores of 1 to 3 are considered to be complete metabolic response, whereas 4 and 5 can either represent partial response, stable disease, or progression in the interim setting, whereas at the end of treatment, these are considered to be as treatment failure. There was no initial demarcation or quantification proposed for the moderately and markedly higher than blood pool notations of score 4 and 5. However, studies explored 2 times more than the liver blood pool and 3 times more than the blood pool in the taking as the criterion. And subsequently, during the Lugano classification, a uptake more than 2 to 3 times of the liver blood pool was considered as 5. Any less uptake is considered to be 4. So these are example images showing the complete response on dually 1, uptake that are less than that of mediastinal blood pool in 2, more than blood pool but less than the liver in 3, and moderately and markedly increased uptake in the lesions compared to liver blood pool in 4 and 5. These images show that dually 4 and 5 can depict either a partial response and even a stable disease and progressive disease. So a score of 5 does not convey the complete information whether the patient is responding or having a progression. Coming to the value of dual score in interim PET. Interim PET is a promising tool for personalized lymphoma treatment. The main intention of the interim PET interpreted using dual score is to use it as a prognostic marker, that is to assess whether the dual score based PET negative and positive status is predictive of progression-free survival and overall survival or not. And response adapted therapy, to explore the possibility of response adapted therapy. That is to de-escalate the chemotherapy or radiotherapy in PET negative patients so as to reduce the treatment related toxicity and escalate the chemotherapy to more aggressive therapies in PET positive patients on interim PET CT, thus detecting the poor responders early in the course of treatment. So to understand this, let us go through the classification of lymphoma. Lymphoma classified into Hodgkin's and non-Hodgkin's. Hodgkin's again divided into early and advanced stage. Early and advanced stage are treated with 2 to 4 cycles of ABVD plus involved field radiotherapy, and advanced stage with 6 cycles of ABVD or 8 cycles of BOPCOP with or without radiation. And non-Hodgkin's lymphoma, DLBCL is the main chunk, and which is usually treated with 6 cycles of R-CHOP. Not many studies are available. Data is available on follicular lymphoma, so I'm skipping that portion of it. So there are several trials that evaluated these lymphomas, including the UK Rapid Trial and H10 trial for the early stage lymphomas. In these trials, they explored whether bleomycin can be deleted from the regimen, avoided from the regimen after a PET negative status on interim PET CT, and also radiotherapy if it can be skipped if the patient is having a PET negative status. And in advanced stage, clinicians wanted to de-escalate the dose to ABD regimens by skipping ABVD, and also escalate the treatment to BOCOP if there was PET positive status. So these are the trials that explored these. The current discussion would not permit for the detailed discussion, so I just added the conclusions. So these are the conclusions of the several trials, where in Hodgkin's lymphoma, interim PET based, dually score based interim PET CT interpretation is a strong prognostic indicator and is superior to international prognostic score and response evaluated with CECT alone. And interim PET based response adapted therapy has proven role in advanced stage classical Hodgkin's lymphoma. In early classical Hodgkin's lymphoma, response adapted therapy fell short of the margins for the non-inferiority trials. However, it is marginally short of the non-inferiority levels, and hence it is of the discretion of the clinician after discussing with the potential risk and benefits with the patient. In DLBCL, the available evidence is variable, and in the interim PET, based on the Dewey score, is a good prognostic indicator, though end of treatment PET-CT is a stronger predictor. And treatment intensification in positive patients was not associated with improved outcomes and was, but with more toxicity. And hence, currently, there is no established role of response-adapted therapy in DLBCL. So this image shows the response-adapted therapy in advanced stage lymphoma, which is a proven role currently. After 2 cycles of ABVD, we do a PET scan. If it is negative, the bleomycin can be avoided for the next cycles, and an ABD regimen can be used. And for PET positive status, the treatment might be escalated to BOCOP regimen. Coming to the end of treatment PET-CT based on Dewey score. Assessment, the purpose of end of treatment PET-CT is to assess the remission status, which is more accurate with PET-CT than that of CT in both Hodgkin's lymphoma, DLBCL, and follicular lymphoma. PET-CT is of particular value in assessment of response of extranodal disease, which are otherwise imperceptible in CT. So we can see a lesion in the liver, which was intensely avid, which persisted to be the same even after the end of treatment CT. And PET correctly depicts the response in these cases. Coming to the challenges of Dewey score, there is no subcategorization for the Dewey 4 or 5, because these 4 or 5 scores represents both partial response, stable disease, and progressive disease. For suppose if a trial wants to include a Dewey score of 4 or 5 score for evaluating escalation therapy, a patient with even excellent partial response but categorized under 4 or 5 might be treated with the same escalated regimen as that of a patient with disease progression, which is is not justified as per many clinicians. And recently there are several studies that are mentioning that there is variability in the scores based on the change in the acquisition timing of the scans. And also upscoring is noted with the use of the newer reconstruction techniques for PET, and presence of fatty liver is found to affect the background liver uptake, which might affect the overall Dewey score. So this is an example patient where there was significant disease in the retroperitoneum and few deposits with inguinal nodes in the pre-treatment scan, where there was near complete resolution of the avidity in the retroperitoneum, and there was only one node, inguinal node, which was showing moderate uptake, which was higher than that of the liver blood pool. So a score of 4. However, the clinician feels escalating the regimen just for the sake of a single node with this moderate uptake is unjustified. So what is ahead for Dewey score? There are multiple PET-CT based quantitative parameters currently being proposed, including the delta ICV, metabolic tumor volume, and the tumor lesion glycolysis. So early studies are showing promising data with improved prognostic assessment when these parameters are used either alone or in combination with the visual assessment. However, standardization and validation of these quantification parameters is underway. In future, we may see delta SV max is one other singular standard parameter similar to Dewey score that might be used for the interpretation of the interim and end of treatment scans. Radiomix is also being explored to identify other potential imaging biomarkers. So with this, we conclude the Dewey score and move to the head and neck malignancies. For head and neck cancers, recently Hopkins criteria has been proposed for interpretation of post-therapy scans, and neck imaging rats has been proposed for interpretation of surveillance scans. We would just briefly go through these criteria. Hopkins criteria is similar to that of Dewey, where the background of internal jugular vein and liver are considered for reference systems. And in this study, they evaluated almost 214 patients with post-therapy scans and evaluated by 3 different nuclear medicine physicians. And they produced a strong, substantial inter-reader agreement. And the interpretation was having high negative predictive value and very good prediction association with the overall survival and progression-free survival. There were further validation studies published in 2017 and 19 where the Hopkins criteria has been proved to be promising. And the most recent Eclipse study says that after 12 weeks of concurrent chemoradiotherapy, PET-CT interpretation with Hopkins criteria was reliable. However, they said that the late manifesting residual disease might need a surveillance scan at 1 year. Coming to the neck imaging rats. This was an American College of Radiology proposed white paper where recurrence is evaluated on a scoring system of 0 to 4. 0 when there is no prior imaging available, and when there is no evidence of recurrence, we give a score of 1. When there is recurrence in the when there is suspected focal uptake in the superficial areas, a score of 2A is given, which might be managed with direct visual inspection, and a score of 2B is given when there is deep-seated, ill-defined lesions or focal areas of uptake with no significant enhancement. So these might be managed with short interval follow-up of 3 months. And lesions with the discrete nodule or mass on CT and intense focal uptake on PET-CT might be scored as 3, suggesting high suspicion, which and managed with biopsy. And lesions with obvious recurrence are scored as 4 and suggested further clinical management. This is one promising scoring system that might be incorporated into the routine practice. Coming to the myeloma. The Italian myeloma criteria has been proposed by Cristina Nani et al. For PET use, and they included both PET and CT components. PET, the bone marrow interpreted as diffuse and focal, and mentioning the sites of involvement, and CT interpreted for the lytic lesions, fractures, presence of paramedullary and extramedullary disease. This is an example image where there is uptake in the focal lesion in the liver. There are lytic lesions in the iliac bones and with soft tissue component in one of the bone. So the notation as per the impetus score would be the above one, where BM3, F2, extraspinal 5, L, extramedullary, extranodal 5. So this description gives the complete report in an annotated format. So this scoring has been studied by further people, and it is shown that there is significant prognostic significance of this scoring system when used alone or along with the volumetric parameters, including MTV. Coming to neuroendocrine tumors, the Krenning score and the NetPET score. Krenning score is a visual grading system of the pathological uptake. It was originally designed for planar indium pentatoroid imaging, and was named after Eric Krenning, who studied widely in this SSTR imaging. It is a semi-quantitative visual scoring system with a scale from 0 to 4 and uses the liver and the spleen as the reference organs. And though it was designed for planar imaging, it was found to be valuable descriptor for reporting the gallium dotatate PET-CT as well. Currently, it is being used for choosing patients for PRRT, with a scores of 3 or 4 are usually considered for therapy. The NetPET score. In this scoring system is used for the interpretation of combined SSTR and FDG PET imaging. It was scored from P1 to P5 based on the degree of uptake of on FDG PET-CT and dotatate. The lesions from P1 to P4A are possible suitable cases for lutetium therapy. P4B are patients that might need other therapy along with the lutetium therapy, and P5 is patients that might not benefit from lutetium dotatate therapy. This is one scoring system where which can help in deciding the aggressiveness of disease and deciding the management of the patients. Coming to the PSMA rats and SSTR rats, these have been incorporated into molecular imaging rats as a generalized framework. These molecular imaging rats gives a scoring of 1 to 5 and categorizes the lesions into uptake as benign lesions, equivocal lesions, and strongly possible lesions for disease, and recommends the further management, further workup for these lesions, and also helps in deciding whether PRRT or PRLT is useful in these patients. So to summarize, among the existing criteria, only PERSIST criteria and Lugano criteria are in clinical practice. Rest of the criteria are showing a few promising results. However, it needs further validating studies. To summarize, scoring systems are valuable tools in appropriately categorizing and communicating the outcomes. However, equivocal situations do exist. Hence, communication is the key, and combined reviews with and multidisciplinary tumor boards are needed for equivocal cases. Jubilee score has strong prognostic value in interim and end of treatment PET-CT. Interim PET-CT based response adapted therapy are validated in advanced stage Hodgkin's lymphoma and in early disease at clinician's discretion. Several NIBR scoring systems are being proposed for each malignancy. However, personally, I feel that it would potentially add more confusion to the clinician if we start reporting every malignancy with a different scoring system. So the need of the hour should be that the international professional society should collaborate and create platforms for creation of harmonized reporting and scoring systems that can be universally adapted. Thank you.
Thank you, Dr. Arun. Any questions?
Dr. Krishna Kumar Ratnam sir has joined. I think the topic is very relevant to sir.
Thank you, Hari. A wonderful presentation from the speaker. Of course, as he mentioned very clearly, interim assessment is becoming more and more important to tailor therapy for two reasons. One, for patients who achieve an excellent response, we can step down therapy to avoid toxic drugs and reduce the number of cycles of therapy, and in some cases avoid radiation. And in those not achieving response in interim assessment, there is increasing data to say that stepping up therapy can enhance survival. In fact, I think Hari must be remembering very recently, we had a publication, collaborative publication, along with 10 other centers, real world data of 409 patients. And those who achieved IPET complete response had an event-free survival of nearly 92% compared to 68 of those who did not achieve. And now we are actually running a multicentric study where those who don't achieve IPET CR at 2 cycles, we escalate these patients to BACOP 14 in Hodgkin lymphoma. So I think it's an ongoing study, so very relevant to what our speaker said. So we will soon have some data from our own patients, which will give us some more clarity. So anyway, it was a wonderful presentation, and once again, kudos to the speaker for putting things together. Thank you.
The theme of the conference was from infantry to precision strikes. I think until now we have shown us our soldiers, our machine guns, and from today morning our youngsters have been flying all around with Chetaks, light combat helicopters, Rafales, MiG-21s, and also the Sukhois. So before we go to the actual Agnis and Brahmos, we will have one quiz followed by some cyber attack from Dr. Madhur. Over to Dr. Sunita, ma'am.
Yeah. So the winner for the question number 18 is Harish Goyal. So the answer for is D, metastatic neck nodes with COVID pneumonia. So let's see question number 19 now. So the quiz can be answered like this. So this is a renogram. The upper images are the flow images and the lower down dynamic images. So these are the parameters. As I told you, GFR is 1/3 the value of ERPF. And these are the delayed pre-void and delayed images, dynamic and pre-void and delayed images. So once again, I'm showing you the dynamic and ROC curves and also the images. So the options are option A, urinary bladder diverticulum. Option B, supernumeral kidneys. Option C, right ureterocele. Option D, right obstructed megaureter. So I will show you the images once again. So over to the chairpersons now for the next talk.
Yeah, the next speaker will be Dr. Madhur from NIMS, Hyderabad. Over to Dr. Madhur.
Good afternoon, everybody. At the outset, first I would like to thank the organizers of Southern Chapter of Society of Nuclear Medicine of India, giving me this very interesting topic, grainy brains, from the infantry to precision strikes. First, we'll see the timeline of the brain imaging. Basically, it started from the first when the suggestion was given of cerebral blood flow was given in 1878 after Musso. Approximately after 72 years, the first gamma camera or the CT scanner that was invented. After 25 years, the first PET scanner was invented. And in 1997, the first PET MR hybrid prototype was made. So as you can see from the first concept, we have come a long way in the brain imaging as compared to nuclear medicine. This is the first image. As you can see that it was in 1985, 13/3/1985. You can see the brain image. It is very grainy. And from that, now we have transformed to such nice high precision imaging as seen here. With the advent of hybrid imaging, now we have a CT scanner which is attached to the PET scan. So we have got fusion PET CT images. And with PET coming of PET MR, we have PET MR images. And those who don't have PET MR, they have the softwares in which they can fuse the PET and the MR images to get such high quality images. How does this help? This is a case of an epilepsy. As you can see now with PET MR, we can fairly localize to the gyri where the hypometabolism is there. This is the case of an epilepsy in which this turned out to be FCD type 2. First of all, in brain imaging, as we say, there's SPECT imaging, there's PET imaging. SPECT imaging is ECD, HMPIO. PET imaging, again, it is FDG, F18, FDG, PET CT. It can be FTOPA. It can be receptor images. There are innumerable number of radioisotopes which are in pipeline for PET imaging. But the most commonly what we use is FDG, F18, FDG, PET CT, which we'll be talking about here. These are the common indications with which the patient comes for nuclear scan. Dementia, then movement disorders, whether it is idiopathic Parkinson disease or it is Parkinson plus syndrome, epilepsy, encephalitis, and tumors. But like in our institute, we have got a huge neurology department which has got TM courses also. And in our daily practice, approximately 20 to 30% cases are from neurology. In almost 50% cases are PET CT cases are non-oncological, and 20 to 30% cases are from neurology department. In fact, like yesterday also, we did some approximately 20 cases, out of which 7 were from neurology department. So what are the other indications with which the patient comes apart from these common indications? These are like orbital apex syndrome, pachymeningitis, cavernous sinus syndrome, inflammatory muscle conditions, peripheral neuropathy, ataxia, nerve palsies. Mind it, the PET CT is not used for the diagnosis of all these things. Most of the times when the patient comes to us, he will already have an MR, he'll have a diagnosis of orbital apex syndrome, he'll have a diagnosis of cavernous sinus, they will know that the patient has pachymeningitis. How we help is the related cause behind which causes this pachymeningitis, which causes cavernous sinus syndrome. That is the reason, that is the place where FDG PET CT or the nuclear medicine department plays an important role, especially in these other indications. So we'll see how this, how can we help in these cases. We'll see a few cases with that. So our first case, this is a 42-year-old female, right? She presented with right-sided headache, drooping eyelids, double vision, blurring of vision of right eye for the past 6 months, and MRI is suggestive of pachymeningitis. Her blood parameters are almost normal, except for that hemoglobin is 9.8 and TLC is 12,700. And the CSF analysis showed no cells, no no cells, and then the glucose, protein, and chloride are in the normal range. So basically, this patient has pachymeningitis, and apart from that, she has this double vision or the visual problem disturbances is there. So with this, we have what we can have in the mind. We can have orbital effect syndrome. We can have cavernous sinus syndrome. We can have Tolosa-Hunt. And with pachymeningitis, you can see there is a long list of differential diagnoses which can be there. Basically, it can be an idiopathic cause. It can be inflammatory causes. It can be like infection like tuberculosis. Then it can be fungal infection. Then Lyme's disease. It can be the viral infection. Then there are neoplastic causes like carcinomatous meningitis, lymphomatous meningitis. Then there can be other miscellaneous causes like spontaneous intracranial hypertension. Even after chronic hemodialysis, we can have pachymeningitis. So if you go by a usual normal routine pattern, this is the list which is given for the diagnosis evaluation of Tolosa-Hunt. Hematological test, long list is there, then CSF, neuroradiological, then biopsy. And this here is the list of all the investigations for the pachymeningitis there. So in our case, since we can say that we are having these cases for a long time, our neurologists, they have a better experience with FDG PET-CT. After the basic investigations and MR, we directly went for PET-CT. So this is, as you can see here, there is some hyperdensity is there in the region of cavernous sinus, which shows faint, like mild FDG uptake. It is involving the superior orbital fissure. It is involving the optic orbital apex. The thing is that in most of the cases, along with the dedicated brain study, we do a whole body FDG PET-CT study also. So these are the images of the whole body PET-CT study. Nothing very unusual. This is the coronal image. This is the MIP image. And in this case, we see that there is a mild uptake in the thyroid gland, apart from this brown part uptake is there. Usually thyroid glands uptake, it was only 3.5, SUV 3.5. We don't take into account. But in these cases, even this small amount of uptake becomes significant and it has to be reported. So the report which we gave was that PET-CT indicated some increased uptake in the soft tissue in the right cavernous sinus pachymeningitis. But the differentials which we included were first infective in view of low FDG uptake. It can be viral or it can be fungal. It can be Aspergillus or Cryptococcus, or it can be immune mediated due to thyroiditis or thyroid antigens. And with this, from that, the long list of differential diagnoses, we can rule out that all the granulomatous causes, whereas we don't have any other, in the whole body, we don't have any other evidence of granulomatous disease, any vascular disease and tumor. So with this, the patient underwent further investigations. Aspergillus, it was normal, 0.4. But if you see that later, the anti-TQ antibodies, it was positive. So based on these and the PET-CT findings, then the patient underwent the appropriate treatment and patient is doing well now. Second case, almost same history, double vision of left eye, left third no palsy, pachymeningeal enhancement, blood parameters, serum creatinine was raised, otherwise everything normal. Again, CSF, no cells, glucose, protein, chloride normal, TB fluorescence, negative incarnate, everything is negative. In this case, you can see that there is increased uptake here in the meningeal region. This in the pachymeningeal, increased uptake is there. In this case, the whole body, you can see this is the coronal image apart from these some nodes. Interestingly, what we saw was that there is increased uptake in the salivary glands, the parotids. Apart from that, in the there was this small, like you can say that the beginning of some fibrotic changes around the kidneys. Based on these things, then we suggested that it might be an IgG4 related disease. Patient underwent the biopsy of the parotid glands and it came out to be IgG4 related disease. This is a 47-year-old male. He had a history of extradural hematoma in 2018, for which he underwent right parotid keratectomy was done. He was all right for 1 year. After that, he started having symptoms, which was in form of inappropriate behavior, like laughter in inappropriate conditions. And he had memory disturbances, which were more of recent than remote memory. Recent in the sense he was not able to recognize people. He was not able to do his daily work. Apart from this, there was no history of hallucinations. There was no history of epilepsy. There was no history of vomiting, no history of headache. And his blood parameters were all of normal, within normal limit. We went ahead with the PET brain study in this case, as the patient was suspected to have dementia. So these are the images. You can see that there is marked atrophy in the frontal lobe on the left side with reduced FDG uptake. These are the other images. Apart from the frontal, we can say that there is this temporal also, which is involved in this case. So this was the case of behavioral variant of frontotemporal dementia. A companion case, 47-year-old female who presented. In her case, only complaint was speaking difficulties and unable to recognize objects, which was of recent onset. Again, FDG PET, you can see that there is reduced uptake in the frontal prefrontal region, and there is reduced uptake in this temporal region, which is very focal. But if you compare with the previous case, there was marked atrophy in the frontal and in the temporal region. The patient has marked atrophy only in the temporal region. There is some atrophy in the, maybe you can say it's a starting of the atrophy in the frontal, but there is marked atrophy in this even widening is there and this atrophy is there. So based on the imaging findings, that atrophy predominantly in the temporal region, along with the history of only chief complaint of speaking difficulty and able to recognize object. This was diagnosed as a case of non-fluent variant of primary progressive aphasia type of frontotemporal dementia. So with these cases, I would like to say that the take-home message is that neuronuclear medicine is still an unexplored field with there's a lot of scope for improvement, and we should work in that direction. A good extensive history, it goes in a long way in both in reporting, in increasing the confidence, and in reducing the differential diagnosis. And as I told, we have DM courses also, so we get very nice histories, and discussion with the neurologist help a lot. In fact, if I would have to talk about me, my knowledge has been manifold increased with the residents, DM residents to whom we talk, with the consultants, especially we have Dr. Jabin is there. She helps a lot. She explains everything such nicely, wonderfully. It's really like you can say, talking to her is like talking to a book. So discussion with neurologist helps a lot. And last but not the least, read, and read. It is said that our eyes sees only what our mind knows. So unless until we read, it will be very difficult to report a neuronuclear medicine case. Thank you.
Thanks, sir. Thanks, sir, for the wonderful presentation. I have a quick question, sir.
Sure, sir.
Sir, I'm basically a radiation oncologist. So for any malignancy throwing brain metastasis, we do PET CT. But along with we also do MR also. to rule out the leptomeningeal spread. Is there any chance in the future to replace the FDG with other tracers which don't have a physiological background uptake like PSMA? So we can avoid MR for those patients. So we can see the leptomeningeal spread in a better way, I'm saying.
Actually, like if you see, we are doing one study in which we are using gallium-68 PSMA in the glioma in cases to rule out recurrence versus radiation necrosis. So most of them will have a MR done, and then we'll do gallium PSMA PET. So as it said that PSMA as such is not the uptake of PSMA is not in the recurrence, but it is in neovascularization, which is coming along with the recurrence. So till now we are getting very encouraging results. Apart from that, our previous speaker, like he told FAPI, I don't have any experience with FAPI, but maybe in near future it might help a lot in these cases.
What about Hari? What's your comment? Do you have any comment on this?
I am very bad with brain imaging, sir.
Okay.
I have a question, sir.
Yeah, please.
Yeah, please go ahead.
We had a patient where a 60-year-old lady, she had a chronic headache for almost 2 months, and initial imaging was normal. So we treated her initially as trigeminal cephalalgia because of symptoms matched. Later, there was no response to treatment, and then serial MRI showed a growth in the right orbital apex. So later biopsied and found to have aspergillus. So my question is whether when there is a strong suspicion, because late onset trigeminal cephalalgia is rare. So when we have a strong suspicion, if there is any role for PET in MRI negative headaches.
Sure.
Okay.
Yeah, actually, this I would say is not an MRI negative, as you told that there was a growth in orbital apex.
Initial images were negative.
Initial images.
Normal.
So now there are two things actually in this initial image, whether she actually had any fungal infection, difficult, but surely we can do a PET CT to see whether it was there or not. Second thing is, as I showed, in orbital apex syndrome, there is a long list, and doing an FDG PET CT goes a long way in reducing the number of differential diagnoses. So it reduces the time for starting the treatment, it reduces the hospital stay, and it helps in initiating the treatment much faster. You can focus on what type of investigations you have to do instead of going for a routine investigations. And that's why in our institute, basically now the practice is that after the initial investigations and MR, they will come for PET CT. And then other investigations are directed accordingly. If you find something, some node, anything which can be excised, biopsy, they'll do that thing. If you see as the multiple, we get 2-3 cases of ptosis every month. If any lung lesions are there, anything, if you can say that it goes more in favor of granulomatous disease, then accordingly that I don't know how much the treatment changes, but we are able to make a fairly good diagnosis based on that PET CT.
We actually regularly use PET CT nowadays in our center also. Sometimes it directs away from the actual problem also. Sometimes we have cases like that, which finally was diagnosed of infected endocarditis, but actually was something else initially. So in that case, how to direct the patients to PET CT when it will be very sensitive? That was a doubt here. So when MRI is negative, how good is it to refer to PETs?
No, MRI negative, it might be two reasons. One is the operator, the subject who was examined might have missed it, or the disease was true negative. So, Madhur, do you think a true negative MRI, what is the role of PET CT?
Actually, if you talk about orbital apex syndrome, I have not seen any case till now in which the MR is negative, and then we have. But yes, epilepsy is one area, because we have a dedicated epilepsy program running in our center, and the maximum PET CTs what we get are all MR negative. And once we correlate with PET CT, we fuse the MR and PET images. As I show it, that the gyri, it is in what I had shown the picture, that gyri, it's very difficult to pick up only based on MR. Once we show that there is a reduced uptake there, then it becomes significant. So almost 50 to 60%, once we have done a FDG PET-CT, we revisit again and we find that, okay, this was the lesion, which it might be a very subtle lesion, which was pale, which was missed, but because we have a hypometabolism in that region, it becomes a significant lesion.
We basically can divide it into two different things. One is a structural problem and a functional problem. So your functional problem may be negative on MRI and it can be picked up with PET-CT. When it comes to a structural problem, the resolution of PET is not, it cannot be matched with MRI because of two reasons. One is the imaging equipment. Second one is the inherent physics. Okay, so inherent physics, whatever generation of equipment we have, we cannot solve that problem. I think MR equipment hardware has advanced to such a level that probably it has become an unquestionable role when it comes to structural image.
No way FDG PET can replace MR. Both modalities play concurrent role. That's why I told that all the patients who come to us will already have an MR. And they will have a certain diagnosis. And we have to find the cause behind that diagnosis. What is the cause, which is a treatable thing?
I'd like to thank the chairpersons, Dr. Anand Selokumar sir, Dr. Narendran, and the speakers for
thank you.
Wonderful session. So before we go to the next session on therapy, I like Dr. Sunita ma'am to show the last quiz. We'll follow this up with quiz questions for technologists, and the winners of morning Professor Arkat Gujraj Award also will be announced very shortly. Over to you.
Okay, thank you, Dr. Hari. These were the winners for the yesterday's quiz, day 1. So the quiz winner for question number 19 is Dr. Shivanand Bhushan. The answer is A, urinary bladder diverticulum. Now let's move on to the last question for the doctors, that is question number 20. So these are the planar images, anterior and posterior, and these are the intensified. It's a MDP bone scan, planar images, whole body images. So the options are, first, is it contamination or soiling of diaper? Option B is ischial mass lesion. Option C, testicular tumor. Option D, hydrocele. So I will show you the images again. So these are the options: contamination, ischial mass, testicular tumor, or hydrocele. Thank you so much for giving this opportunity. I will hand over the session to the chairpersons for the next topics.
Thank you, ma'am. Before we move to the session, I request all of you to visit the sponsor stalls once again. Usually we have sponsors from only our hardware and our suppliers, but this time we are having even pharmacological companies that are sponsoring us. So the next session is the therapy session. For the session, I'd like to invite Dr. A.C. Arun, my good friend and PGA alumnus, for chairing the session. He's a senior consultant and medical gastroenterologist from Velammal Hospital, Madurai. We have Dr. Saju, who is our senior consultant medical oncologist from Meenakshi Mission Hospital, and Dr. Krishna Kumar Ratnam, sir, who is the senior consultant and head of medical oncology, Meenakshi Mission Hospital. Over to you, sir.
Thank you, Hari. I'm very happy to be part of this wonderfully organized conference. And it's my pleasure to introduce Dr. Arvind Ravi Kumar. He graduated from Sydney University and he is presently placed in Peter MacCallum Cancer Center. And he will be discussing about the PSMA-based therapies.
Thank you very much for the invitation to speak on lutetium theranostics in prostate carcinoma, options, indications, and responses. I'll briefly speak about the clinical course of prostate cancer and focusing on metastatic castrate-resistant disease, and then speak mainly about lutetium PSMA therapy with an emphasis on the recent randomized trials that have been published, and finish with talking about approaches to patient selection and implications of that for treatment efficacy and sequencing. So there are now multiple therapeutic options for prostate cancer, and these red arrows show you that the castrate-resistant space has a lot of treatment options which were introduced around 5 to 10 years ago, which have now moved into the earlier phases of disease, including castrate-sensitive disease, and also the entity known as non-metastatic prostate cancer, so-called, as well as oligometastatic disease. So the clinical course of advanced prostate cancer, you have a castrate-sensitive phase, which traditionally was treated only with ADT, which works very well in about all patients virtually, but the duration of response is limited to 2 to 3 years. So in the modern era, ADT alone is not an adequate treatment for castrate-sensitive disease, and other therapies are additionally added in. In castrate-resistant disease, which inevitably develops after a period of time in the castrate-sensitive space, there are multiple effective treatment options available as well. And sequencing of these therapies is an area of great interest, as well as development of new therapies. So we now have multiple first and second line life-prolonging therapies in castrate-resistant disease. The first one was docetaxel chemotherapy, but there is also cabazitaxel chemotherapy, as well as the novel anti-androgens abiraterone and enzalutamide, as well as radium-223. When you look at the benefits of all of these therapies, the overall survival benefit, unfortunately, is still only measured in a median benefit of only several months. In the castrate-sensitive phase, however, most of these treatments work in a far superior manner to castrate-resistant disease, with survival benefits measured in several years rather than several months. The exception to that is actually cabazitaxel chemotherapy, which is not shown to have significant survival benefit in castrate-sensitive disease. Everyone in the nuclear medicine audience is very familiar and very excited about PSMA diagnostics and PSMA theranostics. This is the PSMA receptor, and a typical castrate-resistant patient with high PSMA expressing extensive bony metastatic disease, which shows you the potential of PSMA not just to diagnose disease, but also to treat the disease with therapeutic isotopes. So lutetium PSMA therapy has been conducted for over a decade around the world, but the first prospective study was performed at the Peter Mac and published in 2018. It was initially a 30-patient study, expanded subsequently to 50 patients, and we showed in a patient population which had basically progressed after all other therapies a PSA response rate of 64%. This is the 8 best responding patients, and those of you who do PSMA therapy would be familiar with this. There is a group of patients who have very remarkable and often very rapid responses with almost resolution of extensive metastatic disease with just a few cycles of lutetium treatment. The overall survival of these patients can be stratified by their best PSA response. So patients who have an optimal PSA response of 34% at a 12-week cutoff have a median overall survival of 18 months versus half of that in patients who don't have an early PSA response at the 12-month mark. Similarly, the PSA progression-free survival is also quite different depending on your early PSA response. It's a very safe treatment, and in our study, we showed that the rates of cytopenias are quite low, even in a heavily pre-treated population. And although there is apparently high renal uptake, longer-term renal injury is measurable, but quite mild. The commonest side effect is dry mouth, of which is generally mild. Very common, but generally very mild. Only a small number of patients develop severe xerostomia with lutetium PSMA, but unfortunately that's not the case with some of the other PSMA-labeled radionuclide therapies, such as alpha therapies. So the first randomized therapy with lutetium PSMA was designed at Peter Mac and conducted at multiple centers in Australia, which compared lutetium PSMA versus cabazitaxel therapy, which I mentioned earlier, is a life-prolonging therapy in castrate-resistant disease as a second-line chemotherapy. So the eligibility criteria for this study was progression post-docetaxel, therefore eligible for second-line cabazitaxel chemotherapy, and of course, progressive disease with rising PSA. We had strict imaging criteria with both PSMA imaging criteria with SUV max of 20 as the minimum eligible site of avidity. And also all patients underwent FDG PET scanning, so they had to have no FDG positive, PSMA negative sites of disease. And we were quite strict about the imaging criteria, and all of the patients who were screened were centrally reviewed prior to eligibility. So once eligible, the patients were randomized to up to 6 de-escalating cycles of lutetium PSMA or conventional cabazitaxel chemotherapy. Importantly, out of the 291 patients screened, 28% of patients were deemed ineligible on the basis of screening PET scans, either due to low PSMA expression or discordant FDG-avid disease. 200 patients went on to the trial. And the results of the trial show that while cabazitaxel had a PSA response of 50% in 37% of patients, the same response was seen in a significantly larger 66% of patients with lutetium PSMA. Similarly, progression-free survival, while the median PFS actually was similar in both arms due to this overlap of the curves early on, as we followed up the patients for longer, it's become very clear that lutetium PSMA therapy at the 12-month mark provides a superior outcome, with 19% of patients progression-free at 12 months, compared to only 3% of patients progression-free with cabazitaxel chemotherapy. The second major trial, which has been published in the last 6 to 8 months, is the VISION trial, which is an international multi-center study recently published in the New England Journal of Medicine. It has a slightly different trial design, in fact, a significantly different trial design, with patients eligible on the basis of PSMA positive disease and previous taxane and anti-androgen therapy. However, the nuance is in the way PSMA positive disease was defined, and also the best standard of care that was allowed as the control arm. So patients who progressed on novel anti-androgen therapy, if they were randomized to the best standard of care arm, were unfortunately not allowed to have further radionuclide therapy or chemotherapy, but they were allowed to continue their novel anti-androgen therapy or switch to an alternative anti-androgen therapy, which we now know does not lead to any superior outcome. And the other arm was lutetium PSMA, but the patients were also allowed to continue their other standard of care at the same time. Alternate primary endpoints were radiographic progression-free survival and overall survival. As I mentioned earlier, the inclusion criteria were different to the therapy study. There was at least one PSMA positive metastatic lesion, but the definition of PSMA positive was higher than liver uptake, which is a much lower level of PSMA expression than was used for the therapy trial. The PSMA negative lesions were defined on the basis of anatomical imaging with lymph nodes of 2.5 centimeters and solid organ or soft tissue component of greater than 1 centimeter, which were PSMA negative as exclusion criteria. So based on these different imaging screening criteria, the exclusion rate of patients from this trial was around 12% as opposed to 28% with the therapy trial. So the majority of patients went on to have lutetium PSMA therapy, or went on to be randomized to be included in the trial to either receive lutetium PSMA therapy or the alternate standard of care. The overall survival was significantly superior with the lutetium arm, with a median overall survival of 15 months versus 11 months for the standard of care arm, with a significantly better hazard ratio of 0.62. Similarly, PFS was also significantly superior for the lutetium arm. So the combined results of the two trials show that we have overall survival benefit demonstrated in the large international multi-center VISION trial, and the therapy trial demonstrates superior results to cabazitaxel chemotherapy, which is a known life-prolonging chemotherapy, but the superiority at this stage is measured in terms of PSA response and progression-free survival rather than overall survival. The treatment is extremely well tolerated with good quality of life and very manageable toxicities. So we now add lutetium PSMA to this long list of therapies as another effective therapy in castrate-resistant disease. The major controversy in the field is actually when to use this disease, this treatment, rather than whether you should use this treatment. And there's increasing interest now in also using lutetium PSMA in earlier phases of disease, as I'll touch on later on. Not everyone responds to lutetium PSMA, and there are variable responses rates in the literature, especially there's a large body of retrospective literature and multiple meta-analyses showing that the PSA response rates can be very heterogeneous, as low as 30 to 35% in some studies. And the variable response rates may be explained by multiple factors, including the inclusion criteria on imaging, the way you screen for PSMA negative disease, as well as factors about the intensity of the delivery of the lutetium PSMA therapy, and of course, intrinsic patient prognostic factors, which could be different in different studies. One of the major points that we always like to emphasize at Peter Mac is the careful imaging criteria for selection of patients. So this is a patient with a very high SUV max, high burden bony metastatic disease on a PSMA PET scan. At face value, seems like a very suitable candidate for lutetium PSMA. But when you screen the same patient with an FDG PET scan, you uncover very extensive hepatic metastases, which are very difficult to see on lutetium PSMA, certainly not to the same extent as on the FDG scan. So on the basis of these anatomically discordant FDG positive sites of disease, a patient like this would not be treated at our center because they have too much disease which cannot be targeted with lutetium PSMA. So there are numerous phenotypes that have been recognized with this dual FDG PSMA PET scanning. The obvious phenotypes are on the left and on the right, which really don't require an FDG scan. Certainly the one on the left does not require an FDG scan. Very low PSMA expression throughout the metastatic disease. Whether the FDG PET scan shows uptake or discordant disease is not particularly relevant. With very low PSMA uptake, likelihood of benefit is low. This patient, while they have high PSMA expression, as another example of a patient with FDG positive sites, which are PSMA negative, we would consider unsuitable, although there is some debate as to whether there would still be some benefit with lutetium therapy in patients like this. There are a group of patients which have high PSMA expression and high FDG expression, but no sites of discordance. And we are quite happy to treat patients like this at Peter Mac, although we do have some data suggesting that they do represent a poorer prognostic group. And this is your classic patient with high PSMA expression, low or no FDG expression, and obviously considered very suitable for lutetium PSMA therapy. So there are different philosophies and goals of treatment of care, which drive some of these treatment decisions as well. So if your philosophy is to maximize access to lutetium PSMA and minimize barriers to entry, this might be a perfectly good philosophy in a last line palliative approach setting, and especially if a patient is very symptomatic. You know, why go through lots of screening investigations when your goal of therapy might be pain relief or a small improvement in quality of life. So an approach like this would allow more patients to be treated, but certainly you would have a very heterogeneous patient population, heterogeneous and poor patient responses in terms of PSA response rates and overall survival rates. But you know, it's not out of question that some of these patients may still benefit to some extent with lutetium therapy rather than derive no benefit. And how many of these patients you treat might then become also a question of, you know, access to care and access to basically economics in terms of whether the treatments can be afforded either by the health system or by the patient. The other philosophy is to use all available screening tools. So you select the patients who are most likely to benefit, so you're not wasting your resources on treating patients in a futile manner, and also select patients who will actually have a good response to this therapy. And this philosophy is increasingly important if we are treating patients earlier on in the course of disease where there are multiple other therapeutic options. It, to me, makes a lot of sense to select patients carefully and make sure that if you're treating a patient with lutetium PSMA when they might have, you know, 2 or 3 other lines of therapy available to them, then you really should ensure that you do what you can to ensure that you know, PSMA is most likely to benefit this patient rather than one of the other conventionally proven treatments. This sort of approach also allows, importantly, in a clinical trial setting, to have careful patient selection and more homogeneous patient populations to get accurate and reproducible results in clinical trials, which might then allow approval of these therapies by funding bodies. So how can we advance PSMA theranostics as it currently stands? Well, there are multiple approaches. We can use different isotopes or different ligands. It doesn't need to be lutetium and it doesn't need to be a small molecule. We can also upregulate PSMA expression using anti-androgen therapies. We could look at combining lutetium with other treatments such as radiosensitizing PARP inhibitors or chemotherapies or potentially even immunotherapies with radiotherapy. And also look at further refining selection and dosing of patients with imaging, radiomics and dosimetry, etc. There are also an array of clinical trials underway exploring exactly these sorts of options and also looking at lutetium PSMA therapy in phases of disease other than, you know, castrate-resistant disease or earlier in castrate-resistant disease, and even with the upfront and lutectomy trials looking at disease in castrate-sensitive populations, and in this pilot study even prior to prostatectomy. So in closing, it's very clear that lutetium PSMA is here to stay as an additional therapy in prostate carcinoma. There's a rapidly increasing evidence base. It's a very well-tolerated therapy, which is very safe, high efficacy, especially if you're careful about which patients you select for lutetium PSMA therapy. And it's been a very well-embraced therapy. The controversies is more around the exact place of lutetium PSMA and when it should best be used rather than should it be used. Future directions are around optimizing combinations with other therapies, optimizing the schedules of the therapy itself, and sequencing and role of lutetium PSMA in relation to all the other therapies I mentioned earlier. PSMA is a very attractive target, not just for nuclear medicine, but there are also a range of other PSMA-based therapies which are being investigated in the wider oncology sphere as well. So thank you very much for your attention. I'll leave you with a picture of our department taken several years ago, where everyone was looking younger, but certainly we are all still very happy and grateful to be working at Peter Mac. Thank you for your invitation, for sharing our experience with you.
Since Dr. Aravind is traveling, we can have the questions at the end of the next talk. Dr. Raghav will take the questions for Dr. Aravind.
We'll go ahead with the next session. The speaker for the session 2 is Dr. Raghav Kashyap, who is an MD in nuclear medicine, and he is also from the Peter Mac Cancer Center. Over to you, Dr. Raghav.
First of all, before I begin my talk, I would like to extend my sincere thanks to Dr. Harishankar for organizing this wonderful meeting and giving me. So we all know the concept of targeted imaging and targeted radionuclide therapy, where we have a specific receptor that is expressed on the surface of the cells, like the somatostatin receptor in neuroendocrine tumors. And we have peptides which bind to the receptors, octreotide and octreotate in the current example. And we link radionuclides for imaging purposes such as indium or gallium for visualization of the tumor, and therapeutic radionuclides emitting high energy beta such as yttrium-90 or lutetium-177 for treatment purposes. So to summarize, PRRT or peptide receptor radionuclide therapy is very highly specific and targeted therapy aimed at neuroendocrine tumors. So this treatment is used in metastatic or inoperable tumors with somatostatin receptor expression, such as the gastroenteropancreatic neuroendocrine tumors, bronchial neuroendocrine tumors, pheochromocytomas and paragangliomas, which also express somatostatin receptors in high extents, and medullary thyroid carcinoma and neuroblastomas. So talking about indications, when do we treat the patients? More commonly, before starting PRRT, we can see that the patients are started on somatostatin analogs as the initial set of treatment. So we have, for example, this particular patient who was started on somatostatin analogs. Now, we can see that after in the second scan, there is a definite increase in the SUV of the lesions. The lesions appear slightly more prominent, especially the lesion in the segment 8 here, compared to the previous scan. So what we are actually seeing here is an altered biodistribution after initiation of somatostatin analog therapy, which can be seen in the form of reduction in the thyroid uptake, which is usually low grade, with and we can usually seen in the baseline study, which disappears or becomes less apparent after the starting of somatostatin analogs. And the SUV of the lesions also might increase, but we should be careful and not consider this as actual progression of disease, and this is just an altered biodistribution. As we can see in this particular example, the disease has not progressed significantly, even though when it is followed for a long period of time from 2018 till 2022. So what actually, when do we actually consider as an indication for treatment is when there is a true progression, as we can see here, where the number of lesions and the size of lesions have also increased, especially this particular lesion here. And when there is appearance of new lesions, yes, that is definitely an imaging progression, and that can be considered as an indication for treatment with PRRT in metastatic neuroendocrine tumors. Now take another example. Here in this patient, there are multiple liver metastases and there is a mesenteric lymph node. If we follow the patients on imaging till throughout the course, as we can see here, it doesn't look like there is significant change in the imaging appearance of the disease. But can there be an indication in such patients for treatment with PRRT? Yes, there can be. For example, in this particular case, the patient had very severe and troubling hormonal symptoms in the form of diarrhea and flushing, and the patient had diarrhea of up to 8 times a day. It was very troubling for the patient, in spite of starting on somatostatin analogs, where we can see again by the altered biodistribution where the thyroid uptake is reduced. And so symptomatic control is another good indication, especially this is seen in secreting small bowel neuroendocrine tumors with metastatic disease, and especially well differentiated low grade tumors. So symptomatic, at this point of time, this patient was treated with 4 cycles of induction PRRT, and symptoms significantly reduced. The patient put on 25 kilos of weight after the PRRT, although the imaging appearance actually was stable, and the diarrhea was controlled significantly from 8 times a day up to 3 times a day. So symptomatic disease is also one of the indications for treatment, selecting the patients for PRRT. Now, these are the kinds of patients whom we should exclude from treating with PRRT. Here we can see that on the FDG PET, there are sites of disease in the liver which are not apparent on the GAT8 or DOTA-TOC study. So the treatment with PRRT in such cases would be futile, and the disease sites which are FDG avid will progress despite the PRRT. So these are not good candidates for PRRT. Among the other contraindications, we can see from the guidelines of the European Association of Nuclear Medicine, including pregnancy, other severe illnesses, and related contraindications such as breastfeeding and severely compromised renal and hematologic reserve. Now, before the taking of the patients for PRRT, they are given some pre-medications like dexamethasone and antiemetics to control their diarrhea. To control their nausea and vomiting, which is usually as a result of infusion of the peptide. Now, we all know that we have to use some kind of renoprotective agent because the peptide that we infuse is taken up by the kidneys, and we want to minimize the radiation damage to the kidneys from the peptide. So amino acids in the form of arginine and lysine specifically in the 25 grams each are used as renoprotective agents before PRRT. There are several formulations which are available, and there are several protocols also and discussed in the guidelines like a 2-day protocol, so on and so forth. We have done an observational study where we looked at the excretion of lutetium dotatate from, the serum levels of lutetium dotatate after administration. We can see that this graph shows a very bi-exponential pattern of concentration in the serum with a very rapid reduction in the concentration in the initial 2.5 hours, followed by a much slower exponential reduction in the concentration. So this initial rapid reduction in the serum concentration at 2.5 hours is from both uptake within the tumor and renal excretion as well. So amino acid infusion as such can have certain side effects like fluid overload or hyperkalemia and other nausea and vomiting, which can be sometimes troubling. And when you have patients who have normal renal function, like with a GFR, eGFR of more than 90, with this particular information and the following slide, which shows that the renal uptake with the 2.5 renal uptake of lutetium dotatate with 2.5 hour infusion of amino acids as compared to 4-hour infusion is not significantly different, or is not it's not much higher as compared to the 4-hour protocol, suggesting that you could possibly reduce the infusion time of amino acids in patients, especially who have a normal renal function. So coming to the treatment proper, we have a different isotopes from which we can select. Like most commonly we have lutetium 177. We also have yttrium 90 with a longer path length of the beta and higher energy of the beta, and indium 111 which emits Auger electrons, and it was used previously. So among these isotopes we can personalize the treatment based upon the characters of the disease that the patient has. For example, if you have a very large and bulky tumor which is more than 5 centimeters, the patient might benefit with treatment with yttrium because of its longer path length and higher beta energy, at least for the initial couple of cycles maybe, and then we can switch to lutetium 177. Presence of diffuse bone marrow metastasis or skeletal metastasis can be treated with indium 111 to minimize bone marrow related toxicities from other isotopes. Now the dose selection can also be titrated to the patients depending upon the age of the patient and renal function and hematological reserve, especially when the renal function is even below 60 eGFR. We can possibly give lutetium PRRT with a reduced dose of administration. Normally we give the dose that is prescribed is around 200 millicuries, but usually in India we give a slightly lesser dose of 150 millicuries. But when there is a deranged renal function, you could probably slightly reduce the dosage to suit the particular patient. Now sequencing, as I have talked before, especially when you have a large burden of tumor which is dimension of more than 5 centimeters, you could probably initially treat with yttrium followed by lutetium depending upon the availability and other financial aspects. Then chemotherapy is often added to PRRT to enhance its efficacy, and presence of grade 2 disease or FDG avid and DOTATOC avid or SSTR expressing disease is favored phenotype for use of chemotherapy along with PRRT, especially if you have imaging evidence of slightly rapid progression of disease. Now depending upon the origin of the tumor, if they are small intestine or small bowel related, the 5-FU has been used, and if they are pancreatic neuroendocrine tumors, CAPTEM has been used as a radiosensitizing chemotherapy for PRRT. So that is one thing which can be used along with PRRT for enhancing its effects. The rate of infusion, you start with a slow infusion. Generally here at Peter Mac we start infusion at 5 micrograms per minute, followed by increasing it to 10 micrograms after 2 minutes, and then 20 micrograms and so on. So this is to limit the vomiting and nausea side effects from related to the peptide. So the rate of infusion can be controlled. And then intra-arterial delivery is an interesting concept, which there are proponents and there are opponents to the intra-arterial delivery. Proponents propose that there is increased retention within the liver metastasis by intra-arterial delivery. I think personally that strong evidence is required before we actually conclude that there is better delivery through or higher dose which is delivered to the tumors by intra-arterial administration of PRRT. So what are the things that we can expect in the post-therapy, immediate post-therapy following PRRT administration? Now, there can be a phenomenon of flare, especially with secretory tumors such as pheochromocytomas and paragangliomas, insulinomas, and small bowel carcinoids which are secreting hormones. And sometimes we can also have tumors which are secreting ACTH and resulting in Cushing's flare. So carcinoid flare and Cushing's flare are seen usually within immediate few days following PRRT. Accelerated hypertension is also seen for immediate few days following PRRT with pheochromocytoma and paraganglioma. Now, how do we deal with this? First of all, for pheo and paragangliomas, optimization of treatment prior to PRRT is essential. So the control of hypertension has to be done by discussing this patient or combined management, shared management with medical oncologists or endocrinologists or physicians. Same thing is for insulinoma. It's better to have an endocrinologist on the team to control the hypoglycemic episodes and optimizing the treatment either by continuous infusion of dextrose or high sugar containing diet for the patients and before the taking up the patients for PRRT purposes. Hospitalization may be considered for high risk tumors such as pheochromocytomas and paragangliomas and insulinomas, especially when the tumor burden is very high. Insulinoma, the symptoms can worsen even within few days following PRRT as well. So once the patients are discharged to home, the carers must be aware of the symptoms of hypoglycemia and they should be trained as to how to manage hypoglycemic episodes. Now, octreotide actually it can worsen hypoglycemia and that should not be given to treat hypoglycemia in insulinoma. Whereas for carcinoid crisis, we can give octreotide. The usual dosage is 250 to 100 milligrams, micrograms as a bolus, followed by infusion. Next, for follow-up of these patients, so usually the response assessment or restaging is usually done at 3 months following the treatment, and the further follow-up is dependent upon the grade of the tumor. So initially we do the restaging at 3 months. We can do dot imaging alone when you have a well-differentiated tumor which is previously known to be FDG negative, or if you have a previously FDG positive tumor, then you can do both GAT8 and FDG imaging at 3 months post PRRT. Interim evaluation with restaging PET scans in the middle of the PRRT at, let's say, after 2 cycles or 3 cycles, it's probably there's not much evidence to support that, and especially in neuroendocrine tumors which are not that fast growing, the point of doing an interim PET CT for response assessment might not have a strong role. But we can definitely do the post-therapy imaging instead of doing just a planar imaging with the lutetium dotatate. We can do a SPECT CT, which will give you a fair idea if there is any ongoing response through the cycles of the treatment. Next, further follow-up for grade 1 tumors, if they are not overtly symptomatic, we can follow up them at 12 months. We should remember that if especially there are small bowel tumors, an annual echocardiogram must be done to monitor the heart condition, especially for carcinoid heart disease. For grade 2 neuroendocrine tumors, the follow-up can be much closer at 6 to 9 months, and for grade 3, which usually have a very high rate of proliferation, you can have follow-up at 3 months. Now, here is an example of case where you have a metastatic neuroendocrine tumor of the small bowel, grade 2, Ki67 of 20%, diagnosed in 2011. Now, this patient was treated with PRRT in 2017, and we can see that there was a good response in the hepatic metastasis following PRRT. Now, the patient was followed up subsequently with serial gallium dotatok PET scans. There was good control of disease till 2020, and in December 2021, the latest scan, we can see that there is progression of disease with the appearance of new bone lesions. Now, this patient, having been treated with PRRT, has progressed further. So what do we do in such scenarios? Now, this is an interesting concept. Even at the time of progression, the disease is highly somatostatin receptor avid. We can see here that there is almost crenin 3 to crenin 4 uptake in all the sites of the tumors. Now, conventional wisdom in other tumors, other solid tumors, is once they have progressed on a particular line of chemotherapy, they are switched to a different line of chemotherapy. But with PRRT, these patients can be further treated with maintenance or retreatment with PRRT on progression post initial treatment, post induction treatment, if all the sites of disease are expressing somatostatin receptors and there are no discordant FDG positive and dotatok negative sites. So that is one interesting concept which we need to know and which we can potentially practice. Now, this patient which I have discussed before, who where the patient was benefited for symptoms with PRRT in 2012, was followed up for a long time, for almost a decade. And whenever this patient, you can see that the overall the disease burden has not changed significantly, but whenever there was a flare of symptom which was not controlled with medical therapy, PRRT was administered for this patient, and every time there was good symptomatic control in this particular patient. So induction 4 cycles followed by maintenance 1 cycle, another cycle here, and 2 cycles most recently in 2021. So what is the evidence with respect to maintenance or retreatment with PRRT? There are several studies which have been published looking at the safety and efficacy of retreatment with PRRT in patients who have previously been treated with induction and progressed on follow-up and retreated with PRRT. So this is called by several terms, either as maintenance PRRT or salvage PRRT or retreatment. So all these terms are used for the same thing, and you should not be confused. Now, the maximum highest data number of patients who have been treated is from this particular paper, which was published in 2019, almost 194 patients. Now, most of these studies have used salvage PRRT or retreatment only when there was imaging progression and all the lesions showed further somatostatin receptor expression. Now, most of the studies show very good disease control rate and efficacy of salvage PRRT. This is a meta-analysis. Now, the statistics show that the disease control rate was again almost close to 80%. Overall response rate was 17% in all the studies combined, and PFS was around 14 months and overall survival of 26 months. But if you take a closer look, the toxicity is also significantly higher. Hematological toxicity of almost 11%, and renal toxicity is also a potential complication, which we can see. Comparing the salvage or retreatment of PRRT with initial PRRT, although the response rates are reasonable, but they are not as good as with initial treatment. That obviously we can hope that after the initial PRRT, whatever the clone of disease that is remaining is probably much more resistant, and it has the response rates can be expected to be slightly less, and the disease control rate was also less in this particular meta-analysis in the subset of patients that have been described in the studies previously listed. The hematological toxicity was higher in salvage PRRT compared to initial PRRT, and renal toxicity was also higher in salvage PRRT compared to initial PRRT. And renal toxicity, hematological toxicity is something which we need to keep a very close eye upon. Thrombocytopenia is frequently noticed, and myelodysplastic syndrome, although uncommon, is not something which we can neglect. We have to keep an eye upon, and we have to educate the patients, and because you never know which patient has which will have the side effect. So that is something which we all need to be aware of, and we should take into consideration, and we should not go with a blind faith that PRRT is without any side effects. This is an interesting protocol of maintenance PRRT, which this particular center from Canada is following. After initial PRRT with up to 150 millicurie, a maintenance of 50 to 100 millicurie every 6 months for up to 4 years after induction treatment was followed. Now, this is something like a metronomic chemotherapy that is usually done in head and neck tumors with metastatic disease. The side effects of chemotherapy are reduced, and with a reduced dose, the disease can still be controlled. Now, whether this particular protocol is better than doing retreatment only when there is progression of disease, we do not know. This group has shown that their PFS was around 47 months. They have taken grade 2, grade 1, grade 2 patients, which is definitely better PFS, but there is no control arm here, and we should not just draw the conclusion that this is something which can be used in all treatment, all the patients, especially in Indian setting where patients have to pay for the treatment. This might not be a feasible option, but just for discussion's sake, I am mentioning this particular protocol. Now, there is one thing which I would like to bring an attention towards, that is the peritoneal disease in neuroendocrine tumors. It is not a very common presentation, but it can occur. We can have ovarian, omental, and obviously mesenteric lymph nodes are also there. But serosal and omental disease is very slightly unusual pattern. Now, the disadvantage with this particular pattern of disease is that the delivery of radiation dose to the peritoneal sites is not very good, and the outcomes, the disease control is not that good with peritoneal disease. Now, this particular patient was treated with medical therapy till 2020, and in 2021 June, when the disease was progressing and symptoms, disease was progressing on imaging, especially with the development of ascites, and you can see here subhepatic deposits which were noticed. Volume of ascites was significant. The patient, it was decided to treat the patient with PRRT, but an unusual presentation, and it has an unusual complication as well. PRRT in patients who have peritoneal disease can lead to fibrosis of the peritoneum and the serosa, leading to small bowel obstruction. And this patient did develop small bowel obstruction after 2 cycles of PRRT, and he had to undergo surgical intervention for that. So this is something which we need to keep an eye, be aware. Okay, this is a very, very interesting phenomenon that can happen in tumors, neuroendocrine tumors. Now, if you look at the first set of images on the left side of the screen here, the gallium dotatok and FDG show high burden of metastatic disease to the liver. But if you look closely, the metastatic disease, there is central non-avidity of somatostatin receptors, which are actually highly FDG avid, and especially this lesion here and the lesion in segment 4 as well. You can see that the uptake of somatostatin receptor is very high in the periphery, whereas the central portion is highly FDG avid. So there is definite discordant metabolic activity in the lesions of FDG and somatostatin receptors, and especially the primary also we can see that it is more FDG avid compared to gallium dotatok avid. So obviously this patient would not be a very good candidate for PRRT, and in the same lines the patient was treated with CAPTEM. Now, the second set of images on the right side, this is post-CAPTEM treatment, and we can see that the FDG avid disease has completely resolved. There is complete metabolic response on FDG, and whatever disease is remaining is just the somatostatin receptor expressing disease, and it is, if you can compare with the previous study, much more somatostatin avid than previous study, and the discordant areas have gone down significantly. Now this is a phenomenon which Professor Rodney Hicks calls as fruitcake phenomenon, where the analogy is like if you have a fruit cake, and the fruit cake you dip it in let's say you wash it in water, the cake part or the sponge part is all washed out and you are left with fruit. So highly post chemotherapy, the faster proliferating the tumors which progress faster are controlled with the chemotherapy, and what you are left is with high somatostatin receptor expressing lesions, and at this point the disease is amenable for PRRT. So this fruitcake phenomenon is an interesting phenomenon which can occur in neuroendocrine tumors, and it's very useful for patients. So before once the patients are treated with chemotherapy, they can be rendered suitable for PRRT. This is another case again. Here you can see that on GAT8 there is photopenic area which is FDG avid and was treated with chemotherapy. Now it is becoming concordantly avid, and with treatment with PRRT the disease has significantly reduced in extent. What are the other new developments in the field of neuroendocrine tumors? This is a very upcoming and interesting test, the NET test, which actually looks at transcriptional profiling of the tumor tissue, that is mRNA analysis in the serum. It evaluates 51 markers, and it is very useful for identifying all types of neuroendocrine tumors, including small bowel tumors, pancreatic, bronchial, and few paragangliomas, and even insulinomas as well. The levels of these markers in the blood, as analyzed by the test, can correlate with disease status such as stable disease or progression, and it is very highly accurate for predicting response to tumors, response of tumors to PRRT as well. So this test is now being validated in several centers, and it might change how we practice the therapy tumors. Now we all are aware of NETTER-1 study, which has shown the utility of PRRT in patients of low grade disease who have progressed on somatostatin analogs. This is the first randomized controlled trial which has established the role of PRRT. But even though the PFS was significantly high, the overall survival in the lutetium arm and in the control arm was not statistically significantly different. So what I'm trying to say here is generation of data and results is very important. Although we have been using this treatment for over a decade, we might be biased as to how useful or how efficacious this treatment is, and we might sometimes overlook certain side effects, and we might overinflate the efficacy, but prospective randomized control trials are the way which can show some actual results as to whether it is. There are so many questions like is there use of actually, what is the benefit of using chemotherapy along with PRRT? Is it any better than PRRT alone, or is PRRT better than chemotherapy at all in the same set of patients? Is there any difference between the PFS or disease control with PRRT or chemotherapy? So all these questions can be answered by prospective trials. Now this data is it's a good time where many trials are being taken up, initiated in a prospective manner, looking at the utility of PRRT in several and trying to answer several of these questions. Then we have, for example, NETTER-2, which is looking at the role of PRRT in grade 2 and grade 3 somatostatin avid somatostatin receptor avid disease. And then we have compete trial, which is comparing DOTA-TOC with everolimus in gastroenteropancreatic neuroendocrine tumors. And then compose trial, which is evaluating inoperable well differentiated grade 2 and grade 3 net with we have the treatment arm as lutetium DOTA-TOC and control arm as standard of care, which includes Captem or Folfox or everolimus. So these are very two interesting trials which we need to keep an eye on, look at the results, whether to what extent they consolidate the role of PRRT. And another interesting tracer which is coming up in neuroendocrine tumors is copper 64 sartate, which has a longer half-life, and it enables delayed imaging, and it enables dosimetry evaluation, and with the aim of the feasibility of delayed imaging, it might be much more sensitive than gallium 68, where on delayed imaging you have washout from physiological areas like liver uptake, and you might be able to detect much more signs of disease. That is being evaluated in prospective trial. And you have parlunate, where the role of PARP inhibitors, which are actually radiosensitizing, as in the DNA damage repair is inhibited by these particular types of drugs, and whether there is any utility of using these PARP inhibitors with PRRT is being evaluated. And we have this particular trial which is being conducted in the Tata Memorial in Mumbai, the precedent trial, where they are trying to evaluate PRRT versus PRRT with chemotherapy in grade 1 and grade 2 disease. And control nets is another particular trial which try to evaluate again PRRT with Captem versus Captem alone or PRRT alone. This particular trial, they presented an abstract in ASCO in 2020, where you can see that PRRT with Captem showed significantly higher grade 3 and 4 toxicity, and PFS at 15 months was similar in both the arms. But this is with just small numbers, and we need to see after the completion of the full study what the results are. There's another interesting trial looking at PRRT as a neoadjuvant setting in high risk tumors which are at high risk for recurrence, pancreatic neuroendocrine tumors. So they are trying to evaluate the safety and efficacy of neoadjuvant PRRT followed by surgical resection for resecting non-functioning pancreatic nets at high risk of recurrence. So overall, it's a very interesting time. We hopefully will come up with much more useful data consolidating the role of PRRT. To summarize, PRRT is a very highly targeted and selective therapy aimed at somatostatin receptor expressing tumors and delivering high radiation doses to the tumors. It is of known efficacy and utility. The side effects are low, but we need to remember the side effects. We cannot completely ignore them, especially the hematotoxicity. And this is an interesting time where much prospective data to strengthen or establish the role of PRRT is being pursued world over. Thank you for giving me this opportunity.
Yeah, thank you, Dr. Kashyap, for a wonderful discussion. So I thank Dr. Harishankar for giving me this opportunity. Also, I am happy to see Dr. Arun after a long time, my batchmate. So without much delay, I am inviting our next speaker, Dr. S. Sumati. She's a lead diagnostic oncologist and expert in the field of theranostics from Miyot International Hospital, Chennai. Over to you, ma'am.
Sir, before that next talk, and we have one quiz. Sir, do you have any questions, sir? Krishna Kumar, sir?
Yeah, I just had two questions. Probably since Dr. Kashyap will take those questions, I think. The first question was based on Dr. Arvind's talk. So is there any difference that in their study they have observed between patients who have predominantly bone disease vis-a-vis a patient who has bone plus visceral disease, which is PSMA avid? So, so basically, as clinicians, we have that doubt when we refer a patient. Is all visceral disease picked up by the PSMA scan, or do we need to do definitely this hybrid method to pick up visceral metastasis? That's first question. And second, if a patient has visceral disease, is lutetium PSMA as effective?
Yeah, can you hear me?
Yes, sir. Please go ahead.
Yeah. Thank you. That's a very nice question and very pertinent question for this scenario. First of all, coming to the scan, visceral metastasis can be detected with PSMA PET scan. Sometimes liver metastasis might not pick up PSMA tracer. The reasons are not very clear. It's not very common, but sometimes it can, they may not show PSMA avidity. The incidence exactly, I don't have the numbers, but among other sites of disease, only the liver disease has been shown to be PSMA negative. And at Peter Mac, especially, this is a philosophy that they do both FDG and PSMA PET for all the patients before taking them up for lutetium PSMA therapy to make sure that there are no discordant FDG avid sites of disease. So second question, another very good question, which is clinically relevant, which you have asked. I think the response of visceral disease to lutetium PSMA. So nodal disease, usually it has been documented to respond really well. That is one observation which has been documented. Coming to visceral metastasis, patients with visceral metastasis to other organs like liver or lung, they don't tend to respond really well with lutetium PSMA. And very frequently we have found that they progress rapidly in spite of giving lutetium PSMA therapy, even if they are avid with PSMA.
So thank you, Dr. Kashyap. The other question was on the NET from your presentation. You had written about the follow-up criteria and you had mentioned grade 1, grade 2, and grade 3. So the lutetium dotatate therapy, is it, what fraction of your patients with grade 3 are you dosing them with this? Because as clinicians, once again, we were taught to refer grade 1 patients and grade 2 patients. And as you mentioned, patients who have a heavy disease burden, we normally treat them with some systemic therapy. And when there is some minimal residual disease in the patient, we prefer to send them off for dotatate, and after that they have a reasonable progression-free survival. But when it comes to grade 3, it has always been systemic therapy. So what percentage of your patients with grade 3 have you dosed, and then have you really found a good response in those patients with high-grade neuroendocrine tumor?
Yeah, it's a very nice question again. So we here at PTMAG, we treat a good number of patients of grade 3 disease with PRRT. And again, most of the times PRRT might not be the first option unless they are all sites of disease which are strongly somatostatin avid. But still, most of the times they go for chemotherapy. And once they progress on chemotherapy, then they are referred for PRRT. And we see very good responses in these particular set of patients. One of the papers which we have published is that FDG avid disease, which usually is a marker for higher grade, when the disease is both somatostatin positive and FDG positive, and you treat them with PRRT, they respond really well in most of the cases. But with grade 3 disease with Ki67 of more than 20%, and sometimes we have treated even patients with 50% showing SSTR avidity. These patients, they respond well, and at the same time, in keeping with the nature of the disease, they recur equally at a faster rate. That's why the follow-up is usually at a shorter intervals, at 3 months, 3-monthly intervals rather than 6 months or 12 months.
So chemo-refractory high-grade neuroendocrine tumors,
yes,
akin to small cell lung tumors also, in case if they have already failed 1 or 2 lines of therapy and there is not too much of a disease burden but not very chemo responsive, they still can be sent for PSMA scan plus FTG. Sorry, not PSMA, sorry, Dotanot scan with FTG, something like a hybrid scan. And if they are both Dotanok as well as FTG positive, they still can be referred for lutetium therapy. That's, can I take that as a take-home
Exactly.
message from that point. Yeah.
Yes, exactly.
Thank you.
And that is the basis for the NETTER-2 trial,
Okay.
wherein grade 3 diseases also is being evaluated compared to control arm.
Because from our medical oncology point of view, somehow, this point has not been driven too hard in any of our collaborative meetings also.
Yeah.
So this was something which I've really heard it from straight from the nuclear physician. Thank you so much. Harry, that's from my side.
Thank you, Dr. Raghav. For people who don't know, Dr. Raghav is not just our close friend and senior. He's a teacher for all of us. He has taught us most of the concepts that we are using day to day in our practice. Thank you, Dr. Raghav, for joining us from Australia. Now, Dr. Arun, can you please show one quick question, and then we can go to Dr. Sumati ma'am's presentation.
Yeah, sure. So we have actually completed our 20 questions, routine questions. Now we have a special session for technologists. So there are 5 questions. These questions are meant only for technologists. So please note only technologists answer to these questions. And before that, I'll announce the winner for the 20th question is Nimagada Ajit. And the answer was hydrocele. Now this is a list of winners for today's 10 questions. Okay. So we move on to the first technologist quiz question. Just for any technologist who has joined just now, you find the option to answer the quiz at the right hand lowermost corner. You memorize the option and then give the correct answer. Okay, so this is your question. Now you are seeing an artifact. Okay, it's a technologist question. You are seeing an artifact. It's known as star artifact. Now the question is, what is the reason for this artifact? Is it PMT error? Is it septal penetration? Is it septal penetration? Is it due to patient coughing during the scan? A low energy of the iodine gamma rays. Once again, I'll show you the image and what is the reason for this artifact. You have 10 seconds to answer, and this is how you answer. Okay, that's it. Thank you.
Dr. Saju, you can now take over the session.
Yeah, thank you, sir. So our next speaker is going to be Dr. Sumati. She's a consultant nuclear medicine in Myoto International Hospital, Chennai. So over to you, ma'am.
Good afternoon. I would like to thank Dr. Harishankar and the organizing team for giving me this opportunity to present in this conference. I'll be now talking about radionuclide therapies of liver cancers. Hepatocellular carcinoma is the most common primary liver cancer with a poor prognosis, with about 2/3 of patients surviving for less than 2 years and less than 5% patients achieving a 5-year survival rate. The curative option of surgery is possible in only about 15 to 20% of patients. The BCLC classification system is the standard staging system in HCCs, which is based on the tumor characteristics and helps in assessing the prognosis and guiding therapeutic recommendations to patients. The intermediate, that is stage B, and advanced stage C diseases, in this group, the treatment option is usually palliative, and it is in this group that TARE as a treatment option fits in, especially in the setting of failed TACE or disease progression following sorafenib. Most of our patients present with advanced disease and present with portal vein tumor thrombosis in about 35 to 50% of patients at the time of presentation, and nearly 13% of patients present with extrahepatic disease. The various radionuclides that are available for treating liver cancers are yttrium-90 microspheres, which is the only FDA-approved radionuclide. Y90 is a pure beta emitter. It has a high maximum energy and a long half-life. And commercially, 2 Y90 devices are available, the glass beads and the resin-based spheres. Iodine and rhenium-labeled epidol are cheaper alternatives that are clinically being used in few centers in our country. And polonium-166, which has been developed and undergone phase 1 and phase 2 trials, has shown safety and efficacy which is comparable to that of 590 microspheres. It is important to ensure optimal selection of patients that will translate into clinical outcome. The treatment planning of TARE has to be done meticulously with a pre-treatment angiography, and this has to be a detailed hepatic angiography to look at the vascular anatomy to identify any arterial variants and non-target vessels that may need coil embolization before proceeding with the radioembolization procedure, and also to ensure that the lung shunt fraction is well within the permissible limits prior to proceeding with radioembolization. I'll be now taking you through the recent advances and the current evidence pertaining to TARE. Current major advancements have impacted the management of advanced HCC. In the last 5 years, there has been substantial progress in the development of systemic therapies. In fact, 6 systemic therapies, including TKIs, VEGF antibodies, and immunotherapies have been approved based on the results of the phase 3 clinical trials. The recent results from the SERSI registry for SERS-Fuse therapy, which is a large European prospective multicentric observational study, showed median survival of 16.5 months in unresectable HCC treated with TARE. 2 randomized controlled trials, phase 3, the SARA and the SERMENIP, which compared SERS-Fuse TARE with sorafenib, did not show any significant difference in the median overall survival of patients, though there was a significant improvement in the tumor response rates, that is the local disease control in both the trials, the SARA and the SERMENIP trials. The third, which is the SORAMIC trial, which compared combination therapy with TARE and sorafenib versus sorafenib alone, also was negative and did not show any significant changes or differences in the median overall survival between both the arms. Summary of these trials basically showed that though the results were negative, these trials were pivotal because they were the first randomized controlled trials for TARE, confirming the safety and efficacy of TARE in patients with locally advanced HCCs. TARE was better tolerated than sorafenib and was found to be non-inferior to sorafenib in terms of efficacy, and was superior in inducing tumor response compared to sorafenib. This is a case of advanced HCC with major vascular involvement. A 55-year-old male with NASH cirrhosis. He had a large left lobar lesion which was infiltrating the hepatic veins, the left and the middle hepatic veins, and the segmental portal vein, and the tumor was directly involving the IVC. And we can see that the tumor thrombus was extending up to the right atrium. This patient had TACE about 2 months ago, and his liver functions were well preserved, and clinically he was performance score 0. So we worked him up for TARE, and he had a normal lung shunt fraction, and we treated him with Y90 microspheres through selective left hepatic arterial catheterization. And 2 months post-TARE imaging shows significant shrinkage of the tumor and arterial enhancement of the lesion. In the coronal images, we can see significant shrinkage of the tumor and also significant reduction in the arterial enhancement of the tumor thrombus in the IVC. His AFP fell from the baseline levels and his liver functions were well preserved. He didn't have any hepatic decompensation. And this patient post-TARE had improved appetite and put on weight. He gained about 15 kgs of weight and he had a survival of about 11.4 months. So despite the dismal prognosis of this patient with major vascular involvement, we were able to provide him a good quality of life and a reasonable survival. And these encouraging results have been quite encouraging for treating physicians like us. The ability of TARE to downstage disease for liver transplantation. This is a 57-year-old seronegative patient with multifocal HCC, largest lesion seen in segment 4, non-cirrhotic liver background, and no major vascular involvement was seen. Patient was treated with TACE, followed by TARE, and then he had another sitting of TACE. This is the post-therapy scan, which shows good localization of the Y90 microspheres in the tumor. And post-therapy, the CT abdomen showed good response. PET-CT did not reveal any extrahepatic disease, and there was no disease progression at 6 months post-TACE and TARE. And in view of non-progressive disease, this patient went ahead with a liver transplantation. So the role of TARE in downstaging patients has been demonstrated in many studies, with over half the patients outside the transplant criteria downstaged and allowed to undergo liver transplant. Intrahepatic cholangiocarcinoma is the second most common primary liver cancers. They usually have poor prognosis, and most of these lesions are chemorefractory. This is a 48-year-old lady with unresectable, moderately differentiated cholangiocarcinoma who had completed 5 cycles of chemotherapy and was referred to us for TARE. Her lung shunt was normal, and we treated her with 1.6 gigabecquerel of Y90 microspheres through right hepatic arterial catheterization. And post-TARE images, you can appreciate good tumor necrosis and complete metabolic response of the lesion. In the coronal images, we can see reasonably good hypertrophy of the left lobe, and this patient underwent hepatic resection. She had an extended right hepatectomy. So now the current concept is moving from standard dosimetry with an average dose of between 80 to 150 grays to the concept of personalized dosimetry of boosted SERT, which involves dose intensification, and studies have shown that this helps in inducing prolonged overall survival in HCC patients with portal vein thrombosis. The Dosing Sphere 1 study, which compared personalized versus standard dosimetry, was a phase 2 randomized multicentric open label trial, which showed significantly higher overall response rates, survival rates, and median overall survival in patients who received personalized therapy with absorbed doses of more than 205 grays to the index lesion. The recent retrospective study, that is the legacy study, in fact supports the use of even higher dose of about 400 grays in BC, LCA, and C stage, which showed that it was able to induce not only a higher response rate, but also prolong the duration of response, that is, induced durability of the treatment response. The current concepts are also now moving from palliative TARE to curative options for HCC with radiation segmentectomy and radiation lobectomy procedures. Radiation segmentectomy is infusing the microspheres to 1 or 2 segments of the liver with an intention of ablating the segments. And this is usually in those patients which cannot be RFA'd. Radiation segmentectomy in about 102 unresectable solitary HCC patients in this study showed a good radiological and pathological correlation with partial and complete pathological necrosis, which was seen in nearly 50% of patients, and median overall survival was around 53.4 months, and about 32% of patients were transplanted with median time to progression of about 6 months. This is a young 28-year-old male patient whom we had treated. He had an HPV-related cirrhosis with a left lobar HCC and left portal vein thrombosis. He was treated with TACE twice before. So he had a diffuse lesion in the left lobe of the liver and a more focal lesion in segment 4. This lesion was supplied by the segment 4 branch arising from the right hepatic artery. So our intention of treatment was to treat the left lateral segments. He was otherwise well preserved. His liver functions were good, and the performance score was also good. He had a lung shunt fraction of 3%, and we treated him with 1.7 gigabecquerels of 190. These are the post-therapy scans, the bremsstratum, which shows good localization of the microspheres in the lesion. And the SPECT CT also shows good localization in the left lateral segments of the liver. Post-therapy Y90 PET CT once again shows good localization of the infused Y90 microspheres. And 8 weeks post-therapy imaging showed ablation of the left lateral segments post-TARE with significant decrease in the serum AFP levels. He had a time to tumor progression of about 13 months, following which he developed new right lobar lesions and lung nodules, and he survival of 20 months post-TARE. Radiation lobectomy is infusing the entire lobe. Recent studies have shown that this procedure is safe and effective technique for hypertrophy of the future liver remnant. The volumetric changes are comparable to portal vein embolization, and the particular interest is in the setting of bridge to liver section. The time-dependent analysis of future liver remnant volume in unresectable liver cancer as a bridge to resection showed that the volumetric changes, that is, in patients with predominant right lobar lesions, HCCs, intrahepatic cholangiocarcinomas, and metastatic liver disease, showed significant volumetric changes as early as 1 month, and significant right lobar atrophy, left lobar hypertrophy at a duration of more than 9 months following treatment. And the percentage of FLR hypertrophy was seen in about 45% of patients, and few of these patients were successful enough to undergo surgeries. So radiation lobectomy has been found to be superior to portal vein embolization, as it induces not only the atrophy of the treated lobe, but also treats the tumor simultaneously without hepatic decompensation, generates high rates of FLR hypertrophy, allowing for resection, and helps in the treatment of portal vein thrombosis. And the ideal candidates are those who would undergo curative surgery, like child A, resectable, and those with inadequate FLR. Coming to the newer molecules, especially FAPI and PSMA in imaging of hepatocellular carcinomas, these agents are being explored because most of the well to moderately differentiated HCCs are negative on FDG PET. Few studies have shown increased SUV max and tumor to background ratio on PSMA scans in the hepatocellular carcinomas as compared to FDG PET scans. And PSMA is being explored as a potential theranostic target based on few studies which have shown ex vivo expression of PSMA in the neovasculature of HCC. FAPI is fibroblast activating protein, which is a new molecule on the road. It is commonly expressed in the stromal fibroblasts in various epithelial tumors. Recent investigations show that FAPI shows improved tumor imaging with low background in the liver and brain. This was a study comparing FAPI with FDG PET in HCCs, which showed significantly higher sensitivity of FAPI PET in identifying intrahepatic HCCs in smaller lesions less than 2 centimeters in size and in well and moderately differentiated HCCs in comparison to FDG. And FAPI showed significantly increased tumor to background ratio. This is a 45-year male with chronic liver disease BCLC patient seen that we had recently imaged in our department. Patient had a large, diffuse, ill-defined, poorly enhancing infiltrated HCC in the right lobe and small lesions in the left lobe as well, with extensive portal vein tumor thrombosis. Here we can see that the FDG PET is negative, whereas there is significant FAPI uptake in the right lobar lesion. We can also see increased FAPI uptake in the background liver in this patient with cirrhosis. So this could be a caveat. In fact, FAPI is known to concentrate in liver fibrosis in exotic livers, and exploring FAPI as a therapeutic potential may be limited in this patient population of chronic liver disease and needs to be studied prospectively. So we went ahead and treated this patient, and these are the post-therapy Bremsstrahlung and the PET images, which shows concentration of the Y90 microspheres corresponding to the tumor blush on the angio. And interestingly, we see deposition of the microspheres in the tumor thrombus extending along the main portal vein and extending to the splenic vein. So to summarize, recent advancements have led to using TARE across all PCLC stages, early stages with a curative intent, as well as in the intermediate and locally advanced disease with portal vein thrombosis. Combination of systemic with local regional therapies is being perceived as promising in earlier stages of HCC, and higher doses can give curative outcomes, and it's important to have appropriate patient selection and exploring new targets for imaging and therapy of HCCs. Thank you very much for your attention.
Thank
you, ma'am, for the wonderful discussion. So basically, I have two doubts. First one is whether the TACE and TARE are interchangeable in clinical practice, or would you recommend a specific subset of patients where TARE can be preferred? And second question is that we know there is a lot of fibrotic activity in the patients with HCC in the neighboring liver. So would FAPI be a matter of concern, whether it would target normal liver parenchyma resulting in injury, ma'am?
So thank you very much, sir. First question is regarding TACE and TARE. Definitely TARE is much more clinically effective than TACE in larger lesions in diffusely infiltrative pattern of HCCs where there is extensive portal vein tumor thrombosis. Even though TACE has been given in most of these patients, it only results in partial response, and eventually we have to go for multiple sittings of TACE and probably a couple of sittings of TARE as well. So definitely TARE, we have to appropriately select the patients where we feel that TACE may not be appropriate. For example, very large lesions, 8-centimeter lesions and all. 1 or 2 sittings of TACE are not really going to help, even though TACE with DC beads have been used and have shown good results, but eventually they may need multiple sessions. So yes, so TARE definitely are much more effective in larger lesions with portal vein thrombosis. Secondly, regarding FAPI, I mean, as I showed in my one of the cases, one of the caveats is that FAPI does concentrate in fibrotic liver tissue, and this is a caveat in patients with chronic liver disease. We have to study. This is just 1 or 2 cases that we have done, wherein we have imaged these patients using both molecules, FDG as well as FAPI, but whether we can translate that into therapy in patients with pre-existing chronic liver disease is something that we really need to look at.
Thank you, ma'am.
Dr. A.C. Arun, you have any questions? Okay, if there are no questions, then I'll thank the chairpersons, Dr. Saju sir, Dr. A.C. Arun, and Dr. Krishna Kumar sir for chairing the session. And congratulations to all the speakers for doing a wonderful job. We move on to the next session, which is a therapy 2 session. So before we move on to the next session, we'll have technologist quiz number 2. Arun?
Yes, sir.
So this is before we move on to second question of the technologist quiz, the announce the first winner. The first question answer was septal penetration, and the winner is Ruth R. Okay, so we move on to second question. So I hope everybody knows how to answer. So which positron emitter has got the lowest positron energy? Option A is fluorine 18, B is O15, C is C11, and D is gallium 68. Which positron emitter has the lowest positron energy? So you've got 10 seconds to answer. This is how you answer. I think that's it. Okay.
Can I take over? Yes. Thank you, Dr. Arun. The second session will have 4 talks. We have Dr. Annapurni ma'am, who's a pediatric oncologist from Meenakshi Mission Hospital, who will be chairing the session, and joining her will be Dr. Danpati sir, who is a very well-known person among nuclear medicine community. He is from Jipmar, Pondicherry, and Dr. Krishna Kumar sir will be joining the session as well. I hand over the session to the chairpersons. Dr. Annapurni ma'am, are you muted?
Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah. Thanks to the organizing committee for giving the opportunity to chair the session. And thanks to Dr. Harishankar. Yeah. So without much delay, shall we go to the next session? I invite Dr. Sunita, Head of Department from AAG Hospitals, Hyderabad, who's a practicing diagnostic and therapeutic nuclear medicine for past 12 years and worked as senior residency in PJ Chandigarh and assistant professor in SPIMS Tirupati and consultant in Manipal Hospitals and Medanta City, the Medicity Hospital in Gurgaon, and senior consultant in Yashoda Hospitals. So main areas of interest is functional hepatobiliary scintigraphy in patients planned for major liver resection and therapeutic nuclear medicine, nuclear cardiology, and nuclear oncology. So executive member of Southern Chapter of Society of Nuclear Medicine. So welcome you, we are awaiting your presentation. Yeah, thank you.
Good afternoon, one and all. Thank you, Dr. Harishankar and other organizing team for giving me this opportunity. I will share my screen. Today, I will be talking about the role of targeted alpha therapy, South Indian experience. So, as we all know, radium chloride is approved by FDA in 2013. Once it is approved, there is a resurgence of interest in the development of alpha particles for cancer treatment. And there is a rapid potential, it is considered as a rapid potential alternative for cancer treatment. The main advantage of alpha therapy is its short range of penetration, that is less than 0.1 millimeters, and also the high linear energy transfer, which results to a double stranded break, and there is no known mechanism of cellular resistance. So the main advantage compared to beta emission is short range, that is around 20 to 80 microns, whereas in beta emission it is around 2000 to 11,000 microns tissue penetration, and high linear energy transfers around 100 keV per micrometer. These two advantages helps in the better treatment option compared to the beta emission, that is especially lutetium-177, which is the most common beta emitter used for cancer therapy. But there are certain major issues. First is a limited clinical experience. Very few data, few clinical studies are available. Most of the data which is available is on prostate cancer, that is metastatic castration-resistant prostate cancer, and also in the case of neuroendocrine tumors, which I will discuss in detail in the next few slides. And there is no known maximum tolerable doses, and also there is no consensus on the proper dosing, timing, administration route, whether it is intra-arterial or intravenous, intracavitatory, and there are no chemotherapy combination as such. Till now there are no clinical studies available, and there is no consensus on these data. So as we all know, in the case of radiopharmaceutical therapy, there are two main components, and that is tumor targeting vector and the emission particle. This emission particle may be an alpha or a beta or azel electron. So regarding the beta emission, Dr. Arvind and Dr. Raghav Kashyap explained in detail regarding this beta emission, beta therapy in the case of prostate cancer and neuroendocrine. So my talk will be focused only on alpha therapy. The alpha therapy, the main advantage, as I told you, is the short tissue range and high linear energy transfer. So there are numerous alpha emitting radionuclides which are available, but only a few are clinically used. Among them, actinium is the most commonly promising one which is used. The main advantage of actinium is the half-life of 10 days, which is it is produced from thorium generator. So because of this half-life of 10 days, it is the most commonly used because of its it allows easy distribution and also easy labeling. But the major limitation compared to the beta therapy is the mode of production, which is expensive. So the medicine is very expensive, and also high linear energy accelerators are used. So this is the decay scheme. Actinium is decayed to the stable bismuth. The most important daughter is the bismuth 213. It emits 4 alpha particles and 2 beta disintegrations, while it is decaying into the stable bismuth 209. So let's discuss regarding the actinium PSMA for therapy of prostate cancer. Around 9 to 10 articles are available in literature regarding the prostate cancer. And also later I will discuss about our experience in actinium therapy. So let's see what is PSMA. Hope Dr. Avinash has discussed in detail regarding the PSMA. This is nothing but a type 2 transmembrane glycoprotein which is highly overexpressed on the membrane in prostate cancer cells, and it correlates with the tumor grade, and it rises under androgen deprivation, and also in the case of castration resistant cancer, and it is a significant prognosticator for disease outcome. So this PSMA is tagged with actinium for therapy, and its theranostic pair is the gallium-68, which is used for the imaging so that the patient can be planned for actinium therapy just like lutetium therapy. So in the case of alpha therapies, 3 approaches are available in literature. One is dynamic de-escalation. That is, first high dose, like around 8 megabecquerel is given. Later on, the dose is reduced to 6, 4 and 2, depending upon the response of the PSMA. If there is no response, again the dose is increased. The main advantage of this de-escalation is the salivary toxicity is less. The other is a fixed approach, either fixed 6 megabecquerel or as we use 100 kilobecquerel per kg body weight. The other one is a cocktail where both actinium, that is alpha emitter, and the beta emitter are used at 50% of the respective single doses. That is, actinium usually is used around 8 megabecquerel. In this cocktail, 4 megabecquerel is used, and lutetium around 4 gigabecquerel is used. That is the cocktail. These 3 are available in literature. Let's see what the data reveals regarding each of these treatment approaches. So first is in the case of de-escalation study, Satike et al. Studied in 17 patients, administered around 8 megabecquerel initially and later reduced to 7, 6 or 4 depending upon the PSA response. He showed around 90% decline in serum PSA, and at the same time the main advantage is reduced toxicity. So main disadvantages of this actinium therapy is the salivary toxicity. This limits the treatment options for actinium. So by using the de-escalation therapy, the toxicity to salivary glands is reduced, but this is the number of patients is very less, around 17 patients. Next, Kratoji et al. They discussed in heavily pre-treated. The previous studies on chemotherapy naive patients, but these patients, 40 patients, they were heavily treated with the chemotherapy, lutetium, all the other therapies, androgen deprivation. In these patients, the study showed that there is a more than 50% decline, but as I said, the main side effect is a xerostomia. Here a fixed option of 100 kilobecquerel per kg body weight is used. Next is our Indian study, Yadav et al. They treated in 28 patients. two arms are there. One is refractory to lutetium. It's a prospective study. The other arm are radiotherapy naive patients, radiopharmaceutical therapy naive patients. That is the patients not received on lutetium therapy. This study showed good objective response in both the categories, showing that it is a good candidate for both lutetium refractory and also post chemotherapy metastatic castration resistant prostate cancer. In both the arms, it is quite useful, and the biochemical and molecular response is very good. At the same time, the major advantage is there is no grade 3, grade 4 toxicity, that is xerostomia. This is one of the recent studies which emphasizes the utility of actinium therapy in metastatic castration resistant in both the categories, that is both lutetium refractory and also the other chemotherapy resistant patients. This is one of the largest studies. Around 73 men were treated with 210 cycles of actinium therapy. Mainly the overall survival and progression-free survival is associated with a PSA decline, but previous lutetium therapy was a negative prognostic factor for in this study. And at the same time, there were only grade 1, grade 2 xerostomia was seen, and no severe xerostomia is seen. The last one, as I said, de-escalation therapy, fixed dose therapy. The other is a cocktail or tandem therapy. In this, it's a retrospective study. Both lutetium and actinium are used in patients, in 20 patients. It showed a biochemical response of 65% and only grade 1 xerostomia. So these three treatment options are available. We use the fixed dose of 100 kilobecquerel per kg body weight. Regarding our experience, the patient selection is the standard criteria, that is WBC count is around 2 Sg per ml, hemoglobin more than or equal to 8. If hemoglobin is less than that, we advise blood transfusions and platelets at least 75,000 and creatinine is 1.6. And we ensure that the ECOG score and life expectancy is around 3 months. And all these patients are planned with the gallium-68 PSMA PET CT, and the lesions should be more than or equal to at least liver. And if there is any symptoms of renal obstruction, then DTPA scan is planned. Before each cycle, the patient are going to go complete blood counts, kidney function test, liver function test, and serum PSA, and the ECOG score and pain score is also documented, and ensure proper hydration, and usually no pre-medication is required. But if there is a severe bony pain, then the patients are started on oral steroid therapy, which is tapered slowly based on the response to the actinium therapy. And we follow the cooling of the salivary glands. FES study by Satige et al. Showed that if the patients are given ice packs to the salivary glands, there is a chances of xerostomia is less, though it is not proven, but we are routinely using in our department. So totally 9 patients with a confirmed metastatic castration-resistant prostate cancer have undergone treatment in our department, and the fixed dose of 100 kilobecquerel per kg body weight is used intravenously. And post-therapy scan is done in a gamma camera using a medium allergy collimator. So treatment response, all the patients had excellent response to a treatment. One patient on a wheelchair with extensive bony metastasis, he had a good response. He was able to walk with the support with 0 painkillers, and the other patient who was also wheelchair bound was able to walk post actinium therapy. So we usually give this therapy with extensive bony metastasis with a severe pain. We are directly going with actinium therapy without giving the option of lutetium therapy, provided the patient is affordable. And the scan is performed after 8 weeks of actinium therapy. So there is a more than 50% decline in PSA in 80% of the patients, and partial response is seen in 70% and stable disease in 10%. One patient is lost to follow-up after one cycle. Though the patient had a good symptomatic relief, there was no scan for this patient. So this is the baseline MIP image, which this patient was a 72-year-old male with a metastatic castration-resistant prostate cancer who was progressing on chemotherapy with a 20 centimeter mass in the left shoulder. After one cycle, clinically there was no palpable mass, and the pain was significantly reduced. So this patient was given a second cycle of chemotherapy after 4 months. So they almost negligible lesions with a good treatment response. So but this patient had grade 3 xerostomia, so we thought we will wait till the symptoms appear. So after 1 year, the patient had a back pain and reappearance of the mass lesion with a severe pain. This patient was started on steroids, and the third cycle of actinium was given in September. So this patient is doing fine now. So this is the 20 centimeter mass in the left scapular region, which is reduced significantly post 1 cycle and 2 cycles. And after 1 year of the second cycle, this patient had again the mass with the restriction of the shoulder movement. Next patient with extensive skeletal metastasis with a primary lesion. This patient was wheelchair bound with a severe pain and on continuous infusion of morphine and fentanyl patch. This patient was given 1 dose of actinium. There was a significant pain relief, and the patient was able to walk with a support with occasional painkillers. The patient is doing fine. So this is the sagittal image showing good response to treatment, and the axial images showing these are the post 1 cycle of chemotherapy, post 1 cycle of actinium therapy. So let's discuss about the neuroendocrine therapies. So though our experience in this neuroendocrine therapy is less, literature also shows only 2 studies. One study was done in one study was done in 2014. This provoked most of the people to use lutetium the alpha therapy in neuroendocrine tumors. In this study, 6 patients were treated with intraarterial infusion because of the liver metastasis, and 1 patient with a bone marrow involvement with a systemic. Because of the promising data with a partial remission, one Indian study is done. It's a prospective study. 32 patients were treated who were on stable or progressive on lutetium therapy. So partial remission is seen in 15 patients and stable disease in 9 patients, and there was no documented disease progression or death. This is an Indian study which is recently published in April 2020. We had treated in 3 patients with metastatic gastroenteropancreatic neuroendocrine tumors who were progressing on lutetium therapy or somatostatin analogs. The 3 patients had stable disease. So this the representative image, this patient had a pancreatic NET unresectable, encasing the portal vein near the confluence, infiltrating the superior mesenteric vessels. So after 1 cycle of dotatate therapy, there was no significant change in the size and metabolic activity. So this patient was not willing for the second cycle in view of a financial constraint. So this patient was referred for the somatostatin therapy. So these are all the few studies in other malignancies where alpha therapy is used, like multiple myeloma. All these are few anecdotal studies. 1-2 studies are available in the other malignancies. So no, only sufficient data is available. With our experience, we feel that actinium PSMA therapy is quite useful, especially in the case of patients with a severe pain, where we can see instant relief within 2 to 3 days. In 9 patients, 9 of our 9 patients had a very good pain relief. Thank you so much for giving me this opportunity.
Dr. Janpati, Dr. Annapurnima. Sir, please unmute yourself, sir.
Thank you for the giving this opportunity to chair this session.
Do you have any questions?
No, I just wanted to comment that I think Dr. Sunita has shown very good response with alpha emitters in few of the patients, very excellent response. So I think alpha emitter usage radionuclide therapy is a very promising this thing. But what my comments is just, I think its availability and the cost is the major limitation, I think, at present. Yes. That is the major limitation. Because most of our Indian patients, affordability is one big issue. So that is the point.
Yes.
So we can. So shall we move to the next talk?
Any other questions we have?
Any other questions? Yeah.
Okay, sir. Before we go to the next speaker, can we have one technologist, please?
Yeah, sure.
Okay. So we move on to the third question, but before that, I'll announce the winner of the second question. The answer was 18F fluorine, and the winner is Elizabeth Babu. Okay, so we move on to the third question. So this is how you answer by pressing at the icon at the right lower bottom. Now, this is a very practical question. Being a technologist, on a Sunday morning at 9 a.m., you eluted technetium generator and you've got 100 millicuries of technetium. And you use it for the day's scans, which are already scheduled. Now, suddenly a VIP walks in at 11 a.m. and your doctor asks you to do a myocardial perfusion scan. You're going to do a single day protocol. So he says we need 50 millicuries of, approximately 50 millicuries of technetium. So what will you do next? So when will you elute the generator again? So options are like option A immediately, B is after payment is made, C is after 2 hours, and option D is after 4 hours. So if you already eluted the generator, did the scans, when will you re-elute again? That is what practically what we are asking. Okay, so this is how you have to answer. You get 10 seconds. Okay, I think that's it.
Yeah, we can move on to the next talk.
Okay. I think the title of in this conference are very interesting. All the titles of the talk in this conference are very interesting. So the next talk title is Old Wine in a New Bottle by Dr. Rashmi. I request Dr. Rashmi to proceed.
Good afternoon, everybody. It gives me an immense pleasure to thank the organizing committee of SNM Southern Chapter for giving me an opportunity to speak few applications of phosphorus 32, and a special thanks to Dr. Harishankar. Well, today I'll be discussing few therapeutic applications of phosphorus 32. Phosphorus 32 is a normal phosphate ion which is present in our blood, and the tumor concentrates much more higher than our surrounding healthy tissue. So it's more commonly used because of the pure beta emitter property with a B max of 1.71 million electron volts, which can travel almost 20 feet in air with its maximum energy, and almost 6 millimeter in the tissue, which can be stopped by a 6 mm of lucite material. The major concerns using the phosphorus 32 being a drop of contamination, which contains almost 1 microcurie of phosphorus 32, results in an exposure of 2000 milligrams per hour. And when we open an vial, then the dose rate what we receive will be somewhere around 26,000 milligrams per hour. So to have as low as reasonably achievable limit with the phosphorus when we are using, we have to use in very minute activities, say about 0.25 and 0.5 millicuries. So it's better to use a pre-labeled materials in a lower concentration, which can have safety aspects attached to it, but more than it offsets the additional costs. So what is the shielding material that we are using to shield the beta particles? Is a plexiglass, which is a lucite, which at least 6.7 mm is required to stop almost all the beta rays. But once we are using more than 1 millicurie of phosphorus 32, it can generate a sufficient number of Bremsstrahlung X-rays. So we require an additional filing with the lead to stop those Bremsstrahlung rays. So we can detect a tiny drop of P32 with an end window of Geiger counter. The safety rules to be followed to reduce the personal radiation exposure is similar to any other radioisotope. We have to have an absorbent bench paper on the tabletop what we are making use for the phosphorus, and separately isolated from the main flow of the traffic in the lab. And then all persons who are handling phosphorus 32 supposed to wear a ring badge, and the sensitive area of the badge should be facing towards the radioactive material, and the full length lab coats preferably. And we need to protect our hands and any exposed area for the skin by wearing 2 pairs of the gloves, or rubber gloves for that matter. And then the contamination for the Geiger counter has to be avoided by placing a thin sheet of plastic paper around a Geiger counter. At least 3/8 or half an inch of thick plexi shielding has to be done wherever we are using this phosphorus 32 material when we are keeping an open vial exposed in a lab area, so that we have to additionally block that entire area with a plexiglass shield. And if required, a lead foil also. We do not directly open an container of phosphorus 32. And whatever the pipettes we are making use for phosphorus 32 should not be used by the mouth, and it has to be segregated from the other radioisotope pipettes, because we need get a different pipettes only for the phosphorus 32. And the Geiger counter has to be checked, kept open all the time, and we need to check our gloves or materials or whatever clothing or the shoes or work surface area, anything that have been worked with the phosphorus 32. Then what are the post-use procedures when we are handling phosphorus 32 is, once we check with all these materials exposed, the bench surface, the centrifuges, the water baths, hands, shoes, clothing, etc. If there is any washable area, then we have to wash thoroughly with the soap and water. We need to, but in case if we found that certain areas which cannot be removed by the soap and water, we need to contact the RSA immediately, so that whatever the area which have been exposed to the radiation has to be confined to particular isolated area and blocked with the additional shielding if required. And all the used materials of the radioactive waste have to be designated in a plexiglass paper with the appropriate date, time, and the amount of activity. And after 10 half-lives, around 143 days, we need to dispatch the radioactive waste. So what is the advice to the patients once administered with the phosphorus 32 we give? Generally, these patients are mildly radioactive, and very small dose we inject, and preferably it's having a very short range in the tissues. We need not worry about the external exposure to the surrounding public or attenders. But we need to flush the toilet at least twice and wash our hands thoroughly. And even we have to instruct the same to the patients when it is being injected. If you use incontinence pad or have a catheter pad, and nurses will advise how to manage and dispose of the respective items. So there are various applications of the phosphorus 32, especially being polycythemia vera, which is a rare blood disorder in the bone marrow, which produces excess amount of red blood cells. And if it is producing excess amount of platelets, we call it as an essential thrombocythemia. Bone palliation for the various skeletal metastases, and intracystic therapies for cystic craniopharyngioma in childhood, radiation synovectomy in patients with severe and chronic rheumatoid arthritis which are unresponsive to the conventional medical treatment. Hepatic arterial installation of phosphorus 32 glass microspheres have been used, and which have been proven to be safe and effective for unresectable HCCs, even with the portal vein thrombosis. So these are the various common applications of phosphorus therapies in nuclear medicine. There may be many tried and tested in previous days also. And maybe I'm not so much aware of them. Then coming to the electrons which are emitted by the phosphorus, they have a very intermediate energy level compared to those of iodine 131, but they are and yttrium 90. So this is going to result in a path length of about 5 millimeters in the tissues. It has got a greater anti-tumor efficacy than other beta emitters compared to I-131 and yttrium 90, because it has a unique property, something which is chemically and radiologically resulting in double stranded breakage of the DNA. So whatever the inorganic phosphorus or a simple aqueous ion that has been used for the decades for the therapeutic applications of polycythemia vera or essential thrombocythemia and the bone pain palliation, because it got incorporated into the extracellular matrix. But still, this aqueous phosphorus 32 have never been established as a primary anti-cancer strategy per se. The first clinical application of phosphorus 32 was attempted in 1930, and its usage has generally been restricted to the colloidal suspension form only. So this, how does the aqueous phosphorus 32 results in the DNA damage? I'll just show you in a pictorial representation. So this is a phosphorus 32 ion. Once it gets incorporated into the nascent DNA molecule, it isotopically decays into sulfur 32, thereby resulting in a single-stranded break, whereby an electron is emitted, which travels a path of 2 nanometer, which is a distance between two strands of the DNA molecule, and thereby resulting in damage to the other strand of the DNA molecule as well. So a chemico-radiological damage, which is resulting in a double-stranded breakage of the DNA, causes an irreparable damage, thereby leading to apoptosis and cytotoxicity. So the polycythemia vera is a chronic slow-going nature characterized by an abnormal increase in the number of blood cells, total blood volume, thereby enlarging the spleen, and there is a tendency for bleeding to occur as well. Some indications have linked to the leukemia for this polycythemia vera. Since there was no true cure, they started using phosphorus 32, which seemed to have a very effective in causing disappearance of the symptoms, thereby lengthening the patient's life. What actually phosphorus 32 did was it slowed down the formation of the red blood cells, which is actually treating the basic cause of the disease than other medicines which were actually destroying the excess of red blood cells. So when it was given intravenously, it mixed rapidly with the circulating blood, started slowly accumulated in the tissues, which utilized the phosphates in their metabolism. So the actively dividing hematopoietic cells accumulated more of this radioactive phosphorus and got destroyed. So thereby treating the basic cause. But there were some controversies which existed over a period of time whether phosphorus 32 treatment caused the leukemia or whether it merely prolonged the lives of the patients until leukemia appeared. So this controversy is still existing. So there was a survival curve which we saw almost over 5 years. At the end of 5 years, the patient survived. 90% of the patients survived at the end of 5 years, and 70% patients survived at the end of 10 years. There were certain studies how to calculate the volume and activity required and the absorbed dose calculation based on the SPECT-based measurements using this phosphorus 32 in the malignant brain tumor treatment. So this was the article which was published in May 2007 in the Journal of Nuclear Medicine. I'll be discussing a few things about craniopharyngiomas. Craniopharyngiomas are histologically benign tumors, but they are very locally aggressive. And so their malignant transformation of craniopharyngioma has been reported as a very rare event. They commonly involve the pituitary stalk, and it's an organ which connects the pituitary gland to the hypothalamus, and majority of them have a cystic component in them. And they exhibit no gender or the racial bias. They commonly seem to present in the childhood between the ages of 5 to 14 years and in the late adulthood between the ages of 50 to 74 years. What are the common presenting symptoms in a case of craniopharyngioma are based on their size, location, and area involved. It goes on with the headache, peripheral field vision loss, eye movement weakness or the double vision, personality changes, confusion, vomiting, hormonal insufficiency or hypothalamic dysfunction related symptoms like excessive thirst and urination, stunted growth or delayed puberty in the children may have fatigue, hyperphagia with a weight gain, increased sleepiness, hot or cold intolerance. And the symptoms related to adrenal insufficiency may be fatigue and low blood pressure. So when we diagnose a craniopharyngioma in a childhood, they may go with a varied effects of contributing from visual, endocrinological, metabolic, and neurocognitive functions. So it's almost more significant compared to the adults, what are the symptoms we are seeing in the children. So there's a basic principle to help or at least to do no harm as an ultimate challenge what we have been offered in treating the pediatric craniopharyngioma. So there were this certain prospects with the minimal invasive intervention, wherein there is an endoscopic insertion of a catheter with a subcutaneous Ommaya reservoir and subsequent installation of certain substances into this cystic or lesion in the cavity, whereby we are resulting in the shrinkage of the cyst So there were certain publications which happened with the intracystic therapies for cystic craniopharyngioma in a childhood. Varied materials have been used to instill into this cyst, like radioisotopes, bleomycin, and interferon. But among these studies, interferon fared well compared to radioisotopes and bleomycin. What I have been discussing with this intracystic treatment modalities in craniopharyngioma, reason being there was this enthusiastic neurosurgeon in our hospital who wanted to treat me with the phosphorus 32 for the intracystic recurrent craniopharyngioma in a female patient. I had to literally go and dig a lot of literature to get a concrete evidence to say whether the phosphorus 32 could help out in this particular case where my neurosurgeon was insisting me to treat. So there was various studies and literature which compared with the bleomycin, interferons, and radionuclide therapies. Amongst the radionuclide therapies, there was this aurum, rhenium, yttrium, and phosphorus being used. Among that, rhenium didn't fare well. Yttrium and phosphorus did a better results. But since yttrium was not available, Brit people were generous enough for me to supply phosphorus 32 on my particular date of treatment. So this phosphorus 32 helped almost overall control in the cystic lesion with the recurrence and shrinkage with 67%, and especially between the ages of 3 and 54 years of age. So I was confident enough to go and treat this child. So we require to adjust to the cyst volume, whatever amount of dose is required, but we should never go beyond 400 grays because it may result a risk to the optic apparatus. So once we calculate the cyst volume on our MRI, we proceeded with this treatment. But generally we have seen in studies that cyst volumes which exceeded 100 ml will not respond to this treatment very well. And there was studies which prove that the phosphorus 32 has an elegant minimal invasive intervention, which a therapeutic effect appeared with only one installation. And we did not have a permanent catheter installation also with the reservoir, wherein repeated we need to keep on instilling like in interferons or the bleomycin. And one drawback is access to the radioisotope, which is available only in limited number of institutions, which require sophisticated equipment and a multidisciplinary team of experts. And there is advocacy using this treatment approach only for the tumors that recur after both surgery and external beam radiation. How do we know the response to the treatment? What generally happened was the motor-like fluid content, which was rich in high LDH levels, converted into colorless fluid. So that is where the LDH levels came down to less than 1,000 units when the liquid became colorless from the cyst when we aspirated that. There was another study which started using interferon also, because almost the craniopharyngioma cell lines and the squamous cell carcinoma cell lines originated from the same cells. That was the reason behind using interferons in the treatment. So they proved that a non-neurotoxic substance like interferons, when instilled into this intracystic lesion, was supposed to be a safer treatment option than radioisotopes or bleomycin, and it almost achieved impressive complete and partial response of 78%. So this was my case, who came with a history of headache and vomiting since birth, and it got aggravated since 2010. And CT brain plane, which was done in 2012, showed a large, well-defined extradural supracellular cystic lesion, more likely suggestive of craniopharyngioma. This patient underwent transcranial transsylvian aspiration of the craniopharyngioma with the Omoya reservoir placement on 1st of October 2012. Intracystic installation with the alpha interferon 2A injection was done in March 2013. And she was put on treatment with the tablet Thyronol. It's wrong. It's 50 micrograms OD and minirin spray with 1 puff per day to the alternate nostrils. So she came with again history of recurrent headaches and diabetes insipidus with a worsening visual disturbances since 2014. So she was almost diagnosed with the case of recurrent cystic craniopharyngioma, for which the investigations done in 2018 showed LDH levels more than 1,000. An MRI brain screening was done, which showed a widening of the sella turcica with the altered T2 and flared hyperintence. The measurements were this. And they suspected some residual or recurrence, and a drainage tube was also noted in the stiff posterior limb of the internal capsule. She got admitted in the Department of Nuclear Medicine in 2018 and underwent intracystic installation of samarium phosphate 32 colloidal suspension with almost 1.2 millicurie. And focal area of intense tracer uptake was noted in the cellar or the supracellar region, and SPECT CT images localized the lesion of this therapeutic intervention. There was no extravasation of the tracer into adjacent surrounding areas when we imaged the patient. We advised all the medication and referred the patient for the endocrinologist for since she was due to attain puberty. Follow-up was advised, and then in 2021, when we measured the LDH levels, it was 162 units per liter, and she was almost symptom-free, completely normal. And this was the SPECT images which got localized in the cellular or supracellular region. Sorry, I don't have the CT images to share currently. So what is the drawback of this treatment? No doubt this patient fared well. I was lucky enough, but there are certain intracystic treatment options with the cystic craniopharyngioma, which are suggestive of durable cyst shrinkage and benefit beyond a pure volume reduction due to repeated fluid aspirations. Generally, only one injection is involved, sufficient to treat this recurrent cystic craniopharyngioma, because I have only treated once to this patient. And a similar case was also there, a female patient, and our neurosurgeon approached me in 2019 for the same case. We need to treat for the same, and we are following up this case, and the patient is doing really fine, only with one installation of phosphorus 32. So what are the limitations to this procedure? Because there may be multiple cysts, and we may land up injecting only into one cyst. And the solid component of the disease may not be effective to the treatment with phosphorus 32. So all these options we need to keep in mind prior to therapy. There are multiple challenges relating to technical practicalities, like multicystic occurrence may limit treatment to one cyst only, like I said. Therefore, this approach may not be clinically beneficial to the patient. The thickness of the cyst wall also matters here, because they may not allow the successful penetration of the scope or the catheter into the cyst, and a different catheter designs may be required for the intracystic positioning of the catheter, and its holes are different. But anyways, we have done good justice for our patient by treating this intracystic installations with the phosphorus 32, especially in cases of recurrent cystic craniopharyngioma cases. Thanks a lot, everybody. I thank organizing committee once again for giving me this opportunity to speak on a few words on behalf of this phosphorus 32 therapies. Any questions or queries? I am open for the.
Do we have any questions, ma'am, from the chairpersons?
No, there is no questions in the chat box, I think. It is a very nice, informative talk from Dr. Rashmi, and she has presented very nice case, recurrent case, that craniopharyngioma, which they have treated with D32. That is a very nice case that she has shown to us. Thank you, Dr. Rashmi.
Yeah, thank you, sir. Thank you.
We must congratulate Dr. Rashmi for using such an inexpensive radioisotope for treating such a condition. Congratulations, Dr. Rashmi.
Yeah, thank you, sir.
Before we move on to the next talk, can I just show one quiz question?
Yeah, sure.
Okay, the winner of the last quiz question was Mr. Amir Sohail from, I think, Hyderabad. So you have this quiz option in the right lower corner of the conference portal. Please remember the option. This is very interesting question. If you follow the news, You will probably find it out. This is a patient who has got intoxicated by one chemical whose radioisotope we use routinely. Okay, you can see this hair, the head, and these words: X-rays, 67 to 82 kilo electron volts X-rays, 1 injection cardiac imaging. So a combination of all three information will lead you to the answer. So what radioisotope is it? Is it technetium-99m? Option B, it is thallium-201. Option C, it is gallium-68. And option 4, it is iodine-131. You see the head and the hair, 67 to 82 kilo electron volts X-rays, 1 injection cardiac imaging. Over to you, sir.
I think next we'll go to the next talk from Dr. Shanmugasundaram. I think Dr. Shanmugasundaram introduction is not required. He is a very well-known figure in our nuclear medicine. He is the senior person in our nuclear medicine field. So I request Dr. Shanmugasundaram sir to please proceed and present his presentation.
Everyone, at the outset, I like to thank Dr. Harishankar for giving me an opportunity to be part of this scientific session. It is indeed my pleasure to be discussing this exciting topic, radionuclide therapy in pediatric tumors, targeting thyroid cancer and beyond. When compared to adult differentiated thyroid cancer, pediatric DTC are relatively rarer, but eminently treatable with excellent prognosis. Surgery and radioactive iodine remain to be the mainstay of therapy. The role of radioiodine therapy is always a point of discussion due to paucity of prospective trials. Another pediatric tumor of nuclear medicine interest is neuroblastoma. The prognosis and therapeutic strategy of neuroblastoma is based on 1, age, stage at presentation, 2, the expression of MYCN oncogene. Conventionally, I-131 MIBG therapy is indicated in chemo-resistant metastatic tumors, and rarely it is also used in recurrent neuroblastoma management. In the next 15 minutes or so, we shall be discussing some of the unique features of pediatric thyroid cancer, the present role of radioiodine therapy in the management of pediatric DTC. With reference to neuroblastoma, we shall be discussing the present role of MIBG therapy and some of the future strategies which will augment the scope of I-131 MIBG therapy in the multimodality management of metastatic neuroblastomas. The presentation of pediatric DTC is unique and different from adults. Here we mean pediatric DTC by including children up to the age of 18. So children and adolescent patients come under pediatric DTC. They most of the time present with more extensive disease. As high as 40 to 90% of patients can present with lymph nodal metastasis at the time of diagnosis. Up to 20 to 30% of these patients show unsuspected distant metastasis, most commonly the lungs in the form of diffuse I-131 uptake in post-therapy I-131 scans. Up to 40% of patients have multifocal thyroid disease in papillary thyroid cancers. With reference to genetics also, there is a significant difference with the pediatric DTC. They don't present with ROS or BRAF mutations. Majority of the time, they show only gene rearrangements. The common rearrangements of the gene are red PTC1 or red PTC3. Specifically, red PTC3 has been shown to be present in radiation-induced papillary thyroid cancers. With reference to radioiodine role in pediatric DTC, there is no consensus as literature evidence are lacking, again due to the absence of randomized controlled trials. There are always controversies and issues related to the exact need of radioiodine therapy in pediatric DTC, the dosage of radioiodine to be used, and possible future complications of radioiodine. But one of the important studies, the Belarus outcome study, comprising of 740 differentiated thyroid cancer patients in pediatric age group, has established one important point, the role of radioiodine. As high as 65% of the patients in this group were treated with radioiodine. And you can see up to 30% of patients were having distant metastasis. Up to 93% of patients showed good response in the form of complete response and good control. Only 7% of patients were non-responders. So what is the present consensus as far as the usage of radioiodine and dosage of radioiodine? We can actually use up to 100 to 200 millicurie of radioiodine in patients, adolescent and children with physical maturity who are presenting with distant metastasis. Even in younger children, we can be more aggressive. We can use 1.35 to 2.7 millicurie per kilogram body weight radioiodine. And Dr. Werberg, who is an authority in pediatric cancers, pediatric DTC management patients from Germany, has established that you can go up to 5.4 millicurie per kilogram body weight or higher without exceeding the bone marrow tolerance limits. In day-to-day practice, when patients present with no distant metastasis and we need to take care of the remnant thyroid tissue, we normally use up to 30 millicurie. It is to be noted, we can do additional sittings of radioiodine therapy if patients present with distant metastasis. Coming to the neuroblastoma, neuroblastoma is the most common extracranial pediatric solid tumors. Most of them present in younger age group. Majority of them are infants less than 1 year. The disease spectrum can vary from spontaneous regression to rapid progression. Unfortunately, more than 50% of neuroblastoma patients have distant metastasis at the time of presentation. If the patient age is less than 1 year, and if they don't express MYC and oncogene amplification, then they have a favorable prognosis. Majority of the time, they are managed with multimodality therapy as they present with distant metastasis. Coming to the role of I-131 MIBG therapy, the uptake pattern 1, where it is energy dependent and ATPase dependent, which happens in cell synthesizing norepinephrine transporter, that helps us to have a good I-131 MIBG uptake in NET cells. And the I-131 MIBG is stored in neurosecretory granules. As of today, majority of the time, I-131 MIBG is indicated as part of multimodality therapy in patients with metastasis of neuroblastoma. It is mainly used in patients who have failed with the first line of chemotherapy, and also to a certain extent used in recurrent neuroblastoma management. A quick recap of how I-131 MIBG therapy is performed. It is to be noted, thyroid blockade is very important. It is to be started 3 days before the therapy and to be continued 7 days later the therapy. It is a prerequisite to have a pre-therapy I-131 MIBG whole body scan, and it is preferable to have dosimetry. MIBG I-131 is always infused as an intravenous infusion over a period of 1 to 1.5 hours. Unlike pheochromocytoma, the adrenergic crisis is very, very rare in neuroblastoma. But the radiation safety during this procedure is to be taken care, and also radiation safety instructions are to be counseled to the caregivers. We need to have a baseline hemogram, RFT, the renal function and liver function tests before the MIBG therapy. And post-MIBG therapy investigations are towards the evaluation of myelosuppression. The routine hemogram should include the platelet counts and also the absolute neutrophil counts estimation. So what is the present literature evidence for I-131 MIBG therapy? The most important point is the dose limiting factor of I-131 MIBG therapy is the myelotoxicity. Dr. Matai from UK was the first one to study the dosimetry studies, and he established the dose range of 3 to 18 millicurie per kilogram body weight. And he performed a phase 2 study with as high as 164 patients. He was able to establish 2 dosage regimens. One is 12 millicurie per kilogram body weight if we are not considering autologous stem cell rescue or bone marrow transplant. And if patient undergoes a bone marrow transplant, or if the patient is planned for the bone marrow transplant, you can take the patient up to 118 millicurie per kilogram body weight. Obviously, with the higher dosage of MIBG, there is a better objective response. He was able to get a reasonably good objective response of 25% for 12 millicurie per kilogram body weight patients, and 37% of patients showed objective response in patients who were treated with 18 millicurie per kilogram body weight. He went on to do other studies. He had another group of patients where he tried 2 sittings of MIBG infusions. All these patients were undergoing a bone marrow transplant after these 2 sittings of MIBG infusion. The dosage range is mind-boggling. You can see he has used 22 to 51 millicurie per kilogram body weight, and he established 36 millicurie per kilogram body weight as a safe dosage of I-131 MIBG in this group of patients undergoing immediate bone marrow transplant. Johnson et al., again another UK physician, has established a more sane dosage. He used 18 millicurie per kilogram body weight. He also gave 2 infusion sittings, but he followed the first infusion with bone marrow transplant. Then bone marrow transplant was followed by the second MIBG infusion. So you can also combine chemotherapy with high-dose MIBG infusions. One of the more famous chemotherapy schedule is cisplatin, 50 milligram per kilogram body weight, infused on 0 and 7th day. MIBG was given 100 to 130 millicurie on 1st and 8th days. Myelosuppression is the most important complications in these infusion patients. German trial was more radical. They used multiple chemotherapeutic agents, carboplatin, etoposide, melphalan, and they followed this I-131 MIBG plus chemotherapy infusions with autologous stem cell rescue. So you can see the more radical MIBG therapy is always followed by a bone marrow transplant. So what are the other strategies by which we can improve the efficacy of I-131 MIBG therapy purely from a nuclear medicine point of view? You can always use no carrier added MIBG or high specific activity MIBG. And instead of using a beta emitter, you can use an alpha emitter, 211 astatine. So MABG is available, meta-acetobenzyl guanidine. So these are the 2 ways by which you can improve the MIBG therapy efficacy. You can also combine I-131 MIBG therapy with other strategies like radiosensitizers can be combined, myeloablative chemotherapy, as we saw in the previous slides, can be combined. Hyperbaric oxygen has been tried with MIBG therapy. Even external beam radiotherapy is following the I-131 MIBG therapy. This strategy also has been tried. Purely from a nuclear medicine point of view, we can always use high specific activity MIBG. The conventional normal MIBG is prepared by the simple iodination, where only simple exchange happens. But if we can prepare the MIBG by electrophilic substitution iodination method, then what you get is no carrier added MIBG with very high specific activity. You can see it is 2000 times better. The concentration of I-131 labeled MIBG inside the cell is 2000 times better. And there is no pharmacological action of MIBG because the number of non-radioactive MIBG molecules is too less. And obviously, we can get a better tumoricidal effect with high specific activity MIBG. The other way is usage of alpha emitters, the 211 astatine MABG, and the alpha range here is very less, only 50 micrometer when compared to 800 micrometers. So obviously, we can get a very good bystander effect of astatine, and astatine impact is independent of cell hypoxia. There is an enhanced cell damage shown by this experiment. You can see that even with a very low activity concentration of 211 astatine MABG, you get a very highly tumoricidal effect. The surviving fraction is too less in patients who were, or in cells who were irradiated with 211 astatine MABG. We can also combine some of the chemotherapeutic drugs. One of the most famous chemotherapeutic drug that is always combined with MIBG therapy is topotecan. This is basically a topoisomerase 1 inhibitor. It has two theoretical advantages. One is it is itself is a radiosensitizer, and it stimulates MIBG uptake in neuroblastoma cells. But myelotoxicity is much more pronounced in this combination. There is a clinical study which I come across, and here they have used 12 millicurie per kilogram body weight MIBG infusion, 2 infusions, first and 15th day. And topotecan will be given at a dosage of 0.7 milligram per meter square for the first 5 days and 15th to 19th day. Many drugs have also been tried to be combined with MIBG therapy. These are all in the experimental stage, but I see a future for checkpoint inhibitors. There can be a possibility to have a good response for a combination strategy of I-131 MIBG therapy with checkpoint inhibitors chemotherapy. So what are the take-home messages as far as the role of I-131 therapy in differentiated thyroid cancer? Surgery is the mainstay of therapy. Total thyroidectomy and central compartmental node dissection to be performed by a high-volume thyroid surgeon, followed by radioiodine ablation or adjuvant therapy or metastasis therapy. If the patient has only residual thyroid tissue, we normally use 30 millicurie, but it can be increased to 100 to 200 millicurie if the patient has distant metastasis. The normal dosage can be more aggressive, 1.3 to 2.7 millicurie per kilogram body weight, even in children less than 13 years. And the pre-treatment dosimetry, if we can perform, probably that is the ideal way. And even up to 5 millicurie per kilogram body weight I-131 can be administered in these patients depending on the dosimetry results. The take-home message of I-131 MIBG therapy in neuroblastoma, we need to be very aggressive if we are planning to use I-131 MIBG as a therapeutic modality in metastasis neuroblastoma therapy management. The infusion dosage can be as high as 12 to 18 millicurie per kilogram body weight. If the patients are scheduled for bone marrow transplant, we can even scale up these dosages up to 51. If not 51, definitely up to 36 millicurie per kilogram body weight. And two attractive new strategies. One is addition of topotecan to the MIBG therapy, and possible use of alpha particle like 211 astatine MABG may be tried. But as of now, this is available with us, the non-carrier added or high specific activity I-131 MIBG. So this should be the backbone of our I-131 MIBG therapy. Thank you very much for your patient hearing. So it is difficult to reach this place, but if we reach this place, we are going to have a very good impact. So that can be applied for I-131 MIBG therapy also. Thank you very much.
Very excellent talk, sir. It was very excellent and very informative talk. Sir, only one question I want to ask.
Please.
Suppose in pediatric thyroid cancer patients with lung metastasis, usually they will respond with a single dose, or they may need multiple doses, sir. What percentage of patients may need multiple doses?
We have a reasonably good experience with pediatric and adolescent differentiated thyroid cancer patients. We have treated more than 250 patients till now. And as far as the pulmonary metastasis management, we may not get always a good response or complete response with one sitting. Although our percentage may be around 35 to 40% of patients may get a complete resolution of the lung lesions or lung metastasis. Most of the time, it is a diffuse uptake, not shown either on the chest X-ray or in the chest CT, but shown only in the post-therapy scan, with a significant fall in the thyroglobulin and absent lung uptake in the follow-up diagnostic scan. But majority of the time, you may need 2 or 3 sittings. I think we should not hesitate in going ahead with the second, third sittings as long as patient is in need. And the take-home message of this discussion purely is we need to be very aggressive. We should not be conservative saying that patient is in the age of pediatric or adolescent. It applies both for differentiated thyroid cancer and MIBG therapy. Probably I may have insisted, I may have told more aggressive treatment is necessary for MIBG therapy management, but it definitely applies for differentiated thyroid cancer also.
Thank you, sir. Thank you.
Annapurna, you want to ask something?
Yes, I have a question, sir. So being in the pediatric oncology, we have treated, I think, only one patient with MIBG therapy for a resistant refractory neuroblastoma. But he didn't respond to that. So that's on one side, how practical it is to procure MIBG and use for a patient, both diagnostic and therapeutically, because if we need MIBG for a diagnostic purpose, we don't have the dye or something immediately for immediate use. So how it is overcome in other centers, and how common we are using MIBG for both diagnostic and therapeutic purposes?
Okay, 3 questions. First one, more practical. Diagnostic MIBG therapy is very much possible in all the centers in India. We really don't need any high sophisticated, no carrier added MIBG for that purpose. And it is normally available weekly once. So every Monday from Brit is available. So it applies to all the centers. That is one. Second, therapy. Yes, the therapy dosage of MIBG is available once in 2 weeks. Again, locally produced, but it may not be no carrier added. That is what I was emphasizing in my talk, but that is mainly because the therapeutic efficacy is much better. So we need to look for imported MIBG. It is available. No carrier added MIBG is available from the imported sources. It will cost around 2 lakhs per sitting. That is the second question. Third is regarding the feasibility or how common we are doing it. You are absolutely right. We even though I have treated 250 patients of differentiated thyroid cancer, the same number cannot be told for the neuroblastoma. The number of patients we get, and the patients need to be very aggressively treated even though they are less than 1 year. So there, the most of the time, whatever I discussed regarding therapeutic strategies, you must have seen all are based with the fact that almost all go for the bone marrow transplant. So all these things, we do it just before the bone marrow transplant. So we don't need to bother about the myelotoxicity or bone marrow suppression in these patients, but it is feasible. So as I showed, 2 important trials, both in UK and Germany, more than 100 patients, more than 250 patients have been treated. So it is possible, but I think that radical approach is possible only with the active management, or active cooperation of medical oncologists, pediatric medical oncologists like you. So, but it is feasible. I think we need to have a program going on, and it is possible. Probably each state should have a specialized center for themselves, so that all the patients are pulled in and being treated. It is not impossible, but you are absolutely right. It is not very common.
Thank you, sir.
Sir, can I ask one question?
Please, go.
Sir, how do you compare iodine MIBG versus Dotanox in neuroblastoma, both for diagnosis and for therapy?
My approach is very simple and very straightforward. I don't believe too much in lutetium dotatate or the gallium Dotanox scan. I always, whenever I get a suspected patient or an established patient of neuroblastoma, first I try doing an MIBG scan, because obviously that is much more established treatment, and theranostic agent, I strongly believe for neuroblastoma is I131 MIBG rather than gallium Dotanox. But yes, encouraging results are also coming out, mainly because of the easy availability of lutetium dotatate therapy, and possibly that can be replaced with the alpha emitters. But right now, I sincerely believe I131 MIBG should be the theranostic agent for neuroblastoma.
Sir, for diagnosis, sir?
For diagnosis, yes. Majority of the time in my institute, we don't do MIBG therapy for a neuroblastoma diagnosis. Majority of the time, they come after the biopsy. So I do MIBG scan mainly to look for the distant metastasis. But you are right, there will be a good diagnostic accuracy for the gallium Dotanox scan also. But as I highlight, I always try to do an MIBG scan first, because as you know, there is no single radiopharmaceutical which is the modality of choice for the diagnosis. Majority of the time, even a simple bone scan will be much better for a bone metastasis. FDG has been also shown. Even DOPA scan has been shown. So we cannot really compare these things, but as a straightforward single modality, I will select MIBG scan. I131 MIBG scan only I do, but I agree completely that gallium Dotanox also will have a good diagnostic accuracy for the initial diagnosis.
Sir, and the second question, sir, when you see this radioiodine refractory or resistant pediatric thyroid C, at what point do you consider them for targeted therapies?
Right now, majority of the time, my experience with the adolescent and the pediatric differentiated thyroid cancer is very good with radioiodine. I don't remember having referred many patients or some patients for a targeted therapy, because they do extremely well with radioiodine. And one point, I am bold in that sense that I go to any number of sittings. I have treated even children of 15 years, 16 years with up to more than 600 millicurie even today. Because especially if they had already achieved physical maturity, then I don't fear. I try to treat them aggressively with radioiodine. So the question is definitely there. I feel adult and pediatric thyroid differentiated cancer, once they become radio resistant, that is radioiodine refractory, I don't think we have a choice. So we have to go for a targeted therapy. But right now, I don't remember having sent patients for targeted therapy as of now.
Do we have any other questions? If we don't have any questions, can we move to the next presentation? Just before the presentation, we'll show the last technologist question.
Thank you very much.
Thank you, sir.
Sir, Harish, Arun sir has lost his internet.
Okay, no problem. I'll go on. Okay, the final question of today is the question number 5. So very interesting question. Which radioactive material can be sent by post? Option A, technetium 99M. Option B, iodine 124. Iodine 125. Option C, it is iodine 131. And option D is indium 111. I regret the typing mistake. Please select the option. Okay, we'll go ahead. This will be the final talk of the conference.
Yeah, next speaker is Dr. Harish Goyal from JIPMER on lutetium EDTMP. Kindly play his talk.
Lutetium 177 EDTMP bone pain palliation JIPMER experience. Skeletal is the third most commonest site for metastasis. 80% of the skeletal metastasis come from breast, CA lung, and prostate malignancy. The incidences of bone metastasis is increasing due to the better survival. The etiology of metastatic pain, mechanical factors including like direct bone invasion, microfractures, increased intramedullary pressure, periosteal stretching, and humoral factors like certain cytokines and certain factor releasing from the tumor. Why to treat metastasis is a painful potential site for pathological fracture, cord compression, hypercalcemia, reduced quality of life or survival, act as a reservoir for malignant cells. And more than the half patient pain is refractory to the conventional analgesics. Strategy for the treatment of metastatic skeletal lesions, cytoreduction approaches like surgery, external beam radiation, chemotherapy, palliative approaches aim to prevent the consequences of skeletal metastasis. Improvement in the symptoms like nausea, vomiting, loss of appetite, insomnia, and depression. Radiopharmaceutical commonly used for bone pain palliation, beta emitters, this listed in this table. These are compounds and isotopes, and respective physical properties is mentioned in this table. This is lutetium 177 EDTMP mentioned here. Optimal characteristics for bone pain palliation radiopharmaceutical, it should be a particulate emission of an appropriate energy and range, physical half-life that approaches the biological half-life of a radiopharmaceutical in the tumor, selective concentration in the bone lesions, rapid blood clearance, low extraosseous uptake, and available in the suitable form for complexing. And our experience with lutetium 177 EDTMP, we assess the efficacy and toxicity profile of low-dose lutetium 177 EDTMP for bone pain palliation in the patient with skeletal metastasis. We assess the efficacy using VAS score, mobility score, Karnofsky performance score, and we evaluated the hematological toxicity profile using complete blood counts. Inclusion criteria: 2 or more painful skeletal metastatic site corresponding uptake on the bone scan within 8 weeks, increasing level of the narcotic analgesics, and ongoing pain non-responsive to the local radiotherapy or high dose analgesic irrespective of the number of the lesions. And it should be adequate hematological parameters as mentioned here. And patient with prior history of exposure of total body irradiation or systemic chemotherapy and persisting bone pain with adequate hematological parameters also included for bone pain palliation. Contraindications: pregnancy, breastfeed, and inadequate hematological parameters, disseminated intravascular coagulation, acute spinal cord compression, impaired renal parameters are contraindicated for the bone pain palliation. Exclusion for bone pain palliation: The patient whose pain is arising from soft tissue or visceral metastasis, patient with less than 3-month projected survival. Then coming to the other consideration for bone pain palliation planning, the delay of the radionuclide therapy for 6 to 8 weeks after the completion of chemotherapy, delay for 2 to 3 months after the large field radiation therapy that allows for the bone marrow to recover, and further chemotherapy should be delayed 2 to 3 months after bone pain palliation therapy. Modern bisphosphonate do not interfere the skeletal uptake of radiopharmaceutical, hence can be used along with the radionuclide therapy. The presence of superscan appearance suggesting that limited bone marrow reserve and constitute a relative contraindication. And this is our patient characteristics. We included 25 patients. Out of this, 11 patients were with metastatic breast cancer, 10 metastatic prostate cancer, 2 patients with the primary lung, and 2 patients with nasopharyngeal carcinoma. Already patient received surgery for 8 patients, chemotherapy for 19 patients, radiotherapy for 17 patients, and bisphosphonate therapy was received in 7 patients before bone pain palliation. Procedure, we use the lutetium-177 EDT-MP half dose, that is 18 megabecquerel per kg or 0.5 millicurie per kg body weight. So this half dose concept that already exists in literature, one study is conducted from Ames Delhi group. They conducted 2 group, one with a low dose or one with high dose. So they found no significant difference. So in this study we conducted lutetium-177 EDT-MP for bone pain palliation with half dose to limit the adverse events and to assess the efficacy of bone pain palliation. Whole body scanning was done after 2 hours of administration of radiopharmaceuticals to see the distribution, and radiation protection measure was explained to the patient. All patients were followed up with clinical and hematological parameters on 2nd, 4th, 6th, 8th, 10th, and 12th week post-therapy follow-up visits. This is the panel A image showing the bone scan in the patient with the multiple sites of osteoblastic metastatic sites, and this is the post-therapy lutetium-177 scan. It's showing a significant tracer concentration into the corresponding osteoblastic sites, and this another patient with the CA prostate with the multiple skeletal metastasis is seen on the bone scan. On the post-therapy lutetium-177 scan is also a significant concentration of radiopharmaceutical is seen on the corresponding bone scan sites. This is a visual analog score that is graded from mild to severe category as per the change in the VAS score on the follow-up visit. That the response category is divided into 3 major categories, like complete response, partial response, and no response category. And the another clinical parameter, that is mobility score, is also assessed on the follow-up visits. The Karnofsky performance score is also evaluated on the follow-up visit to see the clinical performance status of the patient after bone pain palliation therapy. And this is another hematological toxicity parameter grading system that we use from radiation therapy oncological group. So it includes WBC count, platelet count, neutrophil count, and hemoglobin levels. It's graded, the toxicity grades from 0 to 4. And coming to the results, we have seen that 88 patients were responder to the therapy. Out of this, 64 patients were partial responder, 24% patients were complete responders, and 12 patients were no responders. And coming to the VAS score pre and post therapy status, so this is the before starting the therapy, VAS score was significantly high, and means after the administration of therapy, the follow-up visits, we can see initially there is no significant change, But after 4 weeks, 6 weeks, 8 weeks, we can see the gradually decreasing the VAS score level. And there is significant difference we can see from pre-therapy to 10 to 12 week post-therapy assessment. The VAS score is significantly lower. So clinical performance is improved, and the patient pain is also significantly decreased. And coming to the pain responses in the various cancer groups, like in the CA breast patient, 9 patients were partial responders. In CA prostate, 5 patients were complete responders, and 3 patients were partial responder, and 2 patients were non-responder. And hematological parameters coming to this picture, this is for WBC counts, this is for platelet count and hematological hemoglobin levels. And we see that pre-therapy to the post-therapy follow-up visits, we can see the baseline or pre-therapy status of hematological parameters that transiently decreasing after administration of the therapy, all 3 parameters, and then it come to valley on 4th to 6th week on follow-up visits. Then after it's again gradually start rising. So it almost coming to the near normal state, near pre-therapy status by 12 weeks. So not much hematological toxicity. Coming to the conclusion, our study has been shown good palliative effect of low dose lutetium-177 ADT-MP on bone pain in patient with skeletal metastasis with overall response rate of 88%. Our study showed the significant change in both Karnofsky performance scale and mobility scores, which leads to improvement in the quality of life post lutetium-177 ADT-MP therapy, which was the major goal of palliative care. Lutetium-177 ADT-MP therapy is safe, cost effective, and simple and effective modality, and we use the half dose or low dose, so that the adverse event also less, and this is cost effective also. And being a lutetium-177 compound, we can in-house prepare the lutetium labeled compound for bone pain palliation, as well as we can use the free lutetium for labeling other compound also for therapy purpose. So coming to the other studies in the literature, this is the AIMS group study. They have conducted 2 groups, as I mentioned before. One group, they did bone pain palliation with the low dose lutetium-177 ADT-MP, and group B they did with the high dose lutetium-177 ADT-MP, and they found there is no difference in efficacy or toxicity between the both groups. And coming to the other study conducted by KMCH Coimbatore group, so they used the single bolus with the fixed dose combination of 3.7 gigabecquerel lutetium-177 ADT-MP dose, and they also found that yes, it is also low bone marrow toxicity and provides significant pain relief. One another tracer, lutetium-177 labeled dotazole, that that study is conducted from AIMS Delhi group for bone pain palliation in the patient with the skeletal metastasis. This is also effective for bone pain palliation. And another study from PGI group, they conducted bone pain palliation with using lutetium-177 DOT-MP, and they also found it's effective for pain management and improvement in the quality of life. They use the dose 37 megabecquerel per kg, that is 1 millicurie per kg, lutetium-177 DOT-MP. And finally, coming to the recently published systematic review or meta-analysis on lutetium-177 ADT-MP for metastatic bone pain palliation. And this meta-analysis includes 8 studies. Out of 8 studies, 2 studies were conducted, means they divided 2 groups. One group with the low dose of lutetium-177 ADT-MP and high dose of lutetium-177 ADT-MP. Finally, they came to the conclusion that lutetium-177 ADT-MP is comparable efficacy and safety profile, and quite good bone pain palliation and increase in the quality of life. This is the acknowledgement for my presentation, and on behalf of all these people, I'm thank you so much. your patient caring.
Okay. Thank you, Dr. Harish. It is a very nice study. Any comments? Any comments?
How do you label it?
In-house labeling, actually, it's a.
So, who supplies EDTMP? From Brit?
We get from Brit only. Brit sends the EDTMP. It is simple actually, like MDPV label, it is simple only.
If you don't have any other questions, then we'll close this session. So I'd like to thank Dr. Dhanpati sir, Dr. Annapurni ma'am for chairing the session, and I'd like to thank all the speakers of this session. So we have come to the conclusion of this conference. We'll have the valedictory function now.
Thank you. Thanks for the.
Thank you, Dr. Harish. Thank you. It was very nice.
Sir, shall we start the valedictory function?
Please go ahead, Harish.
Kumarasan sir is there? Kumarasan sir, you are here?
Yes, I am here.
Okay, sir. So good evening, everyone. We have come to the conclusion of this 26th annual conference of Society of Nuclear Medicine Southern Chapter. So I'll just summarize some of the statistics from the conference. So, I'm just muting. Okay, I'll summarize some of the statistics of the conference. So this was this conference has some of the things that has come as first. So this is fortunately or unfortunately the first online conference, and we have had maximum number of registrations. The total number of registrations for this conference as of now is 729. That also includes several attendees from outside the country. And this was the first conference to conceptualize the UVA session. We have given more opportunities for young speakers. And the quiz program, we have given a total of 25 questions, 5 specifically for technologists, because technology students and technologists almost they were like 40% of the total registrations. And we have involved a lot of our relevant clinical specialists also as chairperson and also as speakers. So I like to thank initially Dr. Kumarasan sir, Dr. Shanmugha Sundaram sir, Dr. Kalavat sir, Dr. Kavita ma'am once again for giving me and leading me and giving inputs during the various time when the conference was being organized. We started the preparation of planning for the conference more than 2 months before, and every time I had called sirs, he had given a lot of inputs. And special thanks to Dr. Sunita ma'am and Dr. Arun, who have been working behind the screen as the coordinators of the entire program, entire online session. They both have been working with me along with the video technologies team, and they have been coordinating everything. I thank Dr. Sunita ma'am and Dr. Arun Sasikumar for helping me out over the last 2 days. I'd like to thank the sponsors. For the first time, we have got sponsorship from pharmacological industry. We have got Abbott and GSK coming in as sponsors. In fact, GSK is the top sponsor of this conference. So I'd like to thank GSK, Mr. Manigamta Prabhu, Abbott, Dr. Karthik Babu, and we have Dr. Ajit from Isanti, Dr. Satya, Mr. Satya from Curium, Kapil from Siphon, and we got a lot of support from Mr. Shankar Das from GE, Kalpesh from Siemens, Dr. M.R.A. Pillai sir from Molecular Cyclotron, and special thanks to Mr. Taranjit. Sir, Mr. Taranjit, he helped us out without even we asking. He immediately deposited the money, and we didn't even have to negotiate with him as to how much we want. I think his gesture was just too good. And of course, HCG gave one of the maximum sponsorships for the conference. And I will also like to thank our hospital for giving me the seed money. They gave me a very big amount for as a seed money, because when I told them I'm going to organize a physical conference, they knew that the budget will be a problem. And when I met with our medical administrator, he asked me like, how much money you have got from our hospital? And then I told him I got X money. And what is your budget? My budget was 3X. So he said, you don't worry about the budget. At any point, if you want money, you just come to me. Don't plan your conference based on your seed money. You do the planning and then we will give you the money. So that is what he told me. He said, when people come to Madurai, they should remember this event for the rest of their life. So at end, nothing should be compromised. He said, money is not a problem. Hospital is entirely behind you. So you don't worry about anything. You just plan everything top notch. So it is not like I was one person who was conducting the conference. I have the strength of 3,000 staff of Meenakshi Mission behind me. All 3,000 were behind me at every point of the conference. So I like to thank the Southern chapter for giving me, for having the confidence in me to conduct the conference. So a big thanks to the Southern chapter governing body for giving me this opportunity. And it will not be fair if I don't remember my teachers, Dr. Mittal sir, Dr. Anish sir, and of course Dr. Baljinder sir, and all my colleagues from PGI Chandigarh, because of that only I am what I am today. And I like to thank my department staff, because they have been handling all my mood swings over the last 2 months, because most of the time all the planning was done in my head. So many times they didn't even know what I was thinking, why I was behaving the way I was behaving. So I like to apologize to them and also thank them for putting up with me over the last 2 to 3 months. And of course, I thank Meenakshi Mission Hospital for being with me all the time. I thank all the attendees, all the speakers, and all the chairpersons. I think all the talks were of very high quality. And special thanks to video technologies team, because they have managed this event with absolutely zero glitch. So Mr. Sheikh Basharuddin, Gautam, and all his team, you are here. Yes, Uday, Kiran, Abdul Karim, and Madan. I like to thank all of you. You have you have done an excellent job. So before we announce the winners of the Professor Arkat Gajraj Award, is my screen visible to you?
Yes, sir.
Yes, it is. So we had total of 20 questions, and these are the winners of day one as per the question number. So we have, I think Mohan Roop has got 2 prizes. Madhur had, I think, had got 2 prizes. So I will contact all the winners. We have your mobile number and your email address. I'll make sure the prize, the cash prize, it reaches you. These are the winners from day 2. Of course, we had 2 winners from outside India. KT Veljanova, I think that is how it is pronounced, and Chua Kai Wai are the 2 people. I must figure out how I am going to send the cash prize to them. I'll send you coupons, I think. And last, we had this technologist quiz. Technologists form one of the backbones of our society. So we made sure that they are appreciated and acknowledged. So we had a separate technologist quiz, and we have 5 winners of the quiz. So now I kindly request Kumaresan sir to announce the winners of Professor Arkat Gajraj Award paper. And in addition to the 3 prizes that Dr. Kumaresan sir is announcing, another 10 prizes we are giving from the organizer side. So 3 prizes from Professor from the society in the name of Professor Arkat Gajraj Award. The next top 10 papers, you will also be getting cash prizes. It may be oral presentation or poster presentation. The top 10 will get prizes. Over to you, sir.
Thank you, Hari. So it was a very tough job to really judge these papers. It was really a variety of areas, a different work done in a very high standards, and the presentations all were good, really very good, tough fight they all put up. And it was a really big, it was a very satisfying job. And as he mentioned that there are 3 prizes. So first I will announce the 3rd prize. The 3rd prize goes to Dr. Major Bushra Asima from RRL Hospital, Delhi, for the work on radionuclide hysterosalpingography. The 2nd prize goes to Dr. Komal Bishnoi from AIMS Bhubaneswar for the work on Graves' disease follow-up workup with the technetium uptake. And now the prestigious Professor Arkat Gajraj Award goes to Dr. G. Surya Teja from SWIMS Tirupati for the paper on FDG PET-CT in tuberculosis. So I congratulate all these 3, and I am sure that, I mean, the people who didn't make up to this, they really lost by just 1 point or so. There is a very big tie on these papers. It was a deep job. I congratulate all of you have done a very good job. As everybody mentioned, the quality of work and presentation from the southern states as well has gone up very high, and it is very satisfying for the people like me who started this chapter to see the progress we are and achievement we are making, and we are going to lead the nation and show them the way. Thank you very much. Thank you, Harishankar.
Thank you, sir. Now we'll ask, we'll have some, sir, Dr. Riju, sir, would you like to take over, sir? Sir, please unmute yourself.
Yeah. So good evening, all. So it is almost like a festival for last 2 days. So we had a wonderful time, even though there is no physical get together. So we see each other, we enjoyed each other with the science in between, and they have a wonderful quiz program. It is almost like a coffee break, and with a strong sense of science into it. So then that was a wonderful 2 days, and thanks for Dr. Harishankar, who has made a prolific effort to make this 2 days memorable for all the people who are behind the conference as well as who are attending the conference. So then it is my duty and responsibility to congratulate then all the executive members of the Southern Chapter Society of Nuclear Medicine India who have done a commendable teamwork. So I am so happy to say it was a wonderful team effort by the executive committee. All the members were together. They are all contributed one way or other for the success of the conference. That was the landmark of this conference. It was a wonderful support. And before, just 2 months before, when I was talking about the feasibility for conducting this conference, so it was at that time it was unthinkable to have a conference something like this of this scale in 2 months' time. So then Harishankar has done a commendable, very commendable job. So it is, I used to call him Hari. So then all this conversation, I used to call him Hari. Now on today onwards, I would like to call it as a hero. So make a slight change in his name. I will call it as a hero. So you are a new trendsetter. You made this game change. You made the levels completely change. It is a new standard for the Southern Chapter meetings. And the next chapter next meeting will definitely go further from here. And you are done the new milestone for this conference. So then congratulations. And I would like to, then this meeting, so then generally, so the main purpose of meeting, because I used to work alone in my department, until in very recent years, then I was a single person. But attending the conference, the main purpose was to meet, then the colleagues, all the mentors, teachers, and your new friends meeting and greeting each other. That was one of the the pleasure to go for attending a conference. But at this conference, then we thought that we will have a get together, but then at the same time, it was almost like seeing each other or interacting each other kind of experience. I could able to meet Kumaresan sir after a long time, and Dr. Lakshmipathy and his witty dialogues I can't forget, because whenever he talks, he gives me a pleasant way of even if I call him for a kind of a grievance, so he will give back me very positive feedback, and then I will feel happy at the end of the conversation. I could talk to or meet Dr. Lakshmipathy, and then Dr. Shankar Sundaram, so there's who has been inspiring for this generations for a long time. So Dr. Shankar Sundaram and Dr. Padma Sundaram, so I could meet them, and Dr. Sakir, my old friend, Dr. Kavita Reddy, my old colleague. So that I could see, so this Dr. Sadish, Dr. Indrani, Dr. Sumati, and Dr. Kalavat, of course, so many people I could able to meet this time. So that would be the experience or expression for every people, the delegates who are attending the conference. So thank you for this wonderful opportunity, and especially I would like to convey on behalf of the society, I would like to convey thanks to your hospital management, especially Dr. Gurushankar and Dr. Kannan, who has given a tremendous support for you. So then please convey our regards to the executive committee's regards to your hospital management. Please put it on record. And so the youngsters who have made an impact on this conference, especially the UA session, was fantastic. That is going to be a kind of a continuous session, or this going to be a new standard for every future conference in nuclear medicine conferences in India. Absolutely no doubt. And Dr. Arun Shomar and Dr. Sunita has made a wonderful team effort to put the quiz program interesting and make the sessions very lively. And it is almost like a coffee break. And Dr. Arun, he has become like a quiz master for nuclear medicine in India. So he has done a wonderful job. Thank you, Arun. And then also the main interest about this whole session is that you put the scientific sessions in such a way that you have never ignored the basics, the fundamentals, and we reached up to this, then the molecular image in the latest trend. So that was a fantastic display of the scientific program. Thank you to the scientific committee who made this program very interesting and thoughtful, arranged display of all the scientific content. And then I would like to express my thanks to Professor, Dr. Ratna Devi, Dr. N. Ramdas, given video message during this prestigious Professor N. Ramdas oration, and convey our regards to then our special thanks to Dr. Ramesh Arthanari for accepting our invitation to deliver the oration speech. And Professor Arcot Gedraj, the best paper session is always the best during the Southern Chapter meetings. And this time, so that we could able to see that Arcot Gedraj's daughter, Dr. Jayashree, was coming directly and conveying the regards and greetings to the younger generation. So that's so every good thing will have an end. And then I am so happy to be then part of this young team and enthusiastic team, and convey my full regards for this all this delegates, all the registrants, all the chairpersons, faculty, and the students and young scientists and senior mentors for associating with this meeting. And this has to be continued, or even has to make it better in the coming conferences. So then this is something which I wanted to tell you all. And then one more small thing which I wanted to mention about this directory thing, which I sent a message in earlier sessions and through the WhatsApp. So we just wanted to convey about this directory status. So we received around 139 updated, completed. So because then there are a lot of things without photo, without details. So the updated one, it is around 131. Out of that, so we divided into 28 numbers group, and we have taken the first of every 28, and it is not done by me, it is done by the website agency. So then they listed 5 people. So they are the 5 winners as a lot for the the directory registration. So just give me then at least this 5 winners for this directory. For the very first one, the very first registrant. So that is the first group, so the first one, and is none other than our treasurer of our Society of Nuclear Medicine Southern Chapter. It is Dr. Kamlesh. He is the first to register. So he is the first winner. And so this money you have to share with all of us, and this is not going to give you directly. So you have to share with all of us. So Dr. Kamlesh is the first registrant for the directory. So then the head of the department, Kowe Medical Center, Nuclear Medicine, Kowe Medical Center, Coimbatore. Next, second winner is Dr. Rahul, Assistant Professor, Malva Cancer Center, Talasheri, and he is the second lot and the first one. And the third lot, first one is Pratyasha Bikina. If I'm not, I think so. Pratyasha Bikina, consultant.
Pratyusha.
Sorry, I'm apologies. Pratyusha Bikina. Okay, the consultant in Basavatarakam Indo-American Hospital, Banjara Hills. So then that's the third one.
Hyderabad.
So just to scribble down. So then that's the reason.
It's Hyderabad.
Yes, sir. Yes, sir. Then Miss Supriya, she RSO was Panak, Vijayawada.
Oh,
so that is the fourth one. Fifth one is Dr. Suma TM, Swims Hospital, Tirupati. So these are the 5.
All are from Andhra and Telangana.
This happened like that.
Kamaleshwaran is there.
So these are the 5 winners and the lot for the directory. So this directory, so we will make it complete in within another 2 months. We will make it complete. So that is the promise which we have done. So then that is going to be a major directory, the full-fledged directory of all the professionals in nuclear medicine originated in South Indian and working in overseas or other states, or people working, people are currently studying or working employed in southern states. So this is what I want to tell. So then I congratulate all the team members and especially the secretary of the Southern Chapter, Dr. Harishankar, who is also the organizing secretary of this meeting. And I am welcoming all this new team office bearers, so which we will send a mail very soon about the new office bearers. And thank you, sir. Then thank you, congratulations, sir, and thank you all for this for associating with us. Till then, I still remember this the day when I took over the office, and I was I don't know how much I couldn't control my emotion, because that was I am here. I am talking to all of you just because you started Southern Chapter in Tirupati. I attended the first meeting. I was not even a nuclear medicine student. I was just a non-PG registrar in CMC, and I just happened to be there, and I decided to continue. I raised I raised CMC not for nuclear medicine. I happened to be attended that conference. I decided to took over that the specialty. And today I am here after 26 years. Then I am here as the president of that society. I am so much grateful to you, so then for all these founder members. And then I could able to. I'm sitting in front. It is unthinkable at that point of time. I was sitting on the last row, last bench, last person, almost near the door. I still remember. And today I could able to address all the Southern Chapter. I'm so grateful to you, all of you. And thank you for all be here at this late evening, and wish you all a very pleasant evening, very happy week ahead, and stay healthy, stay happy. Thank you all. Thank you.
At this moment, I think all of us should congratulate Dr. Riju sir. He has been an excellent ambassador for nuclear medicine. Thank you very much, sir, for putting up with all of us in the governing body. I like to appreciate your patience, your vision, and if there are no other thing to be discussed.
And as immediate past president, he will continue to be as ex officio member in the executive committee.
Yeah, yes, sir.
Yes, sir. Is there anything else, sir, or can we conclude with national anthem?
Yes, sure.
Okay, see you all at Bangalore.
So
Congratulations, Hari and the team, for excellent conference.
Thank you, ma'am.
Hari, congratulations. It's fantastic. And Riju did a good job.
Thank you, sir.
And as long as commemoration is there, nothing can go wrong in the South Indian chapter, I'll assure you.
Yes, sir. Yes, sir. Correct.
True.
He is the one who has given me two major work. One, first Southern Chapter Conference at Tirupati, and second is first Nuclear Medicine Fusion Conference at Madras. So I remember how he gives the work and how we have to respond for it. So please go ahead with him, and everything will be nice. And fantastic conference. I enjoyed. Wish you all best of the luck. Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Uday, national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you all. Bye.
Bye bye. Bye bye. Bye bye.
Bye.